are with patients with these kind of pathologies, more than 50% I would say, whom we just send for physiotherapy and pregabalin, gabapentin, all these things. So with this background, we thought that why don't we start doing the procedures which a lot of people in the private like Dr. Ashish Tandon, Dr. Dureja and everybody has been doing, and help our patients instead of just making them move around. So with this philosophy in mind, this workshop finally culminated in today in having this program. I hope it enlightens us all, and it's a purely academic feast for 2 days, and I hope we can soak in as much as possible. Thank you so much.
So thank you very much, sir, and I'm hopeful that definitely we'll be reaching one step higher and we'll be knowledgeable by the end of this workshop. I request now our president of the meeting, Dr. S.S. Kale, sir, to please come and give a word of wisdom.
Professor Mahapatra, Dr. Deepak Agarwal, Dr. Rajiv Sharma, Dr. Datta Raj, all my faculty colleagues here, and our invited guests, our faculty who are going to demonstrate pain procedures, all the doctors who have come from all over the country. What can I say, I'm surprised, pleasantly surprised to see the level of enthusiasm of this meeting. Frankly speaking, I had not thought that we'll be able to fill this boardroom, but it's overflowing. So it is a felt need, as they say, it is a need, and I suppose it is a need of the hour. We get caught in these big cases who get referred to these big hospitals, that we forget the daily patients who come, routine patients who come with pain, who don't have any neurological deficit or who don't have a lesion which merits surgery, but they still have pain, and you have to address it. In these big hospitals, we just say, okay, you don't need surgery, go to some other department. But I guess it is a need of a whole lot of patients which is not addressed by us neurosurgeons, and this workshop will probably fill a definite gap which exists in the armamentarium of neurosurgeons to address the problems faced by our patients. So I welcome you all once again, very good, and keep it up. Thank you very much.
Thank you very much, sir. Definitely, like you have rightly said, that there is a gap and a lot of patients coming to our OPD after surgery and need very much, and definitely they will be learning this workshop, sir. Now I request Dr. A.K. Mahapatra, sir, who is guiding this department over the last 35 years, to share word of wisdom with all of us. So.
Good morning. I get greeting from Odisha, Lord Jagannath. I don't know, many of you know, if you read Skanda Purana, Dham is written in Veda. That means Master of the universe stayed at Purushottam Dham, that is Jagannath Puri. It says that Ram, Krishna, they all visited Purushottam Dham. In Vishnu Sahasranam, Jagannath comes in 100,000 times, it comes in 4 places. So we are in the place of Lord Jagannath, and we all need the blessing of the Master of the universe. I think we are in a specialty where you have to do multiple parts of our job. We are doctors, we are human beings, we are healers, and pain management is part of our healing process. If you look at the medical history, before 1835, there is no medical college. It is for the British, they were going for all treatment to England. Those who are ruling in Calcutta from East India Company, for everything they were going to Calcutta. They thought how difficult it is to go by ship to go treatment from India to Calcutta. So they started medical college, medical school, hospital at Calcutta, and that's how the Calcutta Medical College started 1835 June. But after 3 months they thought, why should people from Chennai and Hyderabad and South come to Calcutta for treatment? We should have Chennai Medical College. So it started after 3 months in Chennai Medical College. Then thought, why should everybody come from Bombay there? Then Grand Medical College. That is how the medical college started, and we am today 700 plus 10 medical colleges. So it's a very, very quick development of healthcare in India. And if you look at independence, there is nothing, practical nothing. In 1900 there are 7 medical colleges. In about 1947, about 25, less than 25 medical colleges, but it was thanks to Boer committee, Dr. Boer, Joseph Boer, who gave a report to British government that to develop the healthcare in India, they create the British government Royal Health Society, gave a committee, that Boer committee should be there to improve the healthcare in India. You should know this. If you do not know in a profession you belong, it's like nowhere. So Boer committee in 1943 took 3 years and gave a report 1946, what should be healthcare delivery system in India. That is the reason why all the medical schools existing in 1946 were converted to medical colleges, 25 of them. So suddenly from 7 or 8 medical colleges, there are about 30 medical colleges in India. And we are part of that Boer, Joseph Boer. He is a Kerala gentleman, and he was made the committee chairman by British government. So the question is that today we owe a lot of things to Boer committee, and this institute is by part of the Boer committee report. Boer committee gave a report to Rajkumari Amritkar, who is the founder, the health minister of India from 1947. And he used to be the president of this institute, and they say the Boer committee recommend that there should be a medical university in the country. That is how this medical, we must know, because many people here are the product of AIIMS and they do not, because when I take interview for the professor, I ask what is the meaning of AIIMS, where did it start, what is the purpose? Purpose was quality medical education, international level patient care, and good quality research. How many of you know this medical institute is third in medical publication in the world after Harvard Medical School and Yale University? Do you know anybody? In 10 years time, Harvard Medical School published 47,000 paper, the Yale University published 23,000 paper, and this university produced about 10,000 paper. But do you know that Harvard Medical School has 4,000 faculty? And this was having a faculty of now 700, we have 800 posts, out of which about 200 posts are vacant because of reasons all of you know. So if you see the Harvard work in AIIMS score better. There is a write-off which came in, I think about a year back, comparing Harvard Medical School to AIIMS. They compare the number of patients to number of doctors, cost benefit, and the amount of money spent. The amount of money spent for Harvard Medical School in billions. How much? Billions. As compared to AIIMS, the money spent by the government is nothing. I think it is 4,000 crores for a budget. Nothing. Not even a half a billion. So the amount of patient you treat is 10 times more than Harvard Medical School, because we have large number of people come from. So imagine the contribution of this building, this hospital, institute to the country. And the aim was to produce teachers. If you look at past 10 years or 20 years, all the medical graduates went to US. We are very happy our doctors are going to America. But to make a doctor in India, it costs crores. Do you know that how much money government of India spend in crores? So if a person does MBBS or MD or MS and goes abroad, the America is getting fine products for nothing. And we do not understand how much we harm our country by going abroad. I remember 1st January 77, I was going PG here, and the America was making difficult for the visa. We are 15 a batch of postgraduates joined in 75, 76. And do you know in 6 months time, all of our batch who joined left, we are 5 left. I think Dr. Dureja might not have joined that time. So the question is that we all love to go and work abroad at the cost of our poor country. I think that's bad. I am happy that you people are serve your country, so I salute you, because you are the true citizen of country. Lot of people come from America like Shekhar, Sen and all these my friends. They say, oh, this is big, that is big. Now the Shekhar put, if you look at the doctors, I think WhatsApp, Shekhar give a lot of advice. Never work for this country. The people who sit in New York advise to Indians what to do. Is not very sad? What are the village life people have seen? Go and see village about 50 kilometers from here. Go to Balabgarh. Go from Balabgarh to Jhansa. The rural center of this institute, beautiful institute, is Balabgarh. Balabgarh has sub-center Jhansa. I was posted 3 months in Balabgarh in 78 and 1 month in Jhansa. And that will be my best remembrance of this institute. Because the village, the simplicity of the people, the river, part of the Jamuna is flowing nearby, you will never forget. The question is that what you are going to carry from your career. Here is an institute where he is going to teach you pain management, and pain is a very important part of human being. Anybody can tell he has never suffered by pain? On any of you can tell you have not suffered? Headache, backache, toothache, stomachache. So can anybody say that he is not touched by the disease of pain? No. Yet they are all different. Management, abdominal pain is different, headache is different, chest pain, and we are talking about body ache, body pain. We are not about headache. We are not talking chronic headache. We are not talking about abdominal pain where you give injection. We are talking about musculoskeletal pain. So this pain management is basically talking about musculoskeletal pain. For a brain tumor pain, you cannot give injection here. Cannot. Or a spinal cord tumor, no nerve block is going to help. So you have to understand what to use in what situation. That is the reason where I don't see, even today I don't see more than 5 patients a day. In 6 hours I examine 5 patients. History taking, understanding his problem, psychological aspect, familial aspect, problem, economic problem, doctor's marriage not done. You have to see what. That is why Dr. Abdul Kalam said physical pain, mental pain, social pain, psychological pain, doctor giving pain. What pain doctor give? Lakhs of rupees for pain management. So you have to see what type of pain he is having. Is it physical, mental, social, psychological, or doctor given? I tell everybody, do meditation for pain. Get up in the morning, sit under sunlight for 1 hour, take honey, haldi and warm water. Don't use AC, muscle spasm. I don't use AC. I stayed in Delhi for 45 years. I had no AC in my house. Enjoy summer is sweating, winter is shivering, and rainy is getting wet. If you change your nature, nature is going to ditch you. Get wet in rain, get sweat in summer, and get shivering in cold. The nature is like that. Thank you very much. Don't change nature.
So thank you very much, sir. I mean, like, I can take few tips from your the talk. I mean, like, definitely this is made in workshop, made in India workshop, because we have like all the experts and faculty from India. So that is one point. Second, I mean, like, let's remember Abdul Kalam and get his wings of fire to handle pain for next 2 days and subsequently in our career. Thank you very much, sir, for your address. Before handing over mic to Dr. Raju Sharma for vote of thanks, I will like to acknowledge Dr. Rath, who is our registrar, and I will request Dr. Rajesh to please welcome with the flower bouquet. हाँ, अब Rajesh. Yeah. Yes, thank you. He is one of the pillar of Yes, so we'll stop AC in his rooms. So fine, sir. So he is a pillar of our neuro anesthesia department, and now I'll request Dr. Raju Sharma to please give vote of thanks.
Before I start giving the vote of thanks, I request Dr. Rajesh Meena to felicitate our faculty, Dr. Navdeep Sokal also. Dr. Navdeep Sokal will be presenting his talk in the afternoon session. Dr. Navdeep. Dr. Navdeep Sokal is our professor in neuroanesthesia and quite doing a lot of work in pain management, which and we will be eager to learn from him during the afternoon session. Thank you. With this, we are at the session of vote of thanks, and though this is a very difficult task, and I will try to do as much justice as possible with me. First and foremost, I would like to thank Professor A.K. Mahapatra sir, chief guest of this workshop, who spared his busy time out and came so far off to grace this occasion. Sir is currently working as Vice Chancellor of Shiksha Anusandhan deemed to be University in Bhubaneswar. Sir is a founder member of this society, and not only a founder member, actually this society is a brainchild of Professor Mahapatra sir, and this was started way back in 2010. And when I took that charge of treasurer of ISPNS, and when I opened the file, the first page was application form signed by Professor Mahapatra sir, dated 19 December 2011. So this is actually a brainchild of this, and we are all here because of, we can assume that we are all here because of Professor Mahapatra sir, who planned and conceptualized this society. I am thankful to Professor Kale sir, chairman of this workshop and HOD Neurosurgery of AIIMS New Delhi. Sir had seen each and every aspect of this workshop on his own, and not only guiding us, each and every step he checked and ensured that everything is planned as per need. I am thankful to Professor Deepak Agarwal sir, co-director of this workshop, for planning this workshop. Actually, this workshop, sir was receiving a lot of input since long time by the request of delegates, and the last straw was put when sir organized this ISPNS cadaver workshop in March 23 at our trauma center. A lot of delegates had requested to sir at that time, and I am sure many of them have registered for this workshop also. I am thankful to all those delegates who pushed us for organizing this workshop. I am thankful to I'm thankful to Professor G.P. Dureja sir, who is currently working as Director of Pain Management Center in Delhi. Actually, this pain management services at AIIMS was started by sir at AIIMS in 1986, and not only in AIIMS, it was sir is called as pain management pioneer of our country. This is what I heard from your department colleagues, sir. And sir took VRS from Institute in 2005 and handed over the legacy to Professor Virendra Mohan sir, Dr. Debesh Bhoi, who are continuing his work in the department now. Thank you sir for sparing your busy time and dedicating 2 full days for this workshop. Thank you very much sir. I am thankful to Dr. Ashish Tandon, who is the Director of World Endoscopic Brain and Spine Center in Jabalpur, who came far off from his busy schedule. Sparing out 3 days for a private practitioner is very difficult. I appreciate his contribution for this academic program, and I am sure all of you will gain a lot of things from him during this workshop. I am thankful to Dr. Dhruv Bibra, who helped me in organizing minute things besides the scientific program. I am thankful to Dr. Mahendra Singh Chauhan, Dr. Anirbandhi Banerjee, Dr. K.V. Narsingh Rao, Dr. Siddharth Chawli, Professor Virendra Mohan sir, Professor Navdeep Sokal, Dr. Debesh Bhoi for their contributions to the program. I am thankful to Professor Girija Prasad sir for coming and guiding us, and even during the planning of workshop scientific program, he guided me a lot. I am thankful to Professor Arvind Chaturvedi sir. Actually, sir was planned to attend this conference, and had planned for a trigeminal session to be chaired by him, but because of some personal reasons, sir is not available today. I am thankful to sir for his guidance and support for organizing this workshop. I am thankful to Dr. Ashish Bindra, Professor Manjiri Tripathi madam, Professor Chandra sir. My department colleagues helped me a lot, especially my junior colleague Dr. Dattaraj, Dr. Ramesh Dodamani, Dr. Shweta Kedia, Dr. Sachin Borkar, Dr. Kokula, Dr. Rajesh Meena, Dr. Satish Verma, Raghav, Dr. Surya, Dr. Ravi. They helped me a lot in organizing this workshop. My department residents, they did a lot of hard work in arranging the patients, looking after them, doing their workup and planning the surgery. I'm thankful to all my residents for their hard work. Special thanks to our sponsors, Sun Pharma team, all the 5 divisions of Sun Pharma, Intas Pharma and Synthes for their contribution and support to this academic event. Various vendors, Prashant from Philips, Gaurav, Manish Sharma, audiovisual team led by Ravinder. Our OT nurses have also worked a lot for this workshop, and I am thankful to all of them, our OT nurses, our OT technicians, my office staff, Anugrah, Vinay, Shubham, Navneet, Khyati, Yogesh, Amit, all of them have worked hard for this workshop. I'm thankful to all of you who has taken time out of your busy schedule and come far off, leaving your busy private practice and spending time, and I'm sure you all will learn a lot from this academic program. Lastly, I would like to extend a heartfelt word of thanks to all those who have made today's event possible, whose name I may have missed, I could not have highlighted because of shortage of time. I am thankful to all of you for your valuable contributions. I now invite you all to the dining hall for high tea. Thank you very much. With this, we conclude the inauguration session. We will join back for a case after this tea break for 20 minutes. It's 9:45 now. 10 o'clock exactly we will start case discussion live from OT. Thank you very much.
मेरी बात सुनो।
हेलो, बोलो बोलो, किससे बोल रहा हूँ? हाँ ठीक है, एक मिनट यार, 4 5 ऑन कर दें।
हेलो हेलो। हाँ मैं ये कह रहा हूँ कि अभी कौन सा वो चले, कौन सी ओटी चलेगी पहले तेरे? क्या कर रहा है? अच्छा ठीक 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 है यार, ठीक है बाबा, यहाँ पे बैठे बड़ी हो रही है यार, इधर से हाँ हाँ। ओटी वन में चलेगा? अच्छा मुझे पीआईपी देना पड़ेगा, मत तूने बोलना है OT 1 OT 2, ठीक है ना? कुछ करना ऑडियो जैसे। जो भी नाम तो है ही तेरे पास, OT वाला डॉक्टर। इस बार डालिए तो चल गई है ना? हो गया सॉर्ट आउट? हाँ हो गया, मेरे वो कह रहा है बंद बड़ा सारा ग्रीन सा ग्रासलैंड है ना, उधर ही।
Okay, we'll be starting the operative session soon. अनुज,
अनुज,
OT में अनुज है.
अनुज,
Let us focus on the OT setup. अनुज को बोलो.
हेलो अनुज, हाँ बात करो सर से.
वहीं से बोलेंगे सर.
सर बोलिए.
हेलो. हाँ अनुज, कैन यू हियर अस? अच्छा अनुज, तो वहाँ पे जो OT रेडी है वहाँ का वो केस स्टार्ट कराएं. नहीं, पेशेंट अंदर करते हो, प्रेजेंटेशन स्टार्ट कराओ ना. OT1 कौन है? डॉक्टर जो रेजिडेंट है और डॉक्टर राजेश है.
No, this is Dr. Dareja.
Okay, sir. Ravindra, please take us back to OT1.
Yeah. So we are getting ready for the procedure.
Sir, there is a question from the delegate side. As there is an element of myelopathy in the patient, so what is the final plan?
So basically, there is no major neurological deficit. Even if the MRI is showing a little bit of myelopathy,
Yes, sir.
basic problem is that patient is having radiating pain.
Yes, sir.
And if good neurological examination has yielded us, told us that there is no major motor deficit.
Okay,
So
sir.
first we control the pain and then we take a call on what else to be done. So
Okay,
for this patient, since you have seen the MRI, there are two discs which are bulging, L4-5 and L5-S1, and she has a radicular pain. Which side?
Yeah, we understood that as patient is having predominant lower limb symptoms, that's why we are going ahead with our plan of root block.
Root block, yes.
So we have another question from the audience. People are saying, so what is the cut off defined? Like L4, L5, there is a disc which is quite prolapsed.
Yeah.
So what is the surgical indication and where do we go for
Basically, the
pain
medical
management?
indication comes with your neurological examination. If there is a sensory deficit, we still go ahead with the blocks. But if there is a motor deficit, that is definitely no. So if there are motor deficit, cauda equina, muscle wasting, then definitely we go for surgery.
So what about Shantanu has a question?
Can I speak?
Sir, are we delaying just an inevitable process? Because if the patient comes to me and if I give the option of a block and the surgery, he will definitely go for a block.
Yeah.
But I think we may be delaying his inevitable and he may end up in surgery after a few years. So is it good for the patient? Because
As I said, we just saw the patient now, but definitely the patient doesn't have any motor deficit. She just complains of pain. So even if
is it necessary to wait for the motor deficit to happen and then go for surgery?
Absolutely no. If you think that it's an impending deficit, if the patient's disc is so much bulged that it is going to cause her motor deficit later on, I think surgery would be the option. Definitely surgery would be the option.
I would like to summarize. In this patient, there are two things. One is element of cervical myelopathy plus acute radicular pain. Pain is a thing which we can manage very quickly. Maybe by afternoon he should be pain free. Yeah. But surgery will require planning, admission, anesthesia checkup. That all takes time. So by the time the patient is prepared for surgery, he can have pain relief by this foraminal block. I think there is no dilemma in. The only thing is we need to be careful while positioning this patient so that we don't exacerbate this prolapse of the cervical lesion. C5-6 PIVD should not get exacerbated. We should take all precautions while turning the patient prone.
S1 foramen.
Ravindra, can you show us the operative area?
S1 foramen. Shekhar, can I see this S1 foramen?
Ravindra, can you focus your camera on the screen on the patient? OT1, please focus on OT1 as the procedure is going on there.
आप दिखा रहे हैं पेशेंट को और वो उसका भी आपके पास है? ठीक.
हाँ सर, OT1 you are connected sir.
No, we are seeing OT2.
आप S1 दिखा रहे हैं?
Yeah. Now it's fine.
जी. श्याम चलाने Tandon, hi.
We are with you.
OT-1 can in the meantime prepare for the next case.
Hello.
And Dr. Tandon.
Yeah, can you hear me?
Yes, very
Okay,
nicely.
wow. So let me quickly present the case. He's a gentleman around 50 years. He's a farmer, non-smoker, and with no addictions. He does not have any chronic illness, and he's not on any medication. Specifically, he's not on any antiplatelets or anticoagulants. So this gentleman presents with low back pain for last 3 to 4 years. Increases on bending. It is sort of intermittent, and he has started developing radicular pain, at times extremely severe. It is associated with tingling and numbness, especially on the lateral aspect of leg and foot. He does not complain of any weakness. As such, no complaints in the upper limb or the right lower limb. Apart from very occasionally he may have some pain. Now on examination, his left SLRT appeared to be positive, around 50 to 60 degrees. His knee flexion is 4+/5 on the left side, right is normal. Then I'll show you the MRI. Now if you see, can you focus? Can you see the MRI?
Yes, we can.
So they have selected one of the most normal looking MRIs. And if you look at the central canal, if you look at these roots going, you will hardly find any abnormality. Even the canals, the foramen here looks pretty good. So we started searching. There is no facetal arthropathy as such. There is no evidence of any instability. So then we strained ourselves and we found an extraforaminal disc here. If you look, can you guys appreciate this? Hello?
Yes, we can see.
So
Ashish.
there is an extraforaminal component here which might be the cause of his pain. We can't be very sure. So what I have planned in this case is I would be doing a L4-5 transforaminal epidural steroid. So I'll try to target the exiting route of, that is the L4 as well as L5, and then I'll pour in some steroid and the anesthetic agent outside the foramen in the extraforaminal area as well.
Okay.
So I hope it sort of gives him relief. So are there any questions till now?
Yes, there are a lot of questions.
Okay.
We want to know, we just saw Professor Dureja also demonstrate, so we want to know how is your technique different. Do you also sedate your patient, midazolam or anything before you give?
No, so I do not sedate my patient, and also there are some papers which have shown that as such does not make any difference between whether you give sedation or not. Secondly, especially if you are doing a discectomy procedure, then in that case obviously you want the patient to be awake if you are doing a totally awake procedure.
Right.
So as such, for any of the blocks, generally for spine blocks, I avoid sedation until unless the patient is very apprehensive and his blood pressure is shooting.
Okay.
So in those cases we then use midazolam. So hi. So can you see here?
Yes, we are watching.
So I'll show you the lateral first.
Okay.
Now my approach is absolutely different from what sir had shown, just a paramedian or a parasagittal approach. I would be demonstrating a far lateral.
Okay.
So with that you can do an epidural steroid, along with you can do a discography, and you can then, if you wish to, you can do a transforaminal discectomy as well. So shoot here please. एक जन वहां दिखाएंगे उधर. Okay. So this is L4-5. Agreed? Yeah. Okay. So L4-5. Now what I was telling in my lecture was that in L4-5, when you go lateral, you can go till this facetal joint hump. Whereas when you go higher up,
शूट करिएगा एक बार.
Can you, Ashish, can you just show us first the cranial and caudal so that we are oriented on the patient?
सी आप लोग वहाँ दिखा रहे हैं.
In
so-
the operative field only just show. Because only the operative field is visible to us right now.
या
Okay.
ओके सो दिस इज क्रेनियल. आप सिर दिखा देंगे.
हाँ ठीक है.
So this is towards that is the head, and towards where I am standing is the feet.
Okay, okay.
And this is L45.
Right.
Please shoot once again. Okay, so this would be my entry point here. Now, as I told you, the best point would be the end cartilage of the upper vertebra. That is supposedly to be one of the best areas to go for a block. So for L4 and L5 or even L3 level, you can go up to the facet joint. Shoot. एक बार और shoot.
So laterally at what, I mean, is it, where at laterally are you putting your tip of your forceps?
So yeah, so that is what I was showing. It is just parallel to the facet joint. एक बार और shoot करिए, फिर से दिखाएंगे. See, you see the facet joint, right?
Yes.
On the lateral.
Yes.
So here, exactly at the same point, there would be an entry. So
What I mean to ask is, if you go more laterally, what will happen?
more inferior. I mean, now I am at the lateral most point.
Okay.
If I go more inferiorly,
Yes.
then I'll enter into the peritoneum. एक बार shoot कीजिए.
हाँ, just let us see that also.
So ये अगर मैं यहाँ
Okay.
से needle डालूंगा तो
Yes,
I'll
yes.
enter the peritoneum.
Understood.
And what happens is, Deepak,
Yes.
जब आप ऊपर के लेवल पे रहते हैं, please
हाँ.
shoot. हाँ, तो यहाँ पर अगर आप यहाँ से एंटर करेंगे,
हाँ.
so you will definitely injure some peritoneal structure. So what you require to do is, अब shoot कीजिए. So for the higher level, you have to be at the tip of the spinous process. Can you see that?
Right,
Shoot
right.
करिए एक बार और.
Right. Higher level means L3, 4?
No, higher level means L1, 2, L2, 3.
Okay.
L3, 4, 5 you can go lateral.
Okay, okay.
ठीक है?
Understood.
तो ये हमारी एंट्री पॉइंट होगी. अब एपी दिखा दीजिए प्लीज. या सो हिमांशु इज हेल्पिंग अस विद द सियाम. रमेश इज विद मी. So unlike the approach which sir showed, where you need a Scotty dog view, in this approach which I am showing, it is purely a AP and lateral.
Okay.
Okay. So अब AP view में वो लंबी needle है क्या? Okay. So I would like the camera to focus on this needle. I have brought this needle. This is a long needle. Which obviously through this you can pass in the K wire as well if you want to do a discectomy, and the dilator.
What is it called?
This is just a long transforaminal needle.
Achha, okay, long
Yeah.
transforaminal. So there is some gauge to
Spinal
it.
needle will be small. There are longer spinal needles that you can use, but generally they don't come very thick.
Okay.
Yeah. So
What would be the gauge for this 22?
So no, this is a little more. I think sir was using was 22 or 23. I'm not sure.
Right.
But this is around 20.
20, okay.
Yeah.
Understood.
So now I'll show you the AP. Shoot kariye please. Okay. So friends, what I want you all to focus is, look at where the iliac crest is. So the needle has to go above the iliac crest because you need to take a lateral approach. And the best point of entry, shoot करिए फिर से. Yeah, this would be the best point. Okay.
Okay.
Now why we have gone so lateral is, there is one important technical information is, there is a bevel to the needle, and the bevel will take you where the sharp point is. So what I mean is, अगर आप यहाँ दिखाएंगे, my bevel, the sharp tip is pointing inferiorly. So as I go in, it's gonna go inferior.
The bevel is pointing superiorly, the tip.
Yeah,
Okay.
the sharp point is inferior. So the where the bevel is, the direction would go opposite to sort of where
Understood.
it is.
Understood.
So the sharp point. So because the distance is long, it's gonna go a little inferior.
Inferiorly, understood.
Yeah.
And the length of this needle is how much?
This is 15 centimeters.
15 centimeters, okay.
Or sorry, it's 18 centimeters.
18.
Okay. So we have already given local to this gentleman. Yeah, I showed you on the lateral. Yeah, we see the facet joint. So we now know that. So we just now. Okay, so एक बार shoot कीजिए. So you see my direction is absolutely straight. If I go straight, then hopefully things would be fine. Yeah, I have given local.
So angulation, how?
Just straight, just go straight. That is why we were so lateral.
Okay.
वो lateral spot आएगा क्या जरा दिखाइए.
Parallel to the table, right?
We are absolutely parallel, and if you would have seen that there was no parallax, there was absolutely square.
Right.
Now, हाँ ये दिखा दीजिए. Okay, now see, Deepak.
Yes.
ये अगर आप देखेंगे तो मैं foramen से I am just about 5 millimeter above.
Right.
है ना, तो as I go in, the bevel will take me towards the foramen.
Okay.
Okay.
Understood.
Okay, shoot please. Sorry, shoot please. Okay, so you've started seeing the needle. Okay.
Yes.
On AP. So we are doing it on AP. We are starting on AP, and the target is towards the lower part of the the end plate of the upper vertebra, lower end plate. Shoot करिए.
Lower end plate of the upper vertebra.
Yeah. Shoot करिए please. ठीक है.
How you are ensuring that you will not enter peritoneum, sir?
Because I am going straight, I am not going inside.
Okay.
आप समझ रहे हैं? And you know,
Okay.
and the patient is also prone.
Understood.
Yeah. Shoot करिए. Shoot करिए. Excellent. So on AP I am pretty happy.
Yes.
Now I'll switch to lateral. Lateral दिखाइए. बट स्पाइनस प्रोसेस बिल्कुल सही है. ठीक है. शूट प्लीज. इसको सेव कर लिया ना. शूट करिए. थैंक्स.
Sir, what about the pain? Because you are passing a needle through a long area. So what about the pain and how we manage it?
There is no pain. Now look, I am not into the foramen. I am outside the foramen right now.
Yes.
So I pull out about 2 inches.
2 inches.
The needle.
Okay.
And then target it a little inferior. Now why I have done this is just to be safe.
Okay.
Shoot करिए. शूट कीजिए. यस. शूट कीजिएगा. देखें कहाँ है. ठीक है.
Do you follow the bone to hit the foramen or something?
That is the best thing to hit the bone.
Right.
That is the best thing. Bone is always your friend. This is the facet. दिखाना. Okay, we are in the infraneural part. Right now we'll again confirm through an AP. AP करिए. Now here you can't push your needle too much inside because on the lateral, because then you can injure.
Yes.
So I have to be doubly sure that I have not gone and penetrated the dura.
Because the posterior spinal line we can see just anterior to your needle tip.
Yes. Yeah, good. So दिखाइए please. So I am inside the foramen.
Right.
I am retrodiscal. I am perhaps retrothecal as well inside the foramen.
Okay.
Okay. Now Can I have the dye, please? Dye, please.
You also use Omnipeg 0.2 cc?
Yeah, I mean
0.5.
0.5.
Okay.
But another very important piece of advice, and this is a oft-making committed mistake, is to put a little extra dye in the first go. Never do that, because the dye spreads, and if you are not in the correct position, then you are not able to see the anatomy very well.
Okay, so you should put less.
Yeah, initially just say 0.1, go slow,
Okay.
and once you are sure that you are in the right place, then you can maybe inject the dye a little more. In fact, sir was doing the same thing. If you would have observed closely, initially he gave very small, he confirmed that he is right, and then he put in more.
Till how long you expect the dye to stay there and interfere your vision, if at all you have injected a high amount by
Sorry,
mistake?
I'm not able to hear. क्या कह रहे हैं? That's a good, interesting question. I'm not very sure about the answer for the time. But generally, these dyes, they can, though we would be washing it out, but they can stay in the body for almost 24 hours. Like we are very sure about sodium fluorescein that we use for tumors.
Just a housekeeping announcement, the tea which is, please make sure it doesn't fall, because we are taking special permission. So be careful about the handling of the tea.
End plate, or just at the end plate. मेरे को वो दीजिएगा, ये दीजिएगा. Infraneural. Yes, ऊपर जाएगा. इधर लेते हैं, मेरे को थोड़ा सा ऊपर जाना है. No. दिखाना, शूट करना. Okay. Now, I have repositioned my needle. वो discal पे था ये. This is where I exactly wish to be in. That is near the end plate.
So what did you see on the first contrast that you made change, and what change?
Basically, what we saw was that the position was discal, ना? इस केस में मुझे डिस्क में भी जाके दिखाना है आप लोगों को, इसलिए I just went again up.
Okay.
Exactly जहाँ चाहिए. हाँ, थोड़ा रूट में जा रहा है वो. अभी दिखाना प्लीज. हाँ, तो ये ना नीचे रूट दिख रहा है towards the down, but there is an epidural spread also. So I'll inject a little more. अभी दिखाइए. Yeah, so this is the epidural component.
Yes,
Okay, so now I am targeting the two routes, both the route, the exiting as well as the traversing.
Right.
So this is what is, so जो अभी सर ने दिखाया था, that was a selective nerve root block.
Right.
This is more of a, I'll say a targeted epidural where there are two routes that you can target.
Okay.
Now another important piece of information which I would want to share is the dye is almost 4 to 8 times more viscous than the local anesthetic. So what spread you see here, the drug would spread more than what you see here.
Okay.
Okay. Sensor के अंदर.
What drug would you use?
I am using bupivacaine and I would be using dexamethasone. ये क्या? Bupivacaine.
You
So
are
I
mixing
would
the
be
two?
injecting 1 ml of bupivacaine.
Sir, you are mixing the two or you are giving them separately, one by one?
Shoot karna please. So here you can see the spread now.
Right.
है ना? ये अभी मैंने, now I'll inject the steroid. Dexa.
So bupivacaine, how much did you give?
It will last not more than 6 hours. 6 to
1
8
ml.
hours.
Ashish, how much bupivacaine and steroid?
So steroid would be less than 4 milligram. So basically what I do is, suppose if I am doing at one level, I'll inject 4 milligram in all. But if I have to do 2, then I'll sort of reduce it and say 3 milligram or 2 milligram at each level. And as far as bupivacaine is concerned, 1.5 ml of 0.25%.
1.5 ml, 1.5 ml at every level.
Yeah, so again, if it is at multiple levels, I'll use less.
Okay. And do you mix contrast with either of these two agents, steroids or bupivacaine?
Can you come again?
Do you mix contrast with any of these two agents?
No. That contrast is absolutely separate.
Right.
Yeah.
Dr. Ashish, you are using two things. One is steroid and other is bupivacaine.
Yes.
Are you mixing the two, or is there any sequence? You are giving them sequentially.
So I have given it sequentially here, but you can do that as well. But generally I try to give it separately, not together.
What is the sequence you follow?
So sensorcaine, steroid, sensorcaine.
Okay.
Yeah. Now what I want, sorry. So previously I used to use depometrol, not triamcinolone, but then having gone through a lot of studies, I have shifted to dexamethasone and I have not found any difference in the result, number one. And even there are a lot of good meta-analysis, I'll share in one of my lectures, that there is no difference as such in both things, neither in the rate nor in the duration of response.
Anyway, neurosurgeons are fans of Dexa only.
There are a lot of advantages.
Acha, Ashish?
Yeah, sorry.
Why particulate and non-particulate? What is the difference? And
okay, so the difference is, what happens is, particulate, what do you mean by particulate? When you inject, these particulates coalesce and the particle size would be 10 times or at least 5 times more than the size of the RBC. So in case if you have an accidental injection into the vessel, you will have thrombosis, and that is why patients have had anterospinal artery thrombosis, spinal cord infarcts and other issues with the particulate matter. So till date we have around 20 to 25 cases reported with particulate and none with dexamethasone. Dexamethasone is 10 times smaller than these particulates and it does not coalesce.
Okay, understood.
So that is the science behind it. Okay, now I want to do the extraforaminal block as well. So I am pulling out the needle, dikhaiega, and just I will be going a little inferior now, and obviously the disc is more anterior to the foramen, so little inferiorly directed. Dikhaiye, shoot kariye. See, as I am touching the disc, the patient is having pain.
Right.
So this is, I am here extraforaminal and I will put in some drug here for his benefit. मुझे एक काम करेंगे, एक बार lateral भी shoot कर दीजिए ताकि no, contrast will not show anything great. Sir. Discogram.
So how fast or
ideally yes, but
Ashish,
sorry,
how quickly the relief will be there, pain relief it is there?
Ideally though it comes immediately, but at times we see that it may take say 6 hours to longer.
But the maximum relief should come by 6 hours.
The maximum relief comes a little later when the steroids really act.
Okay.
It is not the sensorcaine, it is the steroid,
right,
which though both have their effects, but so here I think I am very close, but I'll go a little more anterior. Still it dijiyega.
Here the nerve is nicely delineated by the contrast.
Yeah. And you can see the epidural drug flowing. And there is another important thing, though I really don't know whether it makes the publication say it does, anterior position of the agent is better.
Okay.
So, because the incriminating disease is anterior to the root and theca. Shoot करिएगा. शूट करिए. अब ठीक है, आई एम वेरी नियर टू द डिस्क नाउ, so I'll just push in some more drug because it's an extraforaminal disc that we are suspecting. Sensor and steroid. ये कितना है? 0.5, थोड़ा सा और ले लीजिए. So and you know, it is now, if I just take this needle further in, it will go into the disc, the posterior aspect of the disc, and that is where you need to put in your cannula for a transforaminal discectomy as well.
So is there any bony landmark beyond which we should not put the needle to be sort of beginners?
That is the medial pedicle line. AP दिखा दो.
That is standard for if you do a screw fixation or whatever.
Because the disc is herniating a little down. That is why. Huh? Sense. दिखा. Okay, I am happy. I am just paradiscal. So we are suspecting that this is the area where there is extraforaminal disc herniation. I am sorry, because of the dye, you know, you may not be able to. अभी एक बार shot लीजिए. ठीक है. So you can, even now you can see the exiting route अंदर तक जाते हुए.
Yes.
And you can see the traversing route as well. नीचे. I'll show you. Can you give me a? So this is the exiting route here. ऐसा, and this is the traversing route का part.
Right.
Yeah. So we have given some extraforaminal and then we have gone into the sort of end plate के area में to give an epidural.
Extraforaminal, how much have you given?
I have given 1 cc of Sensorcane and around 2 milligrams of steroid.
Okay.
So let's see, I hope we are able to give him some relief. So I think the procedure is done.
Can we ask the patient right now?
Why not? You want to take all my tests, huh? आदत गई नहीं.
नहीं दिया.
नमस्ते. तुम्हारा दर्द कैसा है अभी? जोर से बोलो भाई.
Sir, there is a question. Yeah, sir, with this lateral approach wherein we are putting the needle at a distant point, so he has a doubt that how we avoid going inside the peritoneum. Is there any bony landmark to which we can adhere?
Yeah, so see, I'll show you once again. Lateral ले जाइए. या उसमें lateral दिखा दो. उसमें दिखा.
पहले
push मत करो. Okay, Deepak, this patient is saying that as of now he has relief.
Very nice.
So let's see how.
See, even if he is given bupivacaine, that means he is in the right place. That is most important.
That is what I was saying.
Yes.
That as neurosurgeons,
It's always
diagnostic aid as well.
therapeutic.
नहीं, lateral वाला दिखाइए. Okay, मेरे को artery दे दीजिए. Okay, so see, this picture is a very beautiful picture. Now in the lateral, you sort of the starting point is somewhere here. Okay.
Yes.
Now the best thing is go straight in and hit the bone. The bone, basically the peritoneum at this level starts inside. So it is about almost 1.5 centimeters inferior. You are getting me?
Yes, sir, we are understanding.
Yeah, so basically the best idea to be safe is go straight and hit the lamina or the facet and then just pull out a little and then push your needle inside. Then you will be safe, absolutely safe.
Thank you, Ashish.
Just imagine, if you want to do a discectomy, obviously you have to pass a lot of dilators. So, you know, this is a very thin needle, those dilators are big.
So if you want to go a level below the pelvic bone will come, how will you direct your
So that's a good question, but this iliac crest here, the ala and the transverse process, this gives you very small, very narrow space to negotiate and enter into the foramen. That's number one. And number two, doing a discectomy at this angle is not a good approach. So that is why, and also if you will appreciate this interlaminar window is huge in the L5-S1 space, and the disc is towards the interlaminar space. So you just cut the ligamentum flavum here, interlaminar.
No, Ashish, they are asking for blocks.
For blocks,
So blocks, I will go for L5-S1 block. For L5-S1, if the iliac crest is low, if I am lucky, I may use the same approach. Otherwise, what Dureja sir showed, I do L5-S1 for that, and I can go supraneural for that.
Okay. Hello, Dr. Deepak sir.
the transforaminal.
Hello, Dr. Deepak sir.
Yes.
Next OT ready, OT number 1.
Yes. Okay, Ashish, thank you so much.
Pleasure.
Hi, please have the next case ready. We'll come back to you.
Sure.
Yes, shift to OT1.
Pranjay, are you ready with the presentation of case 4?
OT2.
OT number 2 you are connected sir.
हाँ डॉक्टर आशीष.
हाँ जी डॉक्टर आशीष सर को माइक लगाओ.
ये बीच के केसेस गायब हो गए सर 1 सेकंड एंड 2
सर वो हमने देख के सिलेक्ट कर लिया.
तो बाकियों का क्या करेंगे?
पूछता हूँ मैं.
उनसे को चुपचाप लगा रहे हैं जो भी करना है वेस्ट ना करें पेशेंट आए हुए हैं.
डॉक्टर आशीष सर.
Yeah, hi. I'm
Yes.
starting. Just starting.
आफ्टर स्टॉप.
Yes आशीष.
So local here and local here and then keep. Okay. So,
Ashish, your voice is not coming through. That maybe
hi.
some
Is it-
problem with the mic.
Is it okay?
Still it is low. We can hear you but very low. Ravinder.
Yes.
अभी ठीक है? Okay.
Volume is very low.
Yeah, Deepak, is it okay now?
Better.
Okay. So, I'll take you folks through the next case.
Yes.
He is a 32-year-old gentleman, and this gentleman has complained of low back pain for last 5 years, along with right-sided radicular pain and now weakness. So he has severe radicular pain, he has tingling and numbness in the lateral aspect of leg, foot, and he has weakness in the foot on the right side. He now over last 2 months he has started developing some symptoms on the left side as well, and at times they are also severe.
Okay.
On examination his right SLRT is positive to just about 30 degrees, left is positive to about 50 degrees. He has significant foot toe weakness, mainly on the right side, but some weakness on the left side as well.
So he's got a foot drop.
He doesn't have a foot drop. He has basically power of 2 to 3 by 5.
Okay.
And in the toes it is about, on the right it is 3 by 5, on the left it is 4 by 5.
Okay.
So ideally this case is a case for surgery. However, just to buy time and severe pain, the decision has been undertaken for blocks as of now. So I'll draw your attention to the MRI. There is, so if you see here, there is L4-5 disc prolapse and L5-S1 disc prolapse as well. And on the left side, you have a little more more disc herniation as compared to the right, on especially at L5-S1. At L4-5, if I'll just take you to the axial views, you see a good amount of right-sided disc herniation, and there is an extruded and perhaps a sequestrated small fragment as well,
Yes.
which is compressing the exiting, at the foramen, so perhaps touching the traversing root as it is coming out. Also, there is a central disc at L5-S1 here.
Right.
So the plan today is, I'll demonstrate again the same right L4-5, the long approach, and for L5-S1, we'll just demonstrate a midline interlaminar epidural block. So, I mean, sort of you'll see the complete repertoire. Is that okay, Deepak?
Yes, yes, it's
Okay, fine. So we are preparing the patient. Here we would be using the same set of epidural needle and loss of resistance technique, as well as the long needle block that I had already shown you. I'll just scrub and come. Sorry.
So, Ashish, can you again tell your plan?
So my plan is to do a right far lateral transforaminal block.
Same as you did in the last.
Yes, same at L4-5, and then do a epidural block midline interlaminar
At L5 level.
at L5. S1 because there's sort of central, so there's no point going either side. We want the drug to flow throughout.
And for L5 level transforaminal you're not doing because of the islet crest coming in the way. Hello, Ashish. We have lost audio. Ravinder.
डॉक्टर आशीष सर इस तरफ
अच्छा ठीक.
जनरल उधर से मिल जाएगा, जनरल सर्जरी के उधर. ओके, नहीं अच्छा ठीक है.
I was scrubbing.
ओके,
चलो फटाफट करें यार, बीटाडीन दीजिए जल्दी से. हाँ ये वो सेंट्रल उसका लोअर वन.
If you are going transforamina as per Dr. Dureja's approach, which is near paramedian, then we are targeting only the exiting route. When you are doing the far lateral, Dr. Ashish Tandon's way, then we are targeting both the routes in the transforaminal, the traversing as well as the exiting route.
Okay, Deepak.
Yes.
Yeah, basically, see with both the approaches,
Yes.
you can deal either way. You can do a selective nerve block, or you can target both the blocks, both the nerves with both these approaches. It is just a matter of how inside, where you are positioning your needle tip.
Inside, right, near the foramen.
Yeah, so suppose if you are in the Camden's triangle,
Yes.
then obviously you are infraneural, you will, and if you push the needle a little more towards the center of the pedicle, then you will deal both the exiting as well as the traversing route.
Right.
Whereas if you are supraneural,
Right.
that means just subpedicular, you are doing a selective block.
Okay, understood.
Also, the amount of drug, this is a very important point of discussion. The amount of drug also decides the selectivity. So suppose if you put in 2 or 3 ml, you know, though diluted, it's gonna traverse a lot. So if you want to do a particular selective nerve block, you have to give not just the position has to be correct, but you have to give very limited amounts, say just 0.5 ml or at the most 0.75 to 1 ml.
But if you give more drug, how is it detrimental?
No, it will then affect different routes. So for diagnostic purpose, you will not be sure
For the diagnostic part.
Yeah, you will not be sure that which route has been blocked.
So for the local anesthetic, we should be very selective.
Yeah.
Give a small amount.
Yes,
Right.
yes. Drape, please. Drape, sister, drape करते हैं. So, एक minute. हाँ, कर दो उधर. Yeah, one more drape, please. किधर था? ये है ना? ठीक है. चलो, ये इधर लगा दो. या, थैंक्स. हाँ, ठीक है. और दे दीजिए. जब मॉप देंगे, स्पंज देंगे सिस्टर. सो आई एम स्टार्टिंग विथ वो लंबा नीडल ले लिया सिस्टर. हाँ बस. So we are again starting with the transforaminal. यही है ना? हाँ ठीक है. इधर पूछ गया, we'll do a AP and then we'll decide. ये कर लेंगे, सियाम कर लेंगे अपन. No problem.
Is the patient positioned in the opposite direction this time or what are we?
Yeah. Okay, so आप लोग zoom out करेंगे दिखाने के लिए.
हाँ.
Zoom out है. Okay,
हाँ,
so here the patient has right-sided pain.
Right.
And so I am standing on the right side of the patient.
Right.
Yeah, clean kar do. And I'll be approaching from the right side.
Okay.
So needle please.
But the patient had bilateral pain, right more than left, so that is why you are taking the right side.
For L4-5 Deepak, we know that there is a right-sided disc herniation.
ठीक है.
So we are taking a right approach. For the L5-S1, we know that there is a central disc
herniation.
So we are going a sort of epidural.
Understood.
Yeah. Okay, shoot कीजिए. Shoot please. Okay, we can go a little down. Shoot please. Shoot please. Okay.
So this is the hump you are talking about.
Yes. This is basically the superior and the inferior articular process making the facet joint there. This is the hump. So we should not go below this hump. Also in the X-ray, when you see on the left side of the hump towards the foramen नहीं जाना है.
Right.
Yeah. So क्या आप लोग मेरे needle की position दिखा पाएंगे क्या?
हाँ, we are seeing.
You can see the position of the needle.
Yes.
It's blank straight, Deepak.
Yes.
Okay. And the bevel is sort of looking up.
Right.
So the pointed end is down.
Right.
And it is going to help me take it there. Ideally, for starters, I would recommend that don't start on the lateral, rather go on the AP view, because you know the sort of length कितना अंदर जाना है आपको.
Right.
Okay.
Right.
But here, just for demonstration's sake, and he is quite obese. Sorry. दिखाना please. Okay, so मैं almost सही जा रहा हूं. AP कर लीजिए.
So here the needle looks to us angled. It doesn't look parallel to the floor or to the table.
No, the needle is absolutely parallel to the floor. Though it may not appear that way on the...
Okay, understood.
Yeah. Okay. Yeah. It's just AP. Yeah, we start with AP. हाँ, एक इसको हाँ आप shoot कर लीजिए. Good. We can't even see the needle. हाँ, ठीक है. अभी दिखाइए. और थोड़ा सा आप हाँ थोड़ा अपनी तरफ कर लीजिए. हाँ ठीक है. Yes, that was the iliac crest. जाइए. शूट कीजिए. जाइए. थोड़ा सा आप ना टेढ़े हो रहे हैं. आप टेढ़े मत होइए प्लीज. हाँ, आपको दर्द नहीं होने देंगे. शूट करना भी. नाउ इट इज गुड स्क्वेयरिंग. वो टेढ़ा होगा ना तो यू विल नॉट बी एब्सोल्युटली श्योर वेयर यू आर गोइंग. नहीं आप प्लीज टेढ़ा मत. शूट प्लीज. शूट प्लीज. शूट प्लीज. या Yeah.
So you must be hitting the this bone now.
No. I am into the foramen. I mean, feel-wise, I am just extra resistance. I felt.
Understood.
So I did not hit the bone. Let us confirm on the lateral. That's the best way.
Yes.
And there is one more thing which I wanted to show. ये जरा सियाम आगे करो. Sorry, आप lateral कर लो. आप ये needle दिखा पाएंगे क्या? दिख रही है? Okay. So you see almost the whole 15, 17 centimeter of the needle is gone.
Yes, yes.
And now again, what I want to emphasize here is, that is why for a transforaminal discectomy, we use a 30 centimeter long or instruments and 18 to 20 centimeter long endoscopes.
Right.
ये हाँ दिखाइए. So we are beautifully placed inside the foramen.
Yes.
Agreed?
Yes. Yes.
Okay. Yeah. No, the foramen is coming up to the एक वो दिखाइए मुझे कुछ हाँ instrument. Okay. So the foramen is pedicle to pedicle. So I'll show you here first. So the pedicle is the foramen is all like this from here to here. It is sort of wider above and thoda narrower lower. Yeah. And so it is pedicle to pedicle. So here if you see, it starts from this pedicle and goes up to this. Okay. Yeah. We are, no, so I'll show you with the dye. You will see the, so another important thing is don't pierce, go beyond the medial pedicle line under any circumstances. The other thing is because until unless there is a aberrant root or something, you will never injure the root if you are targeting this area. Dye. Now, can I have AP करेंगे क्या? चलो lateral में पहले देख लेते हैं. दिखाइए shoot. Okay, ठीक है. अब AP कर लीजिए. I can start seeing the root going in. And also Deepak, can you see now the needle appears absolutely parallel?
Yes. Yes. Now it looks better.
थोड़ा सा टिल्ट भी कर लीजिएगा हल्का सा. आप ऐसे हो जाइए. या थैंक यू. Which? That is the knee. The long needle है ना, तो the tissues are putting their pressure. No, it's not bent. It's a straight needle.
So you put in the contrast?
Yeah, see, you can see the contrast.
Yes.
ठीक है?
Right.
Now, see, this is typically one root that is getting affected, though I have injected very small amount. अभी दिखाइए. So the root is very well seen.
Yes.
मेरे को स्टिलेट देंगे इधर.
Some amount of epidural is also
Flow is there, yeah.
Yes.
But you know, because the needle is like not absolutely inside, so I've just pushed it another millimeter or two. जरा दिखाइए, shoot कीजिए. अब shoot कीजिए. Shoot. Okay. ड्रग डाई दीजिएगा फिर से. Shoot, please.
Because we use such a small amount of dye, what do you do with the open ampule?
Arey, that goes waste, Baba.
We can reuse it?
No, we generally can't reuse it. The only thing you can do is you can keep multiple cases as today. Shoot. Okay, now you see the epidural dye.
Yes.
है ना? So I pushed the needle a little bit inside. So now both epidural भी जा रहा है. ठीक है, तो now I am giving 1.5 sensor gain. Yeah. Okay. Dexa, please.
Ashish, the audience wants to see the lateral view also.
दिखाओ भाई lateral. Lateral view also.
So you are given sensoricane followed by Dexa.
मतलब therapeutic दे सकते हो आप. Yeah, sorry दीपक, क्या?
Sensoricane followed by Dexa.
Yeah, and then followed by, I just gave a little bit more 0.2 cc of sensorcan in the end also.
In the
just
end.
to push, because there's some amount of drug remaining
Yes,
in the...
also.
देखो, you can see beautifully the epidural lining, anterior as well as posterior. पूरा thecal sort of myelogram दिख रहा है एक type से.
Correct.
Okay. So this is done. Now I'll try to show you the epidural. AP करेंगे? अच्छा, एक मिनट छोड़ दीजिए. वो हाँ, चलो ये दिखा लो. ऐसे रखिएगा. This was the needle, I think. Shoot करना प्लीज. Okay. Now we are trying to put in a epidural, हाँ?
Right.
चलो अभी मुझको आप एपी दिखा दीजिए. यही था ना. इधर दर्द तो नहीं हो रहा ना आपको? थोड़ा हल्का. हाँ, ठीक ठीक ठीक. हाँ हाँ, अभी हाइट बढ़ा लीजिएगा सियाम की आप. अभी थोड़ा सा ऐसा टिल्ट कर देना इस तरफ को. हाँ हाँ हाँ, बस अभी शूट करके दिखाइए. अभी शूट कीजिए. ओके. और टिल्ट कीजिए. अच्छा, इफ यू लुक एट द एक्सरे, yes, artery once again. So see here, this is not proper squaring. Okay, what I mean is, you see there is one end plate here,
right,
and the other.
Right.
So that is what basically we mean by squaring. Tilt kar lo.
So both should be
parallel,
visible as one line.
Yeah. Like we do for the pituitary surgeries, where the base is like parallel. मशीन नीचे के ऊपर? नहीं, पेशेंट को ऊपर ले लीजिए. आप थोड़ा ऊपर जाएंगे क्या? करिए, ऊपर हो पाएंगे? और होइए. ओके, तो स्लाइड इट देन. चलो अभी शूट करो, देखें. नहीं, वो रॉड ही है यार, पर अपना L5S1 आ जाएगा. हाँ, शूट प्लीज. ओके, गुड. Shoot please. Now it is squared.
Now it is looking much better.
Yeah. थोड़ा सा आप चाहें तो और टिल्ट कर लीजिए. थोड़ा सा और कर लीजिए. Can I just get simple xylokin? ये क्या? Why do we have a bar यार? पेशेंट, चलो कोई, वी एक्सेप्ट. वो थोड़ा सा आप इसको थोड़ा टिल्ट कम कर लीजिए. बस. ओके, शूट. द रीजन आई एम जस्ट एक्सेप्टिंग इट बिकॉज इट्स इन इंटर माइनर. ऐसे भी रहिएगा. बस. हाँ, अब शूट नाउ प्लीज. ठीक, शूट. ओके, नीडल प्लीज, लोकल. एक सुन की सुई लगाएंगे. बस. सॉरी. नहीं, टू ही. यस. स्पंज प्लीज. नहीं, जस्ट द गॉस.
Here, which needle would you use?
She'll use the same needle as sir was using, the 2E needle blunt.
Okay.
Yeah.
Is it the same one we use for lumbar drain placement? Can we use that?
Yeah. It's the same thing, but क्या है, we get the kit जिसमें loss of resistance needle भी रहती है, syringe रहती है.
Okay.
So with that sort of you have the complete set with you. हाँ, epidural. The sort of resistance varies a little. अपन ने करते हैं ना, कई बार वो अटकता है. This is more smooth and So this needle is a little sort of blunt ended. शूट करिए. शूट प्लीज. ओके, लैटरल कर दीजिए. इसको सीधा करके लैटरल कर दीजिए. Same, four. Yeah. No scarring. But when we used to use particulate, we used to have those white steroid particles seen. And even with endoscope, when people use that, when you go in endoscopically, you can see the particles. Yeah, थोड़ा आप height नीचे कर लीजिए. और करिए. Height नीचे. और करिए. Yeah. Now shoot, please. Okay. Right. So what I just wanted to show was, shoot करिए. Okay. Syringe, please. Shoot करिएगा. So here you see, है ना? Yeah, bouncing back. And then feeling. अभी भी I am ligament आ रहा है. Shoot, please.
You can feel the ligamentum flavum now?
Yes, I can. Sorry. Yeah. ठीक है, दिखाइए, शूट करिए. Yeah, now there is give way, sort of. वापस. But we'll confirm. Here you can easily confirm giving the dye.
Yes.
Again, the same principle, small amount initially. Shoot, please. Okay, this is good epidural flow.
Right.
Okay, so I don't think so we need to put any more, and we can just, yeah, sensor can. Steroid. Then sensor can again. बस हो गया भैया.
Same thing, sensorocane followed by Dexa followed by sensorocane.
Yes. Shoot, please. So that is, the dye has been flushed out now. Okay.
Right. Understood.
Yeah. So it's done.
So
Still.
has the patient got relief?
अभी आई.
Any questions? Anybody?
Yeah, sir, these patients, if they require surgery later on, do you ever find more fibrosis there when you eventually have to operate them after 3 months or 6
Okay.
months? Or
So
any difference is there? or not?
no fibrosis, but when particulate steroid are used, we on endoscopy we can very clearly see white shining steroid particles that we are able to appreciate. Until unless you've caused hematoma, there is no scarring as such. The other thing is there is reported literature that frequent blocks leads to increased frequency of infection post-operatively. So after surgery. So basically, to avoid too many blocks if the patient is not getting benefit.
So, if there is any dural injury, it's a very small, can we leave it like this, the rent, or we have to do something for it?
See, you will not appreciate because you're not. How will you appreciate that there is only after the procedure when the patient complains of positional headache? I'm sorry. Will you be able to, find out that yes, you have sort of, especially in lumbar cases, or when there is a frank CSF coming out from the needle, then obviously you are very sure that you have punctured, but nothing to be done as such.
Okay, sir. And how long you want the patient to be in prone position after giving the injection?
So prone position just about 10 minutes, 5 to 10 minutes, and then lying down for another 20 to 30 minutes, and then start ambulating.
For these cases, if at all you puncture?
No.
Okay, thank you, sir.
Sometimes we've seen that with the injection of these, the patient has a reproduction of the
extra, so that is when you are giving extra.
Sometimes with the introduction of the injection of this drugs, the patient has reproduction of the pain. How important do you think that the reproduction of this pain is? And sometimes we do not even see it, even though we see this entire physiologically.
Ashish, the question is, sir, hello Ashish.
Yeah.
One of the questions is sometimes you see the on giving the drugs you have the same replication of the pain.
Yes.
So is there any significance to that?
See, basically that can happen. Generally it happens, there are two circumstances. Either one, your needle is very close or touching the nerve. So the needle can cause that pain, or the drug, because at times we see many tight canals, and when you're putting 1.52 ml of the drug, there are pressure symptoms, and so that can also cause pain. The third is the irritant effect of the drug.
Right.
So these are the three sort of causes.
What should be, nothing to be done basically?
No, I mean Sensorkin would take care of that pain.
Okay.
The patients, most of the patients would complain the pain of the needle entry point.
Right.
That is where they have the pain.
Understood. Right, Dr. Ashish, thank you so much. We shift to OT1 if it is ready. Ravinder, shift to OT1.
Yes, sir, you are connected to OT number 1.
Dr. Dureja, we are with you. Yes, Puranjay. Hi, welcome back.
Thanks.
So what are you showing us now?
Yeah, थोड़ा ऊपर करो. So Deepak, this case is a large extruded disc.
Okay.
So ideally she is for surgery. So what we have planned here is we have shown you quite a range of procedures. So what I have decided is to complete the spectrum. I'll show you paramedian epidural block. I'll just discuss what it exactly is.
And will you be showing us later the radio frequency also, ablation?
RF ablation for the facet.
For facet median.
If we have a case, we can do it. Or what I was thinking was we can also have if we have a case of a intra-articular facetal block.
Yes.
Shoot, please. हाँ. पर वो midline है, ठीक है.
Can you, Ashish, can you just go over the case first?
Yeah, I will do it. I'll just mark and then I'll go.
Okay.
Shoot, please. Okay, this is a good point. इधर local लगा दीजिए, please. Okay. हाँ, center of the interlaminar space, paramedian.
I think you have Dr. Rajesh Meena with you, na? Ashish?
I have Ramesh with me and Prakash.
Ramesh. So,
and Amol.
So you can have Ramesh also do one case later.
Yeah.
So that, we can continue the legacy.
Okay, I'll discuss. She is just discussing the case. She is a young lady.
Can we have the, yes, now.
Yeah. So she's presented to us with low back pain, with pain spreading to her left lower limb, especially for last 1 year. And the pain spreads to the posterolateral aspect of thigh, goes to the lateral aspect of leg and foot. There is no significant history of weakness. Occasionally, again, she has right-sided symptoms as well. And apart from that, there is no significant history. If you look at the MRI, so I'll take you on to the T2 Sag. You can see this large piece here.
Yes.
Which is quite a big extruded piece. But I saw a sequestrated fragment here, which is inferiorly migrated. This is the sequestrated large inferiorly migrated fragment, which is on the left side. If we look at the axial scans, there's a L5S1 disc compression here, and then there is a large sort of sequestrated fragment here.
Yes.
So what I have planned in this case is, obviously you would be doing surgery quite early in such a patient.
But has she got any motor deficits?
Her plantar flexion and knee flexion is 4+/5.
Okay.
The rest of her examination is normal.
Okay, understood.
So what I have planned is to do a paramedian epidural block. So epidural steroid blocks you have seen today, basically one was the interlaminar midline approach. The second we showed you 2 ways of transforaminal steroid injections. One was the far lateral and the parasagittal.
Yes.
Now there is a third technique, which is the paramedian. So instead of the midline, which is the easiest, you go towards the side of the disease.
Right.
So that's the paramedian epidural. So I'll just scrub and come.
Okay. Ashish, you can still hear us?
Yes, Deepak.
Yeah. What is the benefit of paramedian compared to...
Okay, so basically, see, all of it is being near to the pathological area.
Right.
Because what happens is, like in this large sequestrated fragment, if we are like going midline, it may not allow the drug to spread very well.
Okay.
So we are trying to be as near to the pathology as possible.
Right.
So I'll just scrub and come.
Just have a look at the OT list, because if there is any other procedure you would like to see, we can have it expedited today. Because there were actually 7 to 8 cases posted in every OT, both the OTs. So if there is any specific case you would like to see, we'll have it expedited, because I don't think we'll be able to see more than one more case on the other OT today. It's already one. Epidural है इसमें अभी.
सबसे पहले
तो पता करो.
इसके बाद एक ही कुछ
Epidural license,
But I'll show you one data. Which is the sport trial. You heard the sport trial, na? Spine patient outcome research trial. So उसमें दिखा है that if
Hello, Dr. Artika.
Yeah, hi.
Mike, you are on, sir.
Yeah.
Hello.
Yeah, hi Deepak.
हाँ. And one will try and get if Dr. Dureja agrees for C2 block adenolysis, whatever he agrees to. Also, the morning presentations, we have had the videos made on YouTube, and I'm just sharing with you, so you can watch them at your leisure. And these cases also we'll make short videos and send to you.
Okay. Deepak, we are trying to start.
Yes, we are ready.
Okay, great. So we have marked. Let us see the marking. Okay, shoot please. Okay, so almost थोड़ा सा और straight करेंगे.
So this is parallel to the bone you are going.
नहीं, straight मतलब ये tilt है ना, ऐसा थोड़ा कम tilt करिए. वो squaring proper नहीं है. Yeah, sorry दीपक, क्या कह रहे थे?
Angulation of your spinal needle.
Yeah. Shoot please. नहीं. थोड़ा ही straight. हाँ, बस अब दिखाइए. So we are trying to square. नीचे आइए प्लीज, नीचे आइए. हाँ शूट करिए. ओके, सो Deepak, can you appreciate?
Yes, we can see.
Okay, so I am on the left side of the patient.
Right.
This is a AP view.
Right.
We are now paramedian. So basically, see, the idea is to give drug. एक shot और लीजिए. So either you give the drug from this side,
right,
or you give the drug from this side. You know, that's the basic idea.
Understood.
So the and it has again been reported that paramedian steroid is at times has better results as compared to even transforaminal as well as midline interlaminar. So it is the upcoming
and it looks simpler also.
Yeah, shoot please.
Can you tell us the angulation of your?
No, we'll go straight.
You'll go straight.
The C-arm is tilted a bit, but we are going to go straight. The same technique. Yes. Shoot please.
So instead of 2-His needle, you are using a spinal needle now?
No, this is a 2-His needle.
This is a 2-His, okay.
Shoot. Shoot, please. Okay. Lateral. Sorry. ये कह रहा, हाँ ये ऊपर का है, या नाउ लैटरल प्लीज. नीचे ले लीजिए. और नीचे कर, हाँ शूट कर. ओके गुड. बस शूट प्लीज. या thanks sister. So now basically loss of resistance technique again. Yeah.
So it's absolutely the same technique except your paramedian.
Yes, and another thing, when I was in this patient, when I just pierced the epidural,
Right.
there was a slight wince. So that is also another, apart from loss of resistance, that is another patient feedback to you that, you have crossed and now you are there.
Slight what? So
Wincing, a little pain.
Okay,
little
okay,
pain. Yeah. Shoot, please. Okay. Dye, yeah. So now I'll be injecting the dye. Shoot, please. Okay, the dye is flowing. ठीक है?
where do we see the dye? In the superiorly?
Yeah, superiorly.
Right.
I think inferior again, Deepak, because of the large disc, perhaps the flow is not proper.
Right.
So, एक AP भी करके दिखा दीजिए. So we'll put it in AP. AP में डाल के देख लेते हैं. Yeah. हाँ, वो नर्व रूट के अलॉन्ग थोड़ा सा नीचे का टेल सा दिख रहा है, बट वहीं पे तुम्हारा फ्रैगमेंट होगा जो और टिल्ट कर लीजिएगा ऐसे.
Message for the delegates who have not taken their I-card and coupon, please take it from the reception counter because coupon will be required for the lunch. All who have not taken their coupons, please take the coupons from the counter with the registration badge so that you can have a lunch. Thank you so much.
So Deepak,
Yes.
you see the dye flowing superiorly.
Yes.
Also you can see the exiting route, the route above it.
Yes.
ठीक है, सब particularly वो dye उधर जा रही है, and there is a very small amount of dye going towards the S1.
Right. We can see that.
Yeah, dye. मेरे को थोड़ा सेंसर के डाइल्यूटेड ज्यादा अमाउंट चाहिए रहेगा. ये हाइट बढ़ा लीजिए और ऊपर कीजिए. थैंक यू. शूट. ओके, नाउ अभी शूट करिए जरा. शूट करिए. See, you can see some dye flowing below the needle towards the root.
Yes.
The S1 root. ठीक है?
Yes, we can appreciate
Yeah.
it.
And just see that there is no flow towards the right side. Show
Right.
please. ये देख रहे हो रूट के लिए नीचे जा रहा है.
हाँ.
So the same thing, like giving multiple blocks, or you can position your needle properly to sort of give and target various routes. Now I'm just giving the ये sensor कितना हाँ Alexa 8 है, can you dilute it? Thank you. Shoot please. Okay. Now you see the S1 route, the dye has gone. So if the dye has gone down, this patient, again sense organ, this patient should have transient relief.
Right.
And at times, so there's a rule of 30 which I, counsel the patient about, that 30% patients will have long-term relief, 30% patients would have short-term relief, and another 30% may not have any relief at all. So they are sort of mentally prepared for what they are getting into.
Right, right. Any questions at this point? Thank you, Ashish. We'll shift to next OT.
Yeah, thank you.
Okay, thank you, Ashish. Anuj, OT1 लगा दें.
But the
Anuj, OT1. Yes, sir, OT1.
fasten the key. Shoot kariye please. I am perhaps I'm more drug.
Avoid.
You know, so that's a good question.
With this philosophy in mind, this
The Harbour, actually this society is a brainchild of
Almost सही जा रहा हूं मतलब therapeutic steroid. Epidural block. I'll just discuss what. Okay. Giving multiple. If you wish to, you can.
Dr. Ashish. Dr. Ashish.
Yeah. Hi.
हाँ.
ऐसा है हाँ, लगाओ Hello.
Yes, Ashish.
Yeah, hi, Deepak. So we are taking up this patient who has low back pain with spread to both the lower limbs, left more than right. And there's an element of claudication as well.
Right.
So if you can show this, there is ligamentum flavum hypertrophy at L4-5 level with bilateral lateral recess.
Can you zoom in more?
Zoom कर देंगे. So there is an element of lateral recess, again left more than right.
Right.
Okay, and on Sach, here there is quite a thick ligamentum with inferiorly there is compression. Okay, and as far as foraminal stenosis is concerned, just one cut before the where you have the foraminal cut, you have significant stenosis that is seen. So Ramesh is going to do the procedure, and the plan is to do not just interlaminar epidural but also left far lateral transforaminal. Are you there with that?
Yeah, just say that again.
So the plan is that we'll do a interlaminar epidural along with a left foraminal root block.
Left foraminal root block.
Yeah. So if you look here, ये यहाँ दिखाएंगे, there is again an extraforaminal component.
Yes, we can.
Which is quite significant.
Yes.
On the left. So that is why we are taking a far lateral approach for the transforaminal block, and we'll give a epidural shot as well.
Phylum, can you show Ashish? Dr. Mahapatra wants you to.
Phylum I can show. Here you can see the phylum tail. Not very clearly seen here, but here this, then this cut, then in here.
Right.
This is the phylum going in. Here.
Conus, can you show?
Yeah, why not? Conus is ending somewhere around this. G12, L1 pe it is ending here.
Correct. Yes, sir.
Yeah.
So, Dr. Ashish.
Yeah.
So, you said this patient had, because he's got a lateral recess stenosis on the left side.
More on the left, yeah.
You plan to do a transforaminal root block.
Yeah.
Which will be a pure just for that, specifically for that root.
For that specific root.
So it will be a little extra foraminal you're trying
to do exactly, I mean, Ramesh would be doing exactly the same thing that we did for the first case.
And, okay.
And then, ideally, even if we do interlaminar epidural in this case and observe, that should be more than enough. But we are in the interest, we are doing not just interlaminar epidural, but also far lateral.
Okay.
Okay. So, we are marking.
Right.
Marker pen, please.
So, normally, Ashish.
Yeah.
For these patients, when you are doing in your OT, in your OR setup there in Jabalpur, what is the monitoring you set up, and what is the what are the number of people you require for this?
Number of people, huh?
People means technician.
Okay, so we'll require one anesthesia nurse.
Right.
We'll require a CM technician.
Right.
And one scrub nurse. That's about it.
And monitoring, what monitoring?
So we do, so the standard monitoring, we'll have a pulse, BP, ECG,
right,
monitoring going on.
Sir,
this is a lumbar canal stenosis, or the central canal stenosis with bilateral root compression.
Yeah.
So how effective is an epidural or any kind of drug going to be in this case? Because here the compromise is on the blood supply to the nerve root because of compression. So how effective is the medicines what you're going to put in going to work?
Yeah. So basically, we have a level 4 evidence as far as targeted epidural is concerned for lateral recess. So the difference to the extent is that for radicular pain secondary to disc, we have level 1 evidence, which is the best evidence you can have. Whereas for a lateral recess, you have just a level 4 evidence.
All right.
So, some retrospective studies demonstrating and truly not a great consensus.
Okay, sir.
Yeah.
So in this, we are first trying to get that flat parallax.
Yeah, we have removed so the end plates are absolutely parallel. थोड़ा सा ऊपर ले जाइए और. And in this patient, if नहीं, sorry, ऐसे ही बस सिर की तरफ ले जाइए. And can you show it here? आप यहाँ दिखा सकते हैं. So if you see here, there is sort of a ऊपर ले जाइए. There is a reversal of the Siam position to get the parallax. So generally the receiver is tilted towards the head, but in this patient we have to tilt it opposite. So what I'm trying to emphasize is you need to square each level rather than having preconceived fixed angles.
Correct.
हाँ दिखाइए, थोड़ा नीचे ले जाइए. नहीं, ये इसको ऐसे ही रहने दीजिए, बस ये नीचे ले जाओ. हाँ, शूट प्लीज. मिड लाइन, नीचे नीचे नीचे, कम डाउन. Shoot please. Yeah, this is the right point. So one is here. Now lateral ले लीजिए. हाँ, because interlaminar में मतलब generally laminar space नीचे रहता है. Okay, lateral please, and remove this tilt. चलो, who's scrubbing? तू scrub करना, फटाफट करते हैं. You scrub ना? Okay. So let's show the lateral. So नहीं, lateral इधर. इधर हाँ. So now you want to see. Now we'll mark the facetal hump. Shoot please. Of L4-5 level. Are you there with us, Deepak?
Yes, okay. We are looking at it.
So what do you want to do, Ramesh? Siam नीचे ले जाइए.
We need to go a little more inferiorly, I think.
Exactly. बढ़िया. और नीचे ले जाइए Siam. Okay, shoot please.
Go superior.
Shoot.
Yes.
Reasonably good, but you can go still lower down. Yeah, shoot. Yeah, this is the perfect place. So let's mark this. Shoot. Okay, local please. आप scrub कर लो. मुझे दे दो. I'll paint. ये साफ कर रहे हैं please. So till Ramesh is scrubbing, if there are any doubts, questions, I'll be more than happy to answer.
I think we have learnt a lot. No, I think doubts will always remain, but getting cleared.
Scrub. Drape please.
Just I will ask him, let him answer. Ashish,
yes.
there's a question from the audience that when should we consider the epidural block
and when should we consider transforaminal block?
Okay, so results of transforaminal blocks are better, especially for, see, idea is you need to spread the drug to the area of pathology. If your patient has exclusively a one-sided symptom, obviously you don't want to go on to the opposite side. But if you have, like for instance, central canal stenosis, where you want to put in,
Right.
or when you have bilateral recess and you just want to use one technique, then, or more importantly, when it is a post-operative case, then you can go, because there will be obviously fibrosis, so you can go interlaminar.
Post-operatively, I think we are all clear. There's going to be fibrosis, and adenomyosis can only
Injection
get
लगा रहे हैं.
epidural technique.
बस एक इधर, बस सॉरी, और एक इधर लगेगा आपको. थोड़ा बीटाडीन मिलेगा, बस.
For the transforaminal needle you have, is it commercially available or?
It is very easily available now. Previously there was a problem. So हम लोग क्या करते थे? We used to ask the urologist who used to do the nephrostomy and PCNL. They used to use that type of a needle. But now it is being marketed as a transforaminal needle. बहुत आराम से मिल जाता है. The long needle. थोड़ा बीटाडीन, बहुत इजीली. हाँ, थैंक्स. साफ कर रहे हैं. चलो दोनों देखते हुए ड्रेप कर दो.
The high dose of systemic steroid, can it achieve the same result of this?
Yeah, come. Are they asking? Yeah, Deepak, anything? Any question?
No.
Okay.
Yeah, around questions.
One question from the audience. Yes.
The high dose of systemic steroid, can it achieve the same side effect?
Sorry?
Systemic steroid, IV steroid.
Yeah, any difference between systemic steroid versus?
It's local.
No, I mean, what do you want to know?
The same result can it be achieved by high dose of IV steroid instead of this transforaminal local steroid?
Yeah.
Can the same result can be achieved by high dose of systemic steroid?
Yeah, I mean, see, in the past, previously, we have been using steroids, systemic steroids, and even now, for cervical radiculopathy, we do tend to use steroids for the short term. However, it is definitely more effective than the systemic steroid. That is number one. And number two, the side effect profile. Now, adrenal suppression, for example, is extremely low, though it has been reported even with local, but adrenal suppression is very low with a low steroid injection, whereas it is quite high when you give it systemically. Similarly, osteoporosis and other complications of steroids.
Having said that, I think systemic steroids have a role in acute pain. We give a patient all of a dexamethasone or whatever for a short period like 1 week, 2 weeks, and they have a very good response. So I think drugs will always remain the first choice, which could be painkillers like pregabalin or steroids. If they don't work, these are all chronic patients over years, who have not benefiting, and some of them steroids also stop helping after a few days, weeks. Targeted to that nerve, I think, is the key, and what we are trying to show in all this.
बहुत सस्ता. अच्छा, वो मैं बताऊँ तुम्हें. तो let's do a. So वो angle वैसे ही कर दीजिए. So you do it simultaneously. You put both the needles so that the radiology shots are less. Yeah. So what we are planning is first we'll do the transforaminal.
Right.
And Ramesh is starting the case. Okay. Yeah, the bevel is directed upwards.
Okay, Ramesh, we are all watching you. So that you don't get pressurized.
No. Go like this. Straight. No, straight. Just go straight. Yeah, and now go. Because this, the level is almost here. Now go inside. No. Go. Take 5, at least go 5 centimeters inside. Otherwise, अभी नहीं आएगा और जाओ अंदर. हाँ, shoot please. और जाइए. Yeah, on the left. Shoot please. Okay, जाइए. Now, if you see the audience there, this is typically a high iliac crest.
Right.
So, the iliac crest is not just crossing L5, S1, but it is way beyond L4, 5 as well. हाँ, जाइए. Shoot कीजिए. हाँ, good. You'll feel some resistance when you're entering the foramen, or you'll feel bone. Shoot please. नहीं, you've gone too much. और थोड़ा सा ये पैरालेक्स भी इसको थोड़ा सा सीधा करिए. थोड़ा सीधा करिए. हाँ, बस. शूट करिए. Yeah, this is better. Okay. You have to go superior, huh? Go a little superior. No, come out. Otherwise you won't be able to place it. Huh? Go. Go. Yeah, just wait here. Now let's not take up the other procedure. Let's do a lateral first. Yeah, we are in the foramen. Yeah, AP.
Ashish, and this the tip looks to be superior. The bevel is that just the view we are looking?
No, you are correct. इसको rotate कर लीजिए. Rotate कर लीजिए. Yeah, so it is not superior. It was rather directed towards the right side.
Okay.
So caudally. Yeah. Shoot करिए, देखें कहाँ है. So you are outside. Okay. So now I'll tell you a trick. You hold where it is entering. So under no circumstances will you take on the lateral profile. You will not allow the needle to go more than this, because otherwise you will penetrate the dura on AP. You understood? When you are going inside the foramen, you hold the needle at the skin level. So once you are pushing it on a lateral, you cannot go beyond this. ठीक है, चलिए. Pull it out about 2 inches further. Yeah, and now take the bevel down, lift the needle up, lift it up. Now go in, go. No, bevel pointing up. Yeah, now go. हाँ, शूट करिए, एक बार दिखाइए. Your hand is coming. You'll have to remove your hand. ये भी. हाँ. Okay, shoot. Still again pull out. Bring your hand here. Don't take it there. Go up, further up. Now go. Go. That is iliac crest. So, yeah, shoot. But you won't be able to see the crest here. So you'll have to do a AP for that. But anyway, एक AP shot लीजिए. Yeah. But good now. Yeah. So we are again doing AP. टिल्ट वैसे ही कर दीजिए. हाँ. Now shoot. Now take it nappy, but it has to go down because you are absolutely parallel. So the needle has to go down. हाँ. चलो कर. Are you hitting the bone? हाँ. So that means, yeah, no, you'll have to come out, inject the local idhar, and then go like that. Same, yeah, come out. Yeah, come completely. Come out. Go above. Yeah, local. And I'll also come. Can I get sterilium, please? Thanks, bro. Sister, I need a gown. और दे दीजिएगा please. Yeah, okay. Go in. हाँ जाओ ना. चलो. Thanks, sister. Sorry. Yeah. Siyam, बाहर लीजिए. हाँ, perfect. Keep going. But no, take your hand like this. Now go. Yeah, go. Keep going. Down. हाँ, चलो. Shoot, please. Yes, good. Go down. Shoot, please. Excellent. Go down. Go inside. Shoot. Perfect. Now let's do a AP. So here, friends, we are the iliac crest was obstructing. We have just entered a little higher up.
Right. So you made a new entry point?
Yeah, we made a new entry point.
Okay.
Okay, shoot please. इसको सेव कर लीजिएगा. Oh, beautiful. So this is a very good location because it is towards the anterior side.
Right.
Okay.
Right.
So this is a good location. Now we have of the theca in the anterior portion of the neural foramen towards the disc. Okay, that is a very good location. Now AP कर देंगे फिर से. चलो, put the dye now. You understood? Iliac crest, we went above and directed downwards. So at the AP mein, it is always the lower part, lower end plate of the upper vertebra. Yeah, we करेंगे ना shoot. Shoot please. Die please, sister. Yeah. I think with the stillet you can push a little more inside. थोड़ा और. Yeah, so on AP, it is always this inferior end plate where you target. So you will never sort of touch the nerve, neither the exiting nor the traversing route. Because this is the Camden's triangle. You are in the Camden's triangle. So it is the safe zone. You can still go inferior to it. Not an issue. Okay, just a little bit. Shoot, please. Yeah, great.
So are we touching the bone now?
No. See, bone is away.
Right, understood.
Yeah, because we are in the foramen.
You are inside the foramen.
Foramen.
Okay.
Yeah. So dye, please. Yeah, dull. Just put 0.2, 0.3 cc to begin with. Very limited. So that if we are not in the right place, we don't sort of blur the, so image will become black. Yeah, shoot kar. Shoot please. नहीं अभी गया नहीं है, डाई पहुंची नहीं है. डालो. Yeah, this is the exiting route. ठीक है, your exiting route. You can still go a little more inside. You will.
Okay.
Shoot please. Yeah, अभी तुम और थोड़ा अंदर जा सकते हो. Shoot करिए. Yeah. Now. Shoot please. So now you can see the root.
Yes.
And inferiorly there is no spread. There is very poor spread. Chalo, drug please.
Can we have a lateral view also?
Yeah, why not? Lateral ले ली. एक मिनट पहले हाँ चलो lateral दिखा दो. Okay. 2 point. So this is 0.25, right? Sensor keen है ना sister? 0.25 है ना?
Sir, दोनों टीम में किसी
Yeah, but the concentration you have taken was 0.25, right?
इसमें
Okay.
रजमीना कर रहे हैं OT-1 में और ये OT-2 में.
Okay. Shoot. Okay, so you can see the root, na? Can you see the root here? Deepak?
Yes, we
So the root is going ऐसे anteriorly जा रहा है and you are bang inside the foramen which you have confirmed on AP and lateral.
Yes, beautifully seen. So now you're going to do the same solumet, this thing.
Dexa. I use Dexa. Shoot please. Okay, ठीक है. AP कर लो तो AP में और दिख जाएगा. Yeah. We'll put just half of it. Tilt कर लीजिए. Yeah, shoot now. Okay. ठीक है, Deepak?
Yes.
Okay.
Very nice.
Okay. So now we'll finish this one and he'll be doing a small interlaminer as well. Still it please. The midline interlaminer, sorry. हाँ, AP में वो देख लो, आपने लोकल लगाया हुआ है. So no, the best thing is you do it like this, so that radiation wise your hand is safe. जितना. Shoot please.
हाँ तो 2 मिनट लगते हैं उसको में. क्यों? हाँ तो दूर जाके बोलो करें.
Okay, बस. Now you need the feel. डालो अंदर.
खाली करना है.
हाँ.
सारे लोग बैठ रहे हैं.
डालो.
क्या करना चाहिए? हाँ बिल्कुल अर्जेंटली बंद करो उसको.
डालो.
हाँ कल करेंगे.
और डालो. देखो. बोन आया. हाँ. ऐसा रफ सा वो आएगा. एक मिनट बताता हूँ फिर मैं बाहर निकाल दूँ. हाँ, अभी करो. नहीं ना. हाँ, अब डालिए. So now we are doing interlaminer. He is trying to figure out loss of resistance.
Right.
Okay. Now also wait Ramesh. Unlike in cervical here lateral कर दीजिए. You should do this under lateral because you are very sure that you will not damage the theca.
Yes.
Instead of AP you can very well go laterally. Yes, yes. हाँ ठीक है, कर लो नीचे तो. Okay. Good. What I'll suggest is just go a little like this. A shot lena please. Yeah, this is better. Go. मतलब थोड़ा higher up. Now go inside. You should get that feel. It's called a typical gritty feel. Higher? Good. And then sudden give way, you will have sudden give way. So he is checking loss of resistance and there is quite a bit of resistance, so he hasn't penetrated.
Okay.
बोन आ गया तो ऊपर ले लें अपन थोड़ा सा. हाँ थोड़ा सा. ठीक है. हाँ तो शॉट ले लीजिए. Yeah, but the interlaminar space is always a little lower to the disc space. So the other possibility is you are hitting the opposite side lamina. You might have gone a little on the left, on the right. Yeah. So you have to remain straight. Short please. You're there itself. हाँ अभी नहीं बस शूट लीजिए. हाँ करते हैं. Yes, not the spinous. Spinous process is gone. हाँ वो हो सकता है. हाँ बस sorry.
That is the wincing you were talking about?
No. I just tried to pull out because we were not at the right level. हाँ एक मिनट शूट करनी है. हम कहाँ पर हैं देखें. So we are right there. अब एक बार AP कर लो. हम we may be on either side touching the lamina. AP में फिर से एंगल कर लीजिएगा थोड़ा सा.
Actually, maybe we have a puncture or individual lateral position. Feeling good. Can you believe in that? What you know, the arm picture, they don't have very well. Understanding the arm anatomy or lateral, I think do it. Seeing the picture, yeah, they are not more toward the right side. Right. They are go straight. So angle like this and go straight. You should be able to go straight. So, small basic question. What will be the positioning in this, the prone position, whether on a Wilson frame or small bolsters? What will be preferred for epidural or for a knee? Is there any change in positioning?
I think there is a question for positioning of these patients. Is there a difference between epidural and normal transforaminal in terms of?
Yes. In epidural, you generally tend to push a sort of a pillow under the abdomen, whereas in transforaminal, you really don't require, because already the space is 2.5 centimeter wide.
Okay.
So there is
Here, because of the interlaminar, you open a bit with some amount of flexion, as we do for discectomy. So you just put it on monitor of the patient, monitor with the tend to, because the patient is on the monitor and you are not very worried about the venous congestion. So you just push it under the underwater.
Can Wilson frame be helpful in this?
If the patient is conscious, we will not allow.
No, Wilson frame, until unless it is a radiolucent frame. Otherwise, because you need epilateral, तो problem हो सकता है.
And conscious patient.
Yes.
Another question is image guidance, neuronavigation, any role?
You have answered it yourself. Should please. तो अब lateral कर लो.
Yes.
Other side, yeah. So best is to use the stillet. ठीक है. चलो मैं देखता हूँ. करो. हाँ, ठीक है. छोड़ना. अब अभी कुछ मत करना. हाँ. Inside, okay. Loss of resistance. But it is too up. We don't really want that up. दिखा. This is a good place. हाँ. दिखा.
So you're inside epidural?
Just about. Not yet. And उस समय भी I don't think so we were inside. बस कुछ sponge please or gauze piece please. Thank you. बस कुछ नहीं कर रहे हैं. ज्यादा ऊपर आ रहा है. पर रमेश बोन है उधर.
With this case, we should be 206.
उसका क्या महेंद्र वाला का
2 बज गया, वो अभी सर अभी कैसे जाऊंगा?
हाँ
फोन है दिखा
होना
नहीं, this is too high.
कल
AP कर लो.
खा दिया तुमने नहीं वो तो है ही है खा लिया अब खाली है
AP शॉट ले लो और एंगल ले लो.
तो अभी
अच्छा दिखाना प्लीज ताकि हम सही जाएं. दिखाइए प्लीज. ओके गुड. दिखाइए. दिखाइए. ओके lateral. Lateral. Very limited space है इधर. Can't be sure. Let's see. Check करते. Shoot please. कम हाइट कम करो आप. Yeah.
Ashish, what do you think where we are?
Yeah. I'll just discuss. We have sort of repositioned. We have got it into the center. Still. Yeah, now I got it. Shoot, please. Yeah, now I've got it. Sister, die दे देंगे. So, bang in the midline. Yeah, we were touching it on one side. Shoot, please. Yeah, okay, ठीक है. Okay, shoot, please. Drug. So Deepak, now we are in the epidural space.
Yes, very nice.
Yeah. एक AP shot भी लेंगे. Just want to, it is always good to see the spread. So on both AP and lateral. Yeah, दे दीजिए. नहीं, I'll be more. Tilt करके लीजिएगा shot. बस. Yes. You're hitting it. Yeah. थोड़ा सा डाय देना. Shoot. Yeah. Now you can see exiting epidural as well as traversing. Deepak, can you appreciate?
Yes, can you point them out?
Yeah, why not?
We can see the exiting on the left side.
Yeah. So this is the.
Your head is coming, Ashish.
Oh, sorry.
हाँ.
So this would be the exiting route here.
Right.
So the route must be just above to this die.
Correct.
And then this would be the traversing for this level.
Okay.
And this is the central epidural steroid. There is some amount of spill on this ipsilateral side as well, if you see this strand.
Yes.
And then the epidural is flowing down. Okay?
Nice, very nicely.
Yeah. Put the drug. Yeah. Around, how much is that? And how much ml? So put 1 and then we put steroid and then another 0.5 ml. 4 mg.
Thank you, Ashish.
Thanks, Deepak.
Any questions this time? We'll move to the other OT. Let's see if we managed to start the last case of the day. OT1.
हेलो
Hello.
सर OT-1 में केस फिनिश हो गया है, नेक्स्ट केस अभी आ रहा है.
आ रहा है. So we can discuss it by the and shift करो OT last case discuss कर लें. Panchadar Dura, do you continue with the procedure with the withdrawing the needle, or you do at a higher level, or what is the plan?
Okay, so see, basically targeted blocks, you tend to sort of avoid, you can bring the patient back again, and especially the worst scenario would be dye going inside the intrathecal space. So you have to take a call. If the dye is not gone and just puncture, you can proceed, but I would advise that you can just wait for a day and then take the procedure the next day.
Okay, understood. Thank you.
Thanks.
Shift to OT1.
here because she's not having pain in
at a line which is parallel to the greater occipital protuberance.
Yes. So you see here there is this nuchal line.
Yes,
Inferior nuchal line. There will be a depression. You will feel that, and when we press, the direction of your pressure is mostly 45 degrees, and that's where the patient feels severe pain.
Okay.
Because the idea is always to reproduce a pain, any patient's pain. So, and then we did it nicely. I have also done a video recording of that, which we can show. But
so today, Dr. Mahendra, you will be showing in prone position, or you can?
no, sitting position is
Sitting
okay.
only.
Yeah. Sitting is okay. We don't need, so just a chair is required. Basically, it's not even a theater procedure.
Okay.
And that's why, the beauty of these headache blocks is that you can do it you can do many cases in a single day. Patient gets a fantastic relief and a long-term relief. And I've got so many happy patients now. So, and you can do it all within 10-15 minutes. So,
Very
very rewarding procedures.
Correct.
Can we make a sit there quickly? I wish we had more migraine cases where then, because now I don't want to push several points and they are not very difficult. The thing is that, for a neurosurgeon's caliber, these cases are too simple cases and we don't want to do them.
No, definitely. I think this is the first time you're having this workshop, so we try to get different variety of. Next time we'll have more cases for you.
Hospital nerve is one of the most common trigger points, and this trigger point in her case can be handled later on if we don't know right now what kind of pain relief she will get, what duration, because there is some problem deep inside. Then we can either go for a neurolysis or we can go for ganglionotomy or ganglionectomy at C2.
And what do you inject?
So injected, we are using usually Xylocaine 2%, but Xylocaine with adrenaline usually is very acidic. So I use for, say, if I am using 10 ml, 10 cc, though she doesn't require, she requires only 3 ml. So 9:1 ratio, we also use soda bicarb, 8.5%. So in this case, I would be using maybe 3 cc of Xylocaine, 0.5 to 1 cc of bupivacaine, and Xylocard and steroid also. Kenacort or triamcinolone, whatever.
Sorry, can you repeat? So for this case, you will be 3 ml of
3 ml Xylocaine.
3 ml Xylocaine.
0.5 cc of bupivacaine.
Bupivacaine.
Yeah. Then 0.5 cc of soda bicarb.
0.5 cc of soda bicarb.
Triamcinolone.
And triamcinolone.
Yeah.
Okay. All these 4 drugs you mix together.
Yeah, we mix together.
So logic for using soda bicarb is to make it alkaline.
No, if anyone has injected himself Xylocaine, any experience? I did once for my viral wart and I got such a severe pain, and then I researched about it. If you slightly warm Xylocaine, then it becomes painless. That's one thing. Second thing is you can mix soda bicarb, so it neutralizes the severely acidic Xylocaine with epinephrine. And there are papers for that.
Okay.
Yeah. Okay, so let me prepare.
Sure.
Can we have gloves? Okay. आराम से हो आप, इतना कुछ लगाने की जरूरत नहीं थी वैसे. थोड़ा सा नीचे करेंगे सिर को. कितना नीचे कर सकते हैं? Gloves? Yeah. What about mixing? Just prepare.
So Mahendra, you already prepared your this cocktail?
No, we have not. Because you started ragging me.
No. Some resident can start preparing it.
Yeah, I just said. So just like 5 cc. We don't need. I'll need spirit swab also. Do we have a marker pen? Marker pen. Not required. Not required.
Mahendra, there's a comment in the group that few studies use ascorbic acid. Are you aware?
No.
No.
But soda is anyways handily available.
Yes, that is true.
Yeah. So where's the marker pen?
So this you are marking the external occipital
Yeah, yeah.
And we are doing on the left side.
On the left side.
Right.
Left side ये पेन है आपका?
Always better to reconfirm.
So in Kenya, usually we are lucky because most of the patients do not have enough hair. So if we,
The second point is mastoid, right?
yeah, second point is mastoid. So if you see here, this is coming to be 1/3.
Right.
But then there may be anatomical variations, and this is the 2/3. So this point and this point, yeah.
So
are you able to see that?
Yes, at the level of the superior nuchal line you will make.
Yeah, yeah. So I'll press.
अच्छा, you will press and see the trigger point.
यही है दर्द. आप बताओ कहाँ पर दर्द हो रहा है? जोर से बोलना. यही हो रहा है ना? और ये दर्द आपका आगे आंख में भी जा रहा है. कभी कभी आपने बोला कि आंख में भी जाता है पेन. कभी कभी जाता है ना? अभी दबा रहा हूं तो कान में अभी नहीं हो रहा, नीचे हो रहा था. एग्जाम जैसा हो गया. थोड़ी देर पहले भी हो रहा था. ठीक है. और अभी आपने बोला कि आपको 7 का वो है ना? अभी आपको जो मैंने स्केल बताया था उसमें आपको 10 में से 7 हो रहा है अभी पेन. ठीक है. स्पिरिट स्वैप. Yeah, did we make a mix? Xylocard है 3 cc ले लीजिए. एक सेपरेट प्रिपेयर करना है Xylocard ओनली. हाँ 2 cc and 2 cc distilled water. So one of the peripheral block which I was saying about a C6 is because in the dorsal root ganglion there are pseudo bipolar neurons. Pseudo bipolar neurons.
Right.
And so if patient has got pain because of a toxic annular tear or because of some compression, the pain is going centrally and is also coming peripherally, which is perceived as pain in the local dermatome. If you block those peripheral nerve endings, it has got a soothing effect in the central nervous system also because of this nature of pseudo bipolar neurons.
Okay.
So it gives a wonderful relief to the patients even with symptomatic disc compression, particularly if you are seeing something called as chemical neuritis, which comes because of toxic annular tears, and the nucleus is releasing toxic chemicals like interleukins. Yeah, we are ready. This is what I wanted. Yeah. Do we have triamcinolone also, or even dexamethasone can do? Any steroid will be okay. Triamcinolone sometimes just becomes. We are using triamcinolone though. You can use that.
So with the peripheral block with significant operable disc, I have found patients having a pain relief from few days to up to 6 months.
Okay.
Yeah. Recently, I will show you a video of a patient who I did about 6 months back. She was not even able to walk, but once we did that, she has all gone for Hajj. And she says these are magic injections because I am doing injections in the ankle region, and patient is having, she becomes pain free in the low back, and the radiating pain also goes.
Nice, nice.
Are we ready?
So Mahendra, what are we waiting for here right now?
You're waiting with the drug.
It's a drug combination.
This is what? इसको भी दूर रखो. Only this. Triamcinolone. इसी में mix करो. इसी में mix करो. Triamcinolone दे दो.
So your thumb is actually the superior nuchal line, or at the trigger point.
Just, yeah, at the trigger point. So I would only loosely follow the landmarks here, because most important thing is always you can have a third occipital nerve, you can have a greater occipital nerve, lateral occipital nerve. So all of these things we can find, but then the trigger sometimes can also be myofascial. So we have to know which is the trigger point. In chronic cases of headache, usually because there is a free anastomosis between the lateral, the frontal and the posterior nerves, patient gets pain almost everywhere. So I have got headache patients, 24 years of daily headache, devastated life only because of headache. And we were able to give her 80% relief only with the first set of injection. But gradually they come down to the trigger point. So in such chronic cases, if you are doing an injection and you are doing a block, then initially we tell them that you have to now notice all these trigger points you know. Now you have to tell me when headache starts, from where does it start? Yeah, thank you.
Okay.
Okay. The bevel should always face the scale, yeah? So we know how much we inject. यहीं दर्द है ना आपको? है ना मीना जी? यहीं दर्द है ना आपको? ये सही जगह है? क्या भी दर्द चला गया? चला गया? एम्स की कृपा है. फिर से चेक कर लेते हैं. ये वाला, ये वाला. स्पिरिट अगेन. लगेगा. So I'll go to about, we'll aspirate about would like to infiltrate the subcutaneous space, and I can feel a bulge going around.
So do you touch the bone and then give it, or you just come given this?
No. I am just putting my finger on the trigger point so I don't lose it.
No, what I mean to say is that needle where you're injecting,
Yeah.
does it go right up to the bone?
Yeah, you can go to that. You go all the way to the bone, then you come back side.
Right.
Yeah. We will wait for a while. Now that.
In her case, there was only one trigger point, right?
Yeah, only one trigger point. Yeah, आपके दर्द को वहां पे आराम मिल रहा है? अभी कुछ फर्क पड़ रहा है कि दर्द ही नहीं हो रहा है? एक आपको यहाँ पर लगाएंगे, ठीक है? So you go where the two metatarsals meet, you go more on the index finger side.
Right.
Okay.
Right.
Yeah.
How deep?
But here, you have to go around up to 0.75 or half of the needle, because you have to go almost to the metatarsal.
Again, you touch bone here? No.
No, here we don't touch bone. And here it has to be diluted xylocaine.
Can you again just say the entry point?
It's very rough. There is no fixed point here. You just go there, because the idea is wherever the two metatarsals meet, on the medial side of the second metatarsal, you have to go here.
Okay. And here you are just giving pure xylocaine.
Yeah, diluted xylocaine, not our own xylocaine, but diluted xylocaine does the good job here. Because right now patient is in a certain psyche that she anyways feel just because of touch that there is.
Sorry?
She says that anyways even before injection she was pain free.
She had got relief.
Yeah.
That's a sign of a good doctor. Any questions?
Yeah.
For occipital nerve block and peripheral nerve block?
Although I am going to cover into my presentation,
yes,
which is
we
at
look
4, so
forward to
we are
that.
going at length with the
Yes.
headache blocks, even the peripheral blocks.
Thank you, Dr. Mahendra. That was excellent. Thank you so much. तो OT बंद करवा दो.
कैसा लग रहा है?
हाँ. Yours is first. You're loaded है. Schedule.
SI joint blocks for demonstrations.
SI joint to maybe tomorrow. I'm not sure. I will check and let you know.
Right.
Do we have Greja Prasad here? No. Dr. Mahapatra is here? No. So, I will request, we have some very interesting talks. I would request the speakers to please limit themselves to the time allotted. The first talk will be by Dr. Debesh Bhoi, which will be on transforaminal epidural steroid injection. Okay, good afternoon. Thank you very much for the invitation. Thank you very much, Dr. Deepak sir, for the introduction. So my topic given to me is regarding the transforaminal epidural steroid injection.
And since morning, I think we've already seen the many injections, that is the transforaminal epidural steroid injections, facet injection and all. So we'll just discuss about the technique and how basically executing this transforaminal injections in a patient with a back pain or a disc herniation. So if you consider, obviously it is the lumbar radicular pain or radiculopathy is very commonly encountered complaint, and most of the thing that the patient goes to a neurosurgeon, a neurologist, a orthopedician, pain physician. So the patient's load, if we say the low back leg incidence is very high. So obviously somehow the patient has multiple types of pathology that leads to a low back leg. And one of the things is that the herniated disc, or because of the foraminal stenosis, is one of the most common cause that lead to basically inflammation or irritation of the spinal nerves or the dorsal root ganglia. So the disc herniation basically causes something, changes in that area that causes pain. So why there is pain basically? Is it only the compression alone that does cause the pain or something else? Because if you've seen, suppose a surgery has gone, the patient normally suppose disc surgery and all, in the post-operative most of the numbness or something is there, not exactly the pain. So in this disc herniation basically, it's not only the compression, it's only the inflammatory reaction that is going on around the nerve roots. So the highly inflammatory material that is present in the nucleus pulposus, basically with the first layer is A2 or nitric oxide metal proteases. So when there is disc is disrupted, this material that is just come out of there and deposited around the neural structures, and they just elicit a neural or chemical inflammation that leads to pain or intense pain. And if it is going along the nerve root, that becomes a radicular pain in the patients. Intramyomal corticosteroid, the patient when they go for a conservative treatment, then obviously the patient is offered the interlaminar corticosteroid, and if it's an interlaminar corticosteroid means the steroid is deposited in the dorsal part of the epidural space, or the posterior part. That sometimes fails to reach the segmental nerve radius, because if you see the disc is the more ventrally, and obviously the herniation that is coming and involving, that is the more ventral part. So if the drug is deposited in the posterior part, sometimes the drug may not reach to the target area. And if the nerve is getting irritated, it's ideal to deposit the drug close to the nerve. So that's why, in this case, the transforaminal corticosteroid injection is done, so that the drug should be very much close to the involved nerve root. And so obviously the indication is any pain that is radicular in origin, it's from the irritations and the inflammation of the DRG and other neural structures. If you see the irritation, once there is inflammation in this, in the foraminal area, you can see the nerve root is getting affected, and this is the area that basically we want our drug to reach. So if you see the drug is, this material is herniated out from here, and it involves a chemical inflammation at this area. So our motto is to reach the drug at this part. Even if you see the lumbar epidural or this disc, in the case of disc herniation also is a very good level of evidence in case of transforaminal injection in such cases as a conservative treatment, the first before at least in the surgery. In MRI also you can see before, so you can see the different hernial disc is bulges there involving the transversing root and exiting nerve root. You can see there's a disc bulges there, and obviously this is the area where the DRG is getting compressed sometimes. In this case, it is just the disc is bulged. So that means even if you see it is not causing a mechanical compression, but still the disc has that's hydration that's lost. That means the normal disc, if you see the annual purposes is white, but in this case it is black. That means the disc desiccation and the disc is bulged. So that causes inflammation. So even if there is the significant compression is not there, but still there is a chemical inflammation that is irritating the nerve and the DRG. So the traversing roots is also in this case free, but that is the area that the lateral recess and exiting root area that the disc material can involve, and that causes inflammation. In this case, if you see in the left side, you can see a significant disc bulge is there, disc herniation is there, just irritating the nerve. That if you, in this case, if you are finding such cases in my pain clinic, obviously we can post this patient as transforaminal steroid injection. If you see it may not be a significant caudal compression or thecal compressions, that is the patient doesn't have any, but the pain is very severe. So the patient in this area, the fit is the criteria that you might go for a transforaminal injection, and patient will very good relief in this case. So before patient will have subsequently cauda or some motor involvement. So let us look at the technical part basically. How basically you can execute or reach this part, if you say a middle or in this case. So if you see the foraminal part, if you see from lateral side, you can see these are the formed by the pedicle, above one, the upper one, and the medial one, down one in this case. Then the posterior you can see the supraarticular process and infraarticular process above and superior below. And also in the front side you can see the lower body and the disc in the front. This is the area you can see your nerves exiting route is there, and this part is occupied, or if the disc is herniating, that part is involved, and that is where you are going to reach. So what is the content of the this foramen basically? It's not only the root and this there. Along with the root, it's also there the vein, the fat tissue is there, and the artery or some the reticular arteries are also there in this case. That's why sometimes it is very, you have to be very cautious when giving a transforaminal injection. If you have to be very careful not to injure any artery, or if you are using a steroid, a particular steroid, make sure the drug should not go enter into your artery or clogging your blood vessels. So next is how to proceed in this case. Any procedure, so obviously the informed consent is very important in the patient who is undergoing the transforaminal injection, because the injection or needle is very close to the nerve. So obviously the patient should be aware of that. There might be nerve injury, sometimes patient has pain. So you are putting it really close enough, suppose the patient moves or something, the inadvertent needle is inside, then nerve injuries might occur. You are depositing steroids. So there are so many steroids are available. There is a particulate, non-particulate. So there are also complications related to the steroid also. Obviously then infection is another chance that if you are not take the proper sepsis. The checklist must be, obviously you can take the history of allergy, because you are also using a local anesthetic for the skin infiltration, for also the drug. Coagulation studies sometimes very important if the patient is having some blood thinners like antiplatelet or anticoagulant. In that case, you have to strictly follow the guidelines as per your American Society of Regional Anesthesia or pain intervention, and also there is single society that have given the guidelines that the drug should be stopped as per your standard guideline. In some cases, the patient has suppose cardiac origin and taking some medication, then obviously you take the physician opinion also regarding the stoppage of the medications in those cases. Is there any contraindication? Yes, obviously the uncooperative patient, sometimes it's difficult, you might abandon if this patient is not cooperative properly, because normally you don't go for a general anesthesia for such injections. Bleeding diathesis, coagulation or abnormalities, local site infections. There might be some of the relative contraindications, sometimes technically difficulty if the patient has had severe degenerative disease or a large disc displacement, or sometimes a facet hypertrophy. So the needle steering might be sometimes difficult in those cases. So let's come to the fluoroanatomy. Obviously, I think the injection has been very well described by Dr. Ashish and I think the sir. So let us again just revise this how fluoroanatomy that normally in this case we see for or look for. So first thing that we are going to do of step one is the true AP view of the total body. And the lower, and in this case transfer in the injections we do a squaring of the plate, that is the lower end plate squaring. That means this is the first is the true AP, means that it's maintain the symmetricity, that both the pedicle is equidistant from the midline. That the first, that is true AP we are going to do. Then we are going to look for your inferior end plate squaring. That means it should be, if it is not squared along that, it might be in the oval shape. So you make it a one line so that the inferior end plate is properly square. Then you can look for the circular shadow on the lateral side, the other pedicle, that gives a shadow like this, and obviously very faintly you can see the transverse process. So this is the area that we are going to see for. Now once you do AP view, then subsequent second injection is once you mark the which nerve we are targeting. Depending on that, then you go for ipsilateral oblique. So the same side you are doing now, or the patient is going to have this oblique in this case. So what I am going to see in this case once you do oblique. So in this case, we normally a very good description of the Scotty dog. That means if you make image like this, you can identify basically different structures accordingly if the anatomy is good enough. So if the supraarticular facet can be identified as your ear of the top. Transverse process is a snout, and the eye that normally the Dr. Dureja also described as a medial branch or the medial nerve. Pedicle, you can see that infraarticular facet of the hand, the forelimb, and hind limb is your pars. So this basically we make this image first so that we can identify which type of injection we are going to do it. And the transforaminal injection, the injection area is normally just below the mouth of that area. Now let's come to the ones who identify this, there are the different approaches. So what are the different approaches for the transforaminal injections? If you know, there are normally 3 approaches. There is a safe triangle approach, a supraneural approach, that means the injection is above that, retroneural, and the infraneural or Camden's triangle approach. So if in this case you see, once you do a gaze open like this and the nerve root in this foramen, you can see the first is the subpedicle, just below the pedicle, that is above your nerve root, that is the supraneural injections. Second is the retroneural, it's just the middle is just on the posterior side of the nerve, that's the retroneural injections, and the lower one is the retrodiscal or supraneural or infraneural injection. So these are basically 3 approaches we do normally for transforaminal drug deposition in this case. So let's come to the safe triangle. It is a misnomer, it is not really a safe triangle, but still the name per se, how the safe triangle is made, or normally in this case made. If you see in that approach, one line is going to the subpedicular line, the one line parallel line, another line in the lateral border of your pedicle, that is one line, and the hypotenuse angle is formed by the nerve root itself. So this triangle, once it is formed, this is go at this 6 o'clock position of the pedicle, that normally our target point for a transforaminal injection. So once you have scotty duck appearance, we make this triangle and then go just exactly at the 6 o'clock position of this pedicle, that is safe triangle approach in this case. So in this case, basically you are not injuring or try to avoid from the nerve root. That's what is a safe. But this is again, if you are not vigilant, this is the area that the blood vessels are there. So that's why it is not really safe in sometimes if you're not taking precautions in this case. Second is the Camden's triangle. Obviously, it is a infraneural in this case. You can see the disc is there. The medial border is formed by the vertebral end plate and the vertebral border. Then the lower with the over the pedicular line, and there's another your hypotenuse third border is formed by the nerve root itself. So this is basically the same approach you normally would do for your disc injection, something like that. The same exactly this position is done for the disc injection or any disc procedure is done. So that's why this approach sometimes has the risk of entering the disc in these cases. So this in this case this is yes sir. So again, I just regard the safety concern because there are so many blood vessels under your middle arteries there in this case, so that's why it is a little bit risky. And one of these your arterial adenocarcinoma, the radicular anterior radicular middle artery, that's normally if it is injured, that may cause hematoma, or sometimes here the steroid is entered. In this case, that may lead to infarction that is very grave, may lead to paraplegia in such cases. So needle entry, obviously, as I described, look at the 6 o'clock position. You can see the Scotty dog at the just below the head. That's the entry point in this case. And this, once you in the epi view, you can see the needle. Then you confirm your needle in the lateral view. Once in the lateral view, you can see the needle position in the foramen. You can see the needle is exactly in the superior, dorsal superior part of the foramen. That is the if you're doing a safe triangle approach. So once you do that, then you can see. Look for the dye and then look for the dye spread in this case. So the final deposition like that. In case of a Camden's triangle, this is the supraarticular process, and in this case, a middle entry just retrodiscal and just lateral to the supraarticular process in this case. So this is the entry point just right or lateral to the supraarticular process in this case. So here basically we are entering the lower part of the foramen. This is that it is the infraneural, and mostly sometimes if you are doing an infraneural injection, it also involves the traversing routes also. For that, the supraneural is mostly involved in your exiting route. So another again, sometimes you do a vertebral bend, so there is sometimes if there is less space, and some little steering also help in this case. Just hitting the transverse process in the pedicle and just steer towards your foramen. We have to be very careful because sometimes the patient might do jump hitting injection, the immediately you drop because you might be hitting the nerve root in that case. So that to avoid any sort of movement or any case of abuse. Next, the dye spread is very important. Once you finally position, you can after putting the dye, the dye should be spread around the medial border of the pedicle, and if you just look for the volume, how much you need for that seizing of the medulla sin, and also the drug is going to the epidural space. If you give more volume, obviously the epidural space spread will be there. So this is the ideal spread of the drug. So is there any other spread that can be, you have to be careful obviously, because in this case DSA is there, so you can see the around the medial side of the pedicle this drug is spread. There might be some of the adherent spread also, suppose the arterial spread or a venous septic. In this case, if you see the drug is midline to the AP view, like this is the arterial spread. Sometimes if you do an extradural or disc is there in the foramen, that is the actual disc is there, so that might sometimes you can take a picture of like this. That means there is significant disc material that has been extruded in this case, and the dye spread is going to the disc also. So this type of spread sometimes you can see also. Subdural, obviously in this again there is a chance by the subdural dye spread also. In this case the dye is more stick appearance like this in the posterior side. The homogeneous spread, in case of epidural spread there will be air pockets will be there, but in this case it is a homogeneous posterior in this case. This is the intrathecal spread. You can see the intraneural injection has been occurring in this case. You can see the ventral thecal sac in this case like this. Okay, yes. You can say once you depot the drug, might be obviously selection depending on this. This will take some of the very safe because it is a non-particulate steroid in this case. Recovery obviously after recurrence, most if you are using a local anesthetic, most of the patients recover well. If not, then obviously you have to reckon the diagnosis. Here the complication that is very important because the paraplegia has been documented few case reports in this case, but it's not only the particular steroid. Sometimes even the severe disc compression is there. Even slightest transperineal drug deposition might sometimes aggravate the situation, and in this case, even if there is no infarction, this is basically the patient also land up in paraplegia. So they basically have to be careful. So obviously the summary to transfer, this is the, again you can think of this transfer injection before going for surgical intervention as a very good treatment modality in such cases. Thank you. Sorry for that.
I think time is up, so we have no time for question and answer. I think next talk is by Dr. Dureja. Dr. Dureja is go. Yeah. If you finish early, then we'll have a question.
I will. 5 minutes. I've spoken enough now. So can we have the slide, please? Yeah. So I'll be talking about another important pathology, cervical facetal pain, and this is often a underdiagnosed cause of neck pain. I mean, we have a large number of the population who is suffering from this because of injuries or because of other reasons, but generally it is underdiagnosed. And if you have patients with chronic cervical pain, almost 50 to 55% of patients may be suffering from this facetogenic pain. And of course, in our younger population, it is a major source of pain and disability and even socio-economic impact because they are not able to work sitting on a computer or other things. The anatomy, of course, all of you know that this is the joint supplied by nerve from below, nerve from above, as we were discussing. This is the branch from the dorsal ramus, and the joint has a capsule, joint has a synovium, so there is a synovial fluid too. Sometimes when you have a facet arthropathy, you can withdraw fluid, and there is an effusion, and just decompressing the joint gives a fantastic relief to the patients. And if it is persisting, then we knock off the nerves. As you can see, you are doing a radiofrequency ablation of one above and one below. So, of course, I am not going into the detail, but this is the anatomy. That this is a joint from the superior and inferior, like we showed you in the live workshop. It's a synovial joint which has a capsule. So you should not be. The importance of this is that it's a very thin capsule. So intra-articular injections repeated should be avoided because you are disrupting the capsule. So median branch block would be a better option than repeatedly puncturing the capsule and causing injury and making the joint unstable. So it contains the function of these joints is of course flexion and extension, and while limiting the rotation and preventing the vertebra from slipping over each other. The sensory nerve is the medial branch from the dorsal spinous rami. The typical presentation of a cervical facet joint is an axial neck pain. Patient will come and tell you that I get pain in this part of the neck. You ask him, it's radiating down? No, not much radiation, not radiation. Unilateral sometimes, very rarely bilateral. But of course, there is a limitation of extension. He says, as soon as I do this, I get a very sharp pain. And when I rotate my neck, also I get a very sharp pain. If you examine the patient, you may not find much except that if you are right on the facet joint, you may elicit a tenderness. And of course, whiplash injuries, sudden injuries in the car, and various other sports injuries can result in this. So it's an ipsilateral axial neck pain, dull pain, but the sharpness is only on movement. There is a referral pattern too, because the nerve supplies some areas. So I'll show you that C1, C2, C2, C3 can come up right in the ophthalmic, the occipital division of the nerve, and there are C4, C5 can even go up to the scapula. Secondary to trauma, sometimes we do not know, maybe bad posture, using big pillows can also lead to this. Typical morning stiffness, they get up with a very stiff neck, and they are very much worried because in the morning the neck is so stiff that they don't feel like getting up from the bed. And of course, extension and rotation results in more pain, and there are no neurological deficits, absolutely no neurological deficits. So this you can see is a normal facet joint, and this is a diseased facet joint. We have osteoarthritis and various other reasons which could be cause of this degeneration of the facet joint, generally seen in elderly patients, like the arthritis of every joint. You can have misuse arthritis of this joint. Secondary to trauma, sports injuries, whiplash injuries. Secondary to inflammatory conditions, yes, we do get a lot of patients of rheumatoid arthritis and ankylosing spondylitis who keep complaining of pain in the one side of the neck, and that is because of the inflammation of the synovium. So this is more of an inflammatory. So in these conditions, probably an intra-articular injection of steroids would be better off than doing a medial branch block, because this is going to come again and again. And subluxation of facet joints due to spondylolisthesis is also one of the rarer causes. The pathophysiology, of course, the inflamed facet joint, the surrounding muscles go into a spasm, so it's a muscle spasm pain. Hypertrophy over a period of time can itself cause pain. Thickening of the capsule again can result in pain. And then degeneration, osteophyte formation, rubbing against each other, they can also be the cause of pain. So these are some of the pathophysiological factors of cervical facet change. It's often a clinical diagnosis. You may do MRIs, CTs, perhaps CT may give you some clue, or a bone scan can give you some clue, but who is going to get a bone scan for a neck pain? Typically non-radicular, as I mentioned, worse in the morning or during periods of inactivity. So you can see that painful extension and lateral rotation of the neck is generally the provocation for more pain, and if you do the simple test, you will find that the pain aggravates. Now this is what I was talking about the referral pattern, and you may have the pain referred to C2, C3 from the C2, C3 facet joints, C3, C4 side of the neck, the commonest presentation. C4, 5 can even go down to up to the scapula, and C6, C7 facetal pain can go right below the scapula too, and this is the area of C5, C6. So if you clearly take the history, they will tell you that it is referred. Never on the trapezius or never on the shoulder like a radicular pain, but it is basically around the spine, so paraspinal areas where this referral pattern is seen, and by this referral pattern itself you can localize which particular facet joint has been involved. So that's the importance of a good history and good physical examination to come to a diagnosis, so that you confirm it by doing a dorsal branch or the medial branch of this particular. These are some of the morning we had discussed: differential diagnosis, myofascial pain syndrome, cervical radicular pain, cervical disc degeneration, and of course injuries. Clinical diagnosis: MRIs do not give any information unless there is a very severe arthropathy or fluid. Diagnostic medial branch is one of the gold standard approach to diagnose this. A simple test, I think tomorrow maybe we'll try to show you live, and you have to do 2 diagnostic blocks in order to go for a radio frequency at different intervals, and if both the 2 diagnostic blocks are positive, then you go for a radio frequency ablation. So we are now even doing radio frequencies, of course, one regenerative therapies. So if it's like a spondyloarthropathy, you can inject PRP solution into the facet joint, which is a regenerative therapy and really can help these patients. You should be aware of the anatomy. So this is what you get after squaring and these are some of the structures. This is the facet joint, this is the articular pillar which we have to target. This is the place where the dorsal rami would be seen, and you have to target that. So important to see the structures, the facet joint, the lateral mass, the ramina, the spinous process, and this particular the articular pillar is the most important thing when you have to place your needle for radiofrequency ablation. This is a facetal joint injection. As you can see, the spread of the dye in the facet joints, and this is the place where you are going to do a diagnostic. So you right in the middle of the articular pillar, you will place your needle, and remember you have to give very low quantity of local anesthetic. You don't have to give a high volume, one that it spreads to the root, which are very close. The root is just around. So you don't want to call it a root block, because there will be some motor loss and sensory loss, and in any case you will not be able to know whether it is pain relief because of the diagnostic branch or something else. So that is to be avoided. And then you do a radio frequency ablation. This would be the exact position of putting your radio frequency cannula. Do the stimulation as we saw in the morning. We do the stimulation, sensory stimulation up to 0.5 millivolt, 0.5 volt. If you don't get a stimulation in the arm, etc., that is a confirmed position. Motor, you will see the fasciculation in the muscles. And then you can do at different levels. This is the AP view, and this is the lateral view, where you are putting the needles on the middle branches, and then doing a radio frequency ablation. Thank you. Finished in 8 minutes. 7 minutes.
Question now. Now question. Okay. Before you ablation, do you have a small stimulus confirming? No?
Yes. So always sensory and motor both. So sensory will go.
Any monitoring you do, like sensory evoked potential, motor evoked potential, or cardiac monitoring?
No, obviously everything is done, because this is a very sensitive area. Vagus is there. You may have a vagal attack, and also anesthetist and
cardiac monitoring.
Yes.
Any sensory evoked potential?
No, not sensory evoked potential. Only cardiac monitoring.
Any other question? Any other question? Not asking question.
So what is the duration of regeneration of the medial branch?
So that's very variable. Over the years, what we have seen is sometimes the regeneration can take place in 3 months' time. But sometimes even after 5 years, patient comes and I am okay. Today morning I got a call that he's a famous cardiac surgeon in Patna. I did it in 2016. So 7 years he was okay, and he was saying just 3 days back I had a pain, so I think I'll come back for the RF. So 7 years there was no pain.
It's not regeneration of that nerve, it's the other nerve
Maybe.
take over that.
Right.
Actually, when I was in general surgery, Dr. Nandi used to tell, he had published a paper in 75, recurrent nerve to the facet joint in lumbar pain, local pain. And he had published a paper in 75 or something in British Journal Neurosurgery. So still the role is there, right? Dividing the nerve to facet joint, right?
Yes. The surgical division.
Goes to local anesthesia.
No, local anesthesia, of course, but surgically, of course, now with radiofrequency. Yeah, there was not there.
I'm talking 75.
Yeah, I know. I've done phenol injections on the nerve also, but very carefully, because it should not dissipate.
I was in general surgery. Any question? If there is no question, give a big hand to Dr. Reja.
Thank you. Thank you.
It's a great pleasure to have you here. You have contributed to the immensely to the knowledge of the people. Thank you very much.
Thanks.
So one question. So one question, if you
Dr. Mohan, yes. Dr. Mohan, please.
Good afternoon. Thank you, Dr. Raji and organizing team for their kind invitation.
We have not yet started the MD pain medicine or diploma.
So we have started fellowship in pain medicine 4 years back. MD is
But that will involve multiple specialty, from medicine to anesthesia, surgery to pediatrics to gynecology, multi-specialty, nahi? Super specialty, DM.
No, sir, the DM pain medicine has been started in AIMS Rishikesh. I think 4 years back they have started.
Ravi Kumar started.
So we are planning to start in near future, but right now we are doing fellowship in pain
No
medicine.
problem. I just want to know where are we?
Yes, sir. I will be presenting on sacroiliac joint injection, basically fluoroscopy guided. As you know that the sacroiliac joint has a great variability external contours, and most of the time this is auricular in form. It's a C shape in male patients and L shape in female patients, and usually the articular surface extends from the S1 to S3 foramen and sometimes up to S4 also. And as you know, it's a diagonal joint that has some synovial component. And the SI joint itself serves as a major shock absorbing force transducer that is implemented during the weight bearing activity. It's very important joint, one of the largest joint in the body. And coming to a little bit more anatomy, that's a probable form, and it's about 20-degree ventrolateral to the dorsal at S1 level. As you can see this here, it's very difficult to penetrate the needle for SI joint. But this is more or less orientation is surface less oblique. In prone position by posterior approach, one can approach this joint for any injection. And this obliquity is different from person to person, while the proper form remains constant. But and this have very multiple ligaments are there, especially anteriorly and posteriorly. That gives some this enhanced stability by decreasing the friction of SI joint and contribute to the self-locking mechanism. And especially the lower part of the joint, those ligaments they offer proprioceptive feedback with rich plexus articular receptor. This part of the joint is very sensitive and have a number of nerve endings. Coming to different causes of SI joint pain, that some most times unilateral, it may be present in ankylosing spondylosis, tubercle psoriasis, then Reiter syndrome, inflammatory bowel disease, and if it's a bilateral, you can have chronic non-traumatic sacroiliitis. But most common painful SI joint presentation is usually in mechanical injuries with trauma, and sometimes additional lumbar arthropathy and fusion. If patient has had some surgery, those patients can have SI joint dysfunction. Coming to symptomatology, usually these patients have painful catching and increased pain while they are having some loading in the lower extremity, and pain may be induced by simple movement like trunk shift, sneezing or turning in the bed, especially if the patient is ascending or descending in the staircases, and if the provocative landing after a jump or hop. And in this patient, pain is usually not provoked by Vasva maneuver. And these patients, especially pure SI joint dysfunction, may never have any paresthesia, numbness or weakness. Now coming to evaluation, it's basically clinical diagnosis is very important most time, but we go by clinical diagnosis only. And there is a battery of tests which can be performed, especially those may be manual compression tests or provocative tests. Basically, one can do dorsolateral pelvic compression if the patient feels pain and have a finger. You can have finger test if the patient complains that I am having pain in that part of the SI joint or buttock, that means the patient is having some SI dysfunction. Especially axial femoral compression test can be done, and forward flexion, some Waldorf phenomena can be performed. And there is a battery of provocative tests, though they are not any more specific or sensitivity, especially Gillette test, Patrick test, that is Faber test, then Gansler test. These have some relevance, especially in SI joint dysfunction, and midline Seckle test. But all these tests, they are not confirmatory, and they have shown some very little diagnostic value compared to, and the standard gold standard is give some SI joint injection to confirm the diagnosis of SI joint orthopathy. Coming to SI joint innervation, that have a very complex innervation, that this usually that
nerves supplied that medial branch or dorsal ramus of L5, even L4, then lateral branches of the dorsal ramus of S1, S2, S3, and sometimes S4 also. So it's a very complex, and the anatomy is very important, especially you are doing some, apart from after conducting or performing SI joint, diagnostic SI joint injection. If you want to have prolonged relief in those patients, we can perform some thermocoagulation. Why fluoroscopy? Though these injection can be performed easily by SI joint, this ultrasound guided SI joint injection, but fluoroscopy is gold standard for performing SI joint injection, because one can have specially designed joint in the needle, and it improves the precision, accuracy, and clinical outcome. And most time we use fluoroscopic C-arm to conduct these blocks. Coming to injection technique, basically it's interarticular classical oblique ridge by posterior approach, and as I said, it can diagnose the course of pain. Usually this blocks are performed prone fusion fluoroscopy and strictly steroid technique used. And in classical oblique approach, the C arm initially places in direct anterior posterior so that you can view the SI joint total. And once you have visualized the SI joint, you can have two joint line. One is medial joint line, one is lateral joint line. So basically you align both the lines to make a single line, and for that you have to tilt the C-arm in contralateral oblique view so that there is alignment of both anterior posterior joint line. This is the classical P oblique view approach. You can see that slightly contralateral oblique view is there. You can see that that in this view, fluoroscopy view, more or less this is anterior joint line, this is the posterior joint line, and at the lower one third of this, lower half of this, there is a single line. So this is posterior joint line, this is basically anterior joint line. So target area is posterior one third of this joint line. This is a marker where we have to insert the needle. This is after inserting needle and giving dye. You can see that there is a very good spread of dye from anterior superior to inferior aspect of the joint. In lateral view, you can see that there is a clear delineation of the whole of the joint by the radio contrast material. In this, for SI joint injection for diagnostic, we usually use 2 to 4 ml of xylocaine 2%. And if you want to convert this block as a therapeutic block, you can use some steroids, especially dapamidrol or dexamethasone. You can use up to 8 milligram or dapamidrol 80 milligram. It's a big joint. Safely 2 to 4 ml can be used in total. And complication, this needle tip may not be joint. It can go in the pelvic viscera. One has to be careful. At all time, the needle should be closer to the bone. And as the chances of infection, hematoma can occur, but most of it's very safe, easy, and very quickly can be performed. And it's a very good role in diagnosing the pain generated in SI joint. Thank you very much.
Any question?
Okay, now it's not a question, it's rather a comment, and I would request all of you to read something called as Laslet's cluster. So see, when we are in the OPD, the patient is not going to tell us whether he has a disc problem, a SI joint problem, or a hip joint problem. I have missed quite a number of AVN of the hips and SI joints. So there's something called as Laslet's cluster. It's a cluster of 5 tests that you perform. You need to perform in all of your patients. So what Laslet says that if 3 of those 5 tests which Sir has shown If they are positive, then it is suggestive of a SI joint pathology. And then you go forward and get a SI joint MRI as well. So Laslets cluster is what is now the benchmark for SI dysfunction clinically.
Very true, sir. Actually, the area of buttock, this area, we perform any test, okay, even Faber test, fatigue test, if there is a L5, S1 orthopathy, facet orthopathy, those patients can have similar type of problem. So we have, these are diagnosis of exclusion. You have to exclude all these different entities one by one. And in SI joint, the classical picture is usually in most of the patient can pinpoint the pain side by finger touch. And if, especially with that Gensen and Faber test, if the patient complain of pain in entire aspect of this, that means it's a hip pathology. But patient is start telling that it's a posterior aspect of the or gluteal region, then is most of the time it's because of SI joint or facet joint arthropathy.
Here I would like to add one more thing, that many times when patients are too old, like I had 4 patients who were 85 plus, and they have pain everywhere, and MRI also shows so many, it seems like pain is coming from nerve compression or SAP syndrome. But when you take the patient on table, try to push the points and tell them from where the pain is coming, and they can tell you exactly that it's coming from sacroiliac joint. That's one of the most confirmatory thing, that the pain is coming from sacroiliac joint.
And that can be confirmed by direct SI thrust.
Any other question? Very common problem. So if there is no other question, thank you very much.
Thank you, sir.
Require a question. Yes. Post-pregnancy sacroiliac joint pain. What's the remedy and treatment?
So yes, absolutely, and it is because of the ligament laxity that is the cause of the pain. Generally, typically starts between, not immediately after the pregnancy. It may start about 6 weeks to 8 weeks later on, and continue up to 6 months or so, at times longer. So obviously, apart from counseling and reassurance, a good lower down tight corset helps these patients a lot. Only uncommonly do you require to block such a patient, because they generally do well with physio and a good corset.
Thank you very much. Next one.
So, hello everyone. So I think most of the people have come out of post-lunch hangover and they are awake now. So I would like to thank the organizers also for giving me this opportunity. So we are going to talk about stellate ganglion block. Slide please. The blocks are not, as you are seeing in this picture, these are not these blocks. We are basically talking about the pain intervention on the stellate ganglion, and this will provide interruption of the sympathetic efferent fibers to the upper extremity, head and neck. The few important anatomies, this is the longus colli muscle. Then this is the C6 transfer process, so it's a segment anterior tubercle, C7 and T1. This is common carotid artery, then subclavian, this is vertebral, and this is the superior cervical ganglion, middle and inferior cervical ganglion. So stellate ganglion lies here. So its utility is to determine if the pain is sympathetically mediated or not. What happens in sympathetic mediated pain, that due to abnormal connection between sympathetic and sensory nervous system, there is pain. We come to know if there is significant pain relief after block, it means there is significant component of sympathetic mediated pain, and we, after giving block, we can determine if neurolysis or surgical sympathectomy could be beneficial. So the sympathetic fibers for the head, neck and heart and upper limb arise from the thoracic spinal cord T1 to T8. These ascend through the sympathetic chain and synapses in the superior, middle and inferior cervical ganglion, as you can see here. In 80% of population, the inferior cervical ganglion is fused with the first thoracic ganglion, forming the cervicothoracic ganglion or the slit ganglion. So, and nearby this is the vertebral artery, which goes anterior to the C7 tubercle, but goes in the transverse from from C6 upwards. So this ganglion measures 2.5 centimeter long, 1 centimeter wide and half centimeter thick. This slide is the level of the C7 and T1 anterior to the transverse process of C7 and first rib and longus coli muscle. This is the longus coli muscle. This lies anterior to these muscles, and the borders are the longus coli medially, then the scaly laterally, then subclavian artery, then vertebral artery posteriorly, the transverse processes posteriorly, the carotid artery anteriorly, and the nearby structures. This is the phrenic nerve, the vagus nerve, the recurrent nerve, and the brachial plexus. So this is a very useful block, and there are so many indications for this block, starting from the complex regional pain syndrome of head and upper limbs, the peripheral vascular disease, the upper extremity embolism, the post-herpetic neuralgia, the chronic post-surgical pain, hyperhidrosis, Raynaud's disease, scleroderma, orofacial pain, phantom limb pain, the atypical chest pain, cluster or a vascular headache, post-traumatic stress disorder, the Meniere's syndrome, intractable angina, and the refractory cardiac arrhythmias. But there are still few contraindications. The one is recent MI, the anticoagulant patient or coagulopathy, the contralateral diaphragmatic paralysis, because then you may block the same side ipsilateral phrenic nerve also, the cardiac conduction block, the contralateral pneumothorax, because you may puncture the pleura while performing this block. Then glaucoma is one of the contraindications, and if patient is having severe emphysema. So there are few techniques. There are 4 techniques basically. We will be talking about the 3. One is surface landmark technique, the fluoroscopic technique, the USC guided or the CT guided. So as we have discussed that the ganglion lies in front of C7 and T1, but most commonly this block is performed in front of the C6. So why we need to choose C6 for the landmark? Because as you can see here, this is a C6 transverse process and this is C7. The vertebral artery goes in front of the ganglion. So the most likely you may puncture this artery and you won't like to do this. So that's why we choose the C6 transverse process to give the blockage, because then the vertebral artery goes posteriorly in the transverse foramen and through that ascend upwards. Sometimes this may not happen, but most likely this happens, and that's why the C6 is considered more safer for the landmark targets. So in this view you can see this is the trachea, then esophagus, this is thyroid, this is the C6 transverse process, that's a sagnic tubercle, the vertebral artery posteriorly in the transverse foramen, then this is the inferior thyroid artery, this is striate ganglion, then carotid, then vagus, then IJV, and few things. So what is the position? Patient should be supine with slight head extension. Then a carotid cartilage is palpated to find the C6 level. We then move laterally and downwards to feel the C6 sagnic tubercle with the finger compressing the carotid artery laterally. So after sterile percussion, skin and subcu tissue pressed against tubercle, the needle advanced perpendicular to the skin posterior direction to hit the C6 tubercle. Then once we hit the bone, then we withdraw a little bit 2 mm, so that we are just out of the longus coli muscle but still beneath the prevertebral fascia. After 1 mm test dose is given, after negative expression of, look, we need to check for the negative expression of 3 things. It is very important for the blood, for the CSF and the air, because anything may come from this place. You may be in the lungs, you may be in the CSF space, or you may be in the one of the arteries. Then you can give the local bupivacaine or ropivacaine 8 to 10 ml, and patient to be assessed at least 30 minutes post block. Then the same procedure can be done the fluoroscopic guided. The landmark and patient posting same as for the surface landmark. What is the advantage that bony delineation is better than, and the procedure can be performed with fluoroscopy either on C6 or on the C7. Few like to perform on C7 and few like to perform on C6 because they think that C6 is still safe. So when we are giving local, what it will do if we injected the right place, the local or your neural lytic agent will trickle down and it will block the striate ganglion. So oblique fluoroscopy technique is most commonly used, and the contrast is given to confirm the needle placement. If there is proper facial pain, you are in the exact position, the local will spread and contrast will spread both up and down side. If you are in the muscular, so next slide. So this is a honeycomb appearance. If you are given a block just beneath the prevertebral fascia and anterior to longus coeli, but you may see this kind of appearance, striated appearance, if you are in the longus coeli muscles, and then your block may not be that effective. Then you can go to the USC guided. So this is how you give the USC guided block. The carotid sheath and sternocarotid muscle to be retracted laterally with transducer. Presses applied with the linear transducer probe. The needle is inserted directly toward the chest segment tubercle. Then it's withdrawn again, and after negative expression, LA can be injected and spread to be visualized with the ultrasound. So again, this is trachea, this is esophagus, the longus coeli muscle, prevertebral fascia, this is thyroid, carotid, and all. So why this route is preferred? Why ultrasound is preferred? Because in either you are giving fluoroscopic guided or surface landmark, you are going perpendicular to the skin. But as you can see here, this is cricoid, and just near this there is esophagus. So sometimes you may puncture through esophagus because it is not necessary. In up to 40% of patient, esophagus may be just lateral to the trachea instead of being behind the trachea. So it is better to use ultrasound so that you may avoid puncturing through the esophagus, or immediately there may be inferior thyroid artery. So esophagus or inferior thyroid artery may be damaged with the previous techniques. So this is sonotomy. This is sternocarotid muscle. This is common carotid artery, the IJV, the longus capitis, longus coeli muscle. This is the transverse process, and just behind, in front of longus coeli muscle and behind the common carotid artery, there is sympathetic chain. This is our target. So and this is the needle entering, and this is spread of our local anesthetic. This is longus coeli muscle. So the C7 anterior approach can also be used. This is nearly identical to the C6 approach. So what advantage? The needle is closer. Local agent may with more reliable and consistent blockade, and it may be useful if your previous C6 block the C6 level has been failed. And for this you require either fluoroscopic or the USG guided approach, because surface landmark you can't use here because the tubercle is very small and you may not feel it. So what may the various complications? The complications are numerous, so this to be done very meticulously. It may be from vascular puncture of the common carotid or internal jugular, internal thyroid artery or vertebral artery. The needle puncture may, few nerve roots may be damaged like vagus, recurrent brachial plexus, or the phrenic. There may be pneumothorax because you can see the dome of the lung just nearby. This is the striate ganglion and just lungs is just nearby. So there may be thyroid injury, the esophagus or trachea puncture may be there, the transient Horner syndrome, which we many times we see. Then intravascular injection may lead to the generalized seizure, and then infection, and then maybe paratracheal hematoma. A few references for this. Thank you.
Thank you very much. Any question? Any question to him? Anybody? No? No question? Thank you very much. Okay, next one. Group, Dr. Group is there?
Yes, sir. USG. ये फर्स्ट देखिए, लगा के देखिए, कलर वाला वो. हाँ जी.
Good afternoon, everyone. So I am back. Last time when we were back, I came, we discussed the easy part, which was the fluoroanatomy. Now we would be talking about sonoanatomy. The anatomy remains same. The only challenge it poses to us is because again a new technology comes in play. Therefore, the challenges are there. But if we are very clear with regards to anatomy, things can become very easy. So just to give you a brief, as I told in fluoro, I will repeat here, when we are doing interventions, specifically in the domain that we are, bone is our friend. That is one. Here we have one more enemy, if I may say so, that is a vessel. So whatever you are doing ultrasound guided, always have a bone at your base that yes, this is, or any structure around it, and always try to avoid any vessel. With regards to spinal pain, fluoroscopy is the gold standard. And why I say so? Because there is a direct visualization of the needle when even it goes below the bone. That is what you must have seen when we were doing those interventions. So for experts, you can do all those interventions under USG also, but the basic problem remains that once it goes below the bone, then the needle is not seen and it becomes more of a blind. That is one. And second thing is, as I said, wherever there is dye, there is going to be drug. So if you are not be able to push in the dye, you can never be sure about the position, which is just not possible with sonology. But it does have some advantages. So what does that do is, for people, we know that radiation has its own set of side effects. Therefore, radiation exposure reduction is one big thing. And for most of the things clinically, what we are doing in a day-to-day practice is we are doing a hybrid technique. So what I will be doing is I will be putting a needle under USG, and once I am sure about it, then I'll put in the dye and use fluoroscopy. Second, there is an increasing role, a lot of evidence is coming up for facial plane blocks in chronic pain. And now for that, the best drug, the best set of technology is definitely sonology. Then there are certain interventions where, for example, in cervical root, we talked a lot about it, that we should not do it on the fluoroscopy, but that can again be done by USG guidance. Sometimes you can use for scanning also. Sometimes the muscle is something which I feel that you can definitely scan with great precision with sonology, so that is one. Secondly, somebody was asking about post-pregnancy. I would say there is a subset of patients who come up to us who are, during the pregnancy, they have back pains. In those, you cannot go for fluoro-guided intervention. Just in case if you have to, then definitely USG is the indication of choice. As I told you, what we can do, one, caudal epidural, with greater confidence we can do cervical selective root block. It was demonstrated. So again, it can be done. Cervical facet, lumbar median nerve block. SI joint is one thing. Another thing here is newer blocks for chronic pain is the plane blocks that I was talking about. Now, interestingly, when I talk about PRP, so again, the basic major subset of patients are non-specific low back pain, and in non-specific low back pain, there we can't find anything, and there they found out is that what happens is the erector spinal group of muscles, or multifidus in particular, is the one which has atrophied, or that is weakness. So for that, we do exercise. Along with that, we can even consider doing a PRP in the muscle for its initiating its growth. So how do we scan? Now again, as regards to any sonology scanning, you need to follow a protocol. That is one, try to follow it and keep repeating it so that it becomes your second nature. That is one. Second, again, we are converting a 3-dimensional structure into a 2-dimension. Therefore, you have to confirm anything in 2 dimensions always. So what we do is, one is a long axis, another is a short axis. So when we are doing a structure, we always go from long as well as a short axis. That is one. Third, something I always do is I always have a zero. means when you are doing things sonology under USG, you tend to get confused whether you are doing shoulder, whether you are doing hip, whether you do spine, because there are multiple layers. So always have that 0, and then you can start all over again. Now just imagine we are moving from lateral to medial. So if we go from lateral, we start moving, there is a group of muscles, and the first bony structure that we will encounter would be the transverse process. From transverse, we will be going to the facets, lamina, and the spine. Right? So for me, the 0, when I'm doing a scanning of the ultrasound, is my transverse process. So bone is my friend, I see a bone, that is my 0, and then you can go medial or lateral, wherever you want to go. So medial, you will have facet, lamina, spinous process, where if you go lateral, you will have muscle layers. Until you reach the middle, and once you have done that, you can always have a short axis. So this is long, this is short axis, you can have at the spinal level as well as the interspinous level. So long axis view, we start with 3 muscle view, then 2 muscle, then for what we always call as then we come to the transverse process, facetal view, laminal view, and the spinous process. Now these are the images. So once you are at the transverse process, so again bone, hyperechoic, within a caustic shadow, it won't let anything go by. So you will get these straight lines. So this is a classical trident sign, which is for the transverse view. You move medially. So just imagine the anatomy. You are moving medially from transverse process. We have come on to the facets, facetal line, and there it becomes like a hump. So this is where the things starts to get interesting, because we are at the facet. So just in case if you are interested, you want to do a facet block, these are the facet blocks that you can consider going. That is one. Now from the facetal line, we are again moving medially, and what we get is a laminal view or the sawtooth appearance. Right? So this is a lamellar view. Now this is something, if you have not done sonology, it can be challenging. So the next view is, so in sonology what is actually happening is, I'm throwing sound waves and I'm again catching it. So even if I change the direction of the sound wave slightly, the image that I'll get would be different. So so in this case, here I'm just straight, where here I have not moved the needle, but I've just made it slightly oblique. Therefore, what I see is the dura. So dura, this is the posterior complex of the dura, and this is the anterior complex of the dura. So same place, just changing the direction of the probe, changing the direction of the sound waves being given and getting back. And then this is the short axis view. We are at the right at the spine. So we have the spine, we have the facets, and we have the transverse process. So again, this was something I said, you start from 3-4 centimeters from the midline, you keep on going, you see the transverse process, and then you see the trident sign. You move still medially, you come at the level of the facets, you have the facetal thing. Then once you have the facets, then you move still medially, you come to the lamina. When you are in the lamina, you won't be able to see because there is an acoustic shadow. But the moment I change the direction of the sound waves, there you will be able to see these complexes. Excuse me. There you will be able to see the posterior and anterior complex where of that thecal sac. Again, this was this. So once the sound waves travel from the lamina, this is the anterior complex, this is the posterior complex, this is epidural space, this is your CSF. This is the short axis view, right on the spinous process, lamina, and the transverse process. Here, now from when I am at the spine, we just move little, and then what we get is the facet. So these slit-like openings on this is a facet. So if you are in a hurry, the patient is not able to tolerate that position, you do not have fluoroscopy. So this is something which I strongly recommend, is something that you can start doing, where you scan and do a facet block in the short axis view. Caudal epidural, again simple. You just start from the sacrum, just go down. So once you go down, you will see these beautiful cornuas, and between the cornuas, you will see the sacral hair. So we just need to introduce our needle right there. So this is a short axis view, this is long. So once we scan, we get the short axis view, we make it long, and that is how we, just 30 seconds, sir. So just we will introduce the needle right up. So what I generally do is, if I'm doing this as a hybrid technique, short axis view, I introduce the needle. Once it is in, I get the fluoro and see how we go for it. Now, SI joint again can be done, superficial joint. Now the other thing is the common, most common interventions that we are doing left, right and center, that is an erector spinal block. I won't go into the details. The simplest way is just hit the transverse process and give a lot of volume. So around 15-20 ml of local anesthetic can easily be given just by hitting the transverse process, and you will get a good spread, and the erector spinal block would happen. So this is the transverse process, so it can be given right from the thoracic to the lumbar region, and good for non-specific kind of low back pain. Just carry the message, limited lumbar spine intervention, definite role in facial pains, and for subset of patients and indications, you can definitely think about it. Thank you so much.
Thank you very much. Any question? I have a little comment. I don't know how many of you know, the first ultrasound came to AIMS in 1980 for abdominal ultrasound. And there was no ultrasound available in the world before 1979. Usually it was used for the navigation for the ships. Ultrasound started 1940s for navigation of ships. That ultrasound was translated to medical ultrasound in 70s and 80s.
Yes.
So AIMS had the first ultrasound, abdominal ultrasound in 80. We got our ultrasound transcranial Doppler in 81, and that is PCD for the blood flow, and cranial ultrasound in 85. So we had to have a temporal window, occipital window, orbital window. So ultrasound has a tremendous role, and the pediatrician use it very frequently through the fontanelle.
Yes.
So if you go to any pediatric neonatal unit, for every brain problem, they will do a transfrontal app. I don't know how many of you know.
Yeah.
You send anything of pediatric for brain problem, say I will get an ultrasound, neonatology, right? So I think it's a very important, which is very underutilized because we have CT scan and MRI. I still think intraoperative ultrasound is a very important thing to find out bullet, foreign bodies and all this.
Sir, Sir, in chronic pain, the game changer has been ultrasound. The reason is simple, because all these investigations are static images. So for example, a patient comes to me, a player comes to me who says that, doctor, when I throw, that is the time I have pain. So I can actually mimic the movement and do a dynamic scan. Now dynamic scanning is something which is the future of scanning. Right. Apart from needling and everything, obviously precision is there. So for example, not related to spine. So if I have a tear of a rotator cuff supraspinatus, I can do it with precision. Even diagnosing it, I can mimic. So dynamic examination is something which is the thing for the future.
Not only that, it can be repetitive.
Yes, sir.
It's cost effective.
Yes, sir.
It can be done on bedside.
Yeah.
You don't have to push a patient for MRI, CT. So ultrasound is a bedside, repetitive, confirmative test. Very, very, very. I think we all underutilize ultrasound.
Only problem is, before I start the second talk, is that especially in center setups, daycare centers, getting a PNDT is a hell of a job. So that is a big challenge. But rest, the scanning and everything, it is definitely...
all medical superintendents, they give an undertaking during purchasing of a ultrasound. This machine will not be used for check. If somebody thought that's the question, we all thought even red light, driving a red light. What's about ultrasound?
No,
so all of us have driven red light, ne?
Fine.
So anyway, next
time, sir, I was not there, so next topic would be mine, sphenopalatine ganglion block. Okay. I'm so sorry, I'm boring you repeatedly. So now the sphenopalatine ganglion block, it's a simple block done for orofacial pain. Now for me, orofacial pain was not such a big identity, because most of our pain practice is restricted to spine and joints and everything. And very recently, around 2 or 3 years back, I was invited by one of our leading ENT specialists from Meerut. And I said, sir, I have 2-3 तो केस टाइप के होते हैं, कहता तू आ तो. And then he called me, and that was the real time where I found a lot of patients coming with varied presentations of various orofacial pain. That is one. Second thing, as we famously or infamously were discussing about the various complications post-surgery where the patient continues to have pain. In the same way, what the ENT surgeons suffer is that sometimes they do a surgery like a simple mastectomy or ethmoidal or sinus surgery, and the patient comes to with a lot of orofacial pain, which they are sometimes not able to understand. And along with that, those set of patients also have symptoms which are suggestive of sympathetic or parasympathetic overactivity. So in those subset of patients, this block or these kind of blocks can really help us. So with that background, let us start. So where are we doing this phenopalatine ganglion block? Don't worry, you can text me, you can have my this presentation, nothing great. I have not reached to that level where I do something very great, but you can have it. Cluster headache, atypical headaches, phenopalatine neuralgias, CRPS, neuralgias of the face, and sometimes in cases of orofacial cancer. Everything starts with the anatomy. It is this ganglion is present in the fossa. The fossa is present in the pterygostosis and the sinus. The lateral opening is the pterygomaxillary fissure. The medially we have a palatine bone. There's also an opening, interestingly, in the nasal cavity to the sphenopalatine foramen. So basically, for us, we can enter this space either externally or even through the intranasal route. Or a more important thing, the sphenopalatine ganglion is located in the superior 1/3. So when we are trying to do an intervention of this of the ganglion, we always try to target the upper 1/3 of the ganglion. So now this is the famous reverse triangle. So this is the space that we need to target. Even in fluoroscopy, when you will I'll be sharing the images, this is the reverse flask thing that we need to target. That is one. Second, regarding the complications, so any structure which is present here, right from zygomatic nerve, the infraorbital, alveolar, lesser palatine, greater palatine, all these nerves along with the arteries are the ones which can be damaged if we are not careful during the procedure. Now, how do we do it? First is, and the easiest thing is the intranasal approach. Classically, patient of cluster headaches comes to us severe headache, which is very cyclic, and sometimes the patient even cannot come to the hospital before it subsides. So what do? Or if the patient comes to us, obviously we give oxygen, and then we go for a sphenopalatine ganglion block through an intranasal approach. The point is to get the local anesthetic in the fossa. So what we do is we just introduce local anesthetic. Now this can be done by a pedette, this can be done by a syringe, this can even be done, what I was taught and by what I think was we just soak a gauze piece in local anesthetic, ask the patient to have an extended neck, push it in, place it for 5-10 minutes, patient is comfortable, the pain settles down. This is something that we even tell the patient that this is something like a first aid that we can do it at home also. Only precaution is that we ask them to keep a liberal part of the gauze piece outside so that they can pull it out. But sometimes what happens is, now that is for cluster headache, sometimes the pain either doesn't subside or there are atypical presentations of this kind of patient with severe burning, itching in the facial region, or the patient has repeated attacks which are responding to these phenopalatine ganglion blocks, but they have a tendency of coming back. In that, we can consider going for a diagnostic block. So before that, just see again, as a trigeminal ganglion block, the phenopalatine ganglion block is what I call it is a technician's block. So for example, if you can get this image, your job is done. You just need to introduce the needle in this position. But if you are not able to appreciate this, you can never do it, because This is a very narrow space, and there is a lot of overlapping. So how do we do that? Now here, the patient is lying supine. Second, the position of the C-arm is going to be lateral. Now the challenge, as I said in my previous talk when I talked about fluoroanatomy, was getting a perfect AP. In this, getting a perfect lateral is a challenge. We really want the right and the left to superimpose to give us one image. Now, there are various ways. So some people talk about concentrating on the eardrum so that you get the eardrum. Some talk about mastoid. But some simple trick which one of my teachers told me was that ask the patient to put up a stethoscope. So ask them to put up a stethoscope. Ask them to hear their heartbeat. They are also relaxed, and you just need to align the stethoscope. So now that becomes, because that's a huge thing, so you just need to get a perfect lateral image where the stethoscope is matching. You will get this image, and you just need to introduce it from lateral to medial. Now, this is what I was talking about. You get a lateral image, this inverse was appearance, and then this is the lateral image. Now, this is again because this palatine bone is very small and fragile. Therefore, once I am inside the foramen, I get that feeling that I have entered the fossa. I make the patient, my C-arm AP, excuse me, I get the C-arm in AP and introduces gradually, making sure that I do not puncture, because this bone, palatine bone, is soft, and even with a 22 gauge spinal needle, there is a possibility that you might pierce it. Lateral, as I talked about, perpendicular, yeah. So positioning, it has to be supine, lateral view, rotate the head to get a true lateral view. So you can take any structure, as I told you, the eardrum, the mastoid, or try the stethoscope. Enter point is inferior to the zygomatic arch, just in front of the coronoid process. Now this is something, again, sometimes people struggle because in a closed mandible, you cannot go in front of the coronoid and it is blocking. So sometimes you even have to ask the patient to open their mouth. So the moment they open their mouth slightly, that also makes our job easy, and we are able to identify the vase. So what people who are starting, please take these small tips, utilize it, and do not try to introduce before seeing the vase, otherwise you might struggle. AP view, lateral valve, we have already few tips which I have found it perfect lateral image is something which holds the key for the procedure. One can move the coronoid process, just ask the patient to open the mouth slightly, and then your thing, that is second. Third thing, which I was even discussing with doctors who were there with me in the OT, as a beginner, there is no harm in bending the tip so that you are oriented when you are introducing it, especially in fluoroscopy. So that bend tip gives you an idea about orientation, that is one. Secondly, don't target the fissure or the any foramen, try to target the bone. Go close to the bone, hit the bone, be rest assured, and then redirect and go in. So that is the three things. Regarding the RFA, so firstly we go for a diagnostic block. If the patient has relief, then we go ahead with a radiofrequency ablation. So ideally the tingling sensation should be at the tip of the nose. Excuse me. But if the tingling sensation is in the teeth, it means that you are too anterior. Right? So ideally it has to be at the tip of the nose, but if it is anterior, you just like to pull it, redirect it posterior side to make it slightly posterior. If the tingling is at the palate, it means that you are down, you need to move more cranial. So these are the small tips and tricks which I will request, and thank you so much.
Now, only one or two questions, anybody? We are already half an hour late. Any question? No question. Thank you, best. Thank you very much. Ashish?
Thank you, sir. So I'll be summarizing the whole day's program, spine blocks for neurosurgeons, and I'll try to emphasize on certain particular blocks which have not been discussed at a greater length. So why should I learn blocks? It helps clinch diagnosis many a times, and especially if we are taking up the patient for surgery, and it is definitely a part of the treatment algorithm. What are the blocks I would be talking about? Erector spiny block, the plain block. Transforaminal block we have already discussed in the morning and we have demonstrated it as well. Facetal block, that means intrafacetal injections. Then medial branch blocks for facetal pain. Epidural blocks, the various types we have already discussed. Caudal block and SI joint block, they have already been discussed, just the previous lecture was on that. So why blocks? Because there is a poor association between imaging and the cause of chronic pain. So that is why the blocks come into place, so that we are very sure that what we are targeting, even surgically, we are at the right place. And surprisingly, only in 15% cases, the source of chronic pain can be picked up through imaging alone. So, it is so less. So we need to use diagnostic blocks more often. Now, how to go about diagnostic nerve root block? It helps diagnose the source of pain, pinpoints the pain generating root level or the facet joint. You can use lidocaine, which is a short-acting drug, small amount, 0.5 to 1 ml. And if the patient has 50, some studies would say 50%, but generally we agree that 70% is the mark. If the patient has 70% or more pain relief, we consider it to be a positive test. The diagnostic value of any diagnostic nerve root block or facet block is only moderate. So clinical imaging as well as the diagnostic nerve root block. The frequency of blocks that we can give is about 3 to 4 per year is safe for a particular level. And there should be a gap of at least more than 2 weeks. What are the contraindications? Anticoag, local site infection, systemic infection, pregnancy, use ultrasound only, and if there is allergy to contrast or local anesthetic agents. We have had an extensive discussion on the type of steroid. Again, I would emphasize that I personally believe in dexamethasone. The particle size is 10 times smaller than that of a RBC, and they do not aggregate. So dexamethasone is the drug of choice for me, and there is no difference in studies as far as functional or analgesic outcome is concerned between the particulate or the non-particulate steroid. The rationale for steroid use, I'd like to draw your attention to this: epidural steroid versus just bupivacaine injection in disc prolapse. Epidural steroid injection patients, 23% required surgery, whereas just the bupivacaine group required 67%. So obviously you need to use steroids. Rationale for local anesthetic, the viscosity is different. Local anesthetics is similar, and there is higher viscosity of the dye. So the dye would spread less, and the local anesthetic would spread more than the dye. The volume of drug would decide the specificity. So suppose if you're putting 4 or 5 ml, then obviously there will be extensive spread, and you cannot be very sure about the level of the block. And so lower volume for selective nerve root blocks and SI joint or facet blocks, and higher volume spreading to adjoining structures and decreases the specificity. Rationale of epidural steroid. Now this is very important. The SPORT trial, which is the spine patient outcome research trial. Patients of disc herniation receiving epidural steroid, only 20% of them required surgery. Whereas without epidural steroid block, almost 57 to 60% required surgery. So sort of we can avoid a lot of discectomies if we are using the blocks. Now coming to transforaminal versus interlaminar, TF approach has better results, lower complications, and obviously better ventral penetration of the drug, because in these cases and at times with osteophytes or cysts, you may have anterior compression and the root is also lying anterior in the foramen. So transforaminal tends to deposit the drug there. In pregnancy, kindly use ultrasound. Now let us compare fluoroscopy versus CT scan. Now, fluoroscopy is faster, widely available, easy to use, better non-axial view, real-time view of the flow of dye. And the disadvantage is radiation to the surgeon and obviously non-axial views. Whereas in CT, you have excellent axial views and 3D views, precise view of where exactly your needle tip is. However, and also operator radiation is avoided, but the disadvantage is time taking, increased radiation to the patient, and real-time views are absent. So every time you tend to come out. So let's look at erectus spinae plane block. It is the new child around the corner. It was just started 2016. It's a facial plane block, and the drug is deposited below the erectus spinae muscles. So I personally use for peri-op pain reduction for my lumbar surgeries, as well as if I'm doing thoracic surgery. However, it was introduced for thoracic surgery and for chronic pain. So part of it is ESPD block, like for all of us, it can be utilized as the multimodal analgesia. So it is part of the ERAS program now. The target is the tip of the transverse process. You can do it fluoroscopic or ultrasound guided. The needle rests on the tip of the transverse process below the erectus spinae muscle. And I personally use 20 ml of, I use ropivacaine, 0.2%, deposited on either side. So if I am doing just an endoscopic disc or a tubular disc on one side, then obviously I'll just pushing the drug on one, but suppose if I am doing some sort of fixation, I tend to push the drugs on either side. Now, what is the current standing? The conclusion is erectus spinae block provides less opioid consumption, lower pain scores, and longer time to first analgesic in the perioperative period. So obviously, if you're using it, you can enhance the recovery. Complications, you can have partial lower limb weakness, complete motor block, priapism, local toxicity to the anesthetic drug because you're injecting a lot of it. Transforaminal blocks, we have already discussed at length in the morning, so I'm not going to that. Facet, I'll focus on a few very important aspects, which are practical tips. 67% of neck pain is secondary to facet, especially chronic neck pain. 48% of thoracic pain and 45% of low back pain. I must tell you, 10 years before, I hardly thought about facet as the source of pain. So many patients coming to my clinic. And this data sort of opens our eyes to the times we are missing the cause of the pain generator. This has already been shown, the presentation of facet-mediated pain. Basically, it's a diagnosis of exclusion, but the patient can come with lumbar back pain, aggravated on hyperextension, rotational movements. Uncommonly, it will spread to the lower limbs up to the knee. Generally, it does not go below the knee, so you can differentiate with the radicular symptoms. In cervical, Professor Dureja has already discussed, this is the pattern you will get, but no radicular pain into the upper limbs. Coming to intra-articular facet blocks. So facet as a source of pain, basically it's a diagnostic block, not very good therapeutic option. The causes of facet joint pain can be osteoarthritis, rheumatoid arthritis, Angst-Bond, segmental instability, trauma, inflammatory post-laminectomy, and post-spinal fusion. Again, I would emphasize that a good number of our patients, when we fuse, they complain of back pain, and we do not listen to them. We just keep on using analgesic, physiotherapy, and gabapentins and pregabalins. Please think about facet as a source and at least do a diagnostic block. Now, as far as intra-articular facet joint block is concerned, you need to push in less than 1.5 ml because otherwise there would be capsular rupture or leakage. For cervical facet, you can use a short-acting local anesthetic, whereas in lumbar you can go in for a long-acting one. This we have we've had so much of discussion since the morning, but you can see the facetal line here and you just need to push the needle straight in, do the dye. Let's look quickly onto the studies. I think my time is over, so let's skip this. Medial branch block, just one comment. So for say L4-5 facet joint. So the question is, suppose if you have a L4-5 facet joint, the supply is coming from, one is coming from the L4 ramus and the other is coming from L3 ramus. But to simplify L4-5 facet joint, you use L4 pedicle area and L5 pedicle area to block. Okay, so that will give you a good median branch block. To remember, these are the exceptions to the dual supply: atlanto-occipital joint, atlanto-axial joint, and C2-3 joint. They just have singular supply. Technique has already been discussed. The best is between the mammillary process and the accessory process, but the midline is good enough because most of the times on fluoroscopy this is not seen. Complications, this I would like to focus. Multifidus is supplied by medial branch, and it is very important for stability, so avoid more than 3-level median branch block because it will cause denervation and instability. This we have already seen in the morning during our session. We did interlaminar, midline 2, we did one paramedian, and transforaminal we did several. So this we have already discussed, I need not go. Just the final slide on epidural and anticoagulant consensus. NSAIDs, no contraindication. Etiopidine, discontinue for 14 days before the procedure. Clopidogrel, 7 days. Ecosprin, 5 days. Heparin, discontinue 2 to 4 hours prior. Check the PTT, and then you can go ahead. Warfarin, discontinue 5 days. Get the INR normalized. Low molecular weight, wait for 24 hours after the last dose. So I think I'll sum up my lecture here in the interest of time. Thank you so much.
We would like to have some questions.
Yes,
Any
sir.
question to Dr.
Because we are talking here about facet joint block. Facet joint problem is coming mostly because of the joint instability. So aren't we delaying a process which has to be fixed right now? The problem lies at the joint instability. We are not dealing with the joint instability and we are in fact blocking that pain which is arising from a defaulted or imbalanced joint. Shouldn't we go for joint fixation earlier rather than we are just suppressing that pain? So that
absolutely not. First of all, I'll sort of try to convince you that it is not a question of instability. Facetal pain is not secondary to instability. It is secondary to inflammation of, like any joint. There is a synovial membrane, there is a capsule, and there is inflammation, which is the cause of pain. Only one of the causes is instability. But bulk of the indications we saw was more of inflammation, and we are trying to restrict the inflammation first. But secondly, if you said fusion, you are automatically putting stress on the adjacent joints, and now they will be loaded. So why unnecessarily fuse the joints? So perhaps I think that is not the solution. Wherever you have facetal pain, go and fuse is not the way to go. Thank you. Okay, so see, what is happening is you are blocking the sensory component and typically the nociceptive fibers. Previously, when we used to cut it, or there was chemical lesioning, it was sort of permanent. But when you do a RF, like for any RF procedure, RF tends to affect nociceptive C-type fibers much more than A-alpha fibers. So that proprioception sense tends to regenerate much faster, whereas the nociceptive fibers would be blocked for a longer duration of time. And that is what the principle is for using an RF. And just to clarify again, and that is specifically the reason why we use multiple diagnostic blocks to just confirm that yes, we are ethically correct in doing a RF of the medial branch.
When do you block the medial branch? What are the indications for medial?
Okay, so I think for facetal pain, I would say that it is one of the best choices, because intra-articular facetal blocks, I wanted to show the literature, is not very high quality. So it is the median branch block at 2 levels, which really gives long-term benefit. So that should be your ideal
indication.
Yeah.
Before therapy, I myself give it. Both are very fantastic. And the week before the hypotension is very static. I'm able to complete measure it very fast.
Yeah. Yeah, it is an excellent block. I've been using for last 3 years. Yeah, and I also find, but literature I would say is it does not say that all the patients would have excellent results. So, you have to go with a clear mind that, at times the patients may not do very well. So we are still, I would say the jury is still out, and it's a good, easy block. No harm in using it.
When do you give that, sir? How many minutes?
Structure for pain.
So,
your teacher, Dr. Bhattacharya, started Center for Acupuncture.
So these days also we have dry needling. I tell you, specifically the area you are showing for trapezitis. My trapezitis trigger points, I'll tell you that dry needling is one of the best, because, and again, it is the commonest cause of pain. So many neck pains come, they are really trapezitis and not truly neck pain. And dry needling, or you may use acupuncture, is really good for it. So you are asking questions out of course.
In 19, the Indian Institute of Naturopathy started in 1930. The Indian Institute for Naturopathy started by Dr. Mehta in 1938 in Pune. And even it's now they called Indian, so there's a talk about mud therapy, heat therapy, cold therapy, mantra therapy, music therapy. There is a center for music therapy in Los Angeles. Anybody know? 1948, Center for Music Therapy started in Los Angeles. We do not consider that. That what is the role of mantra therapy for health and disease? In Nature Cure, when the Mahatma Gandhi wrote that book, it's a 40 pages book for 40 rupees. Please go for that book, Nature Care. He talks about cold therapy. We know cryogenic. We know heat therapy. For every pain you use heat. You go to spa for relaxing muscle. Then mud therapy, mud. Then there is a Ram therapy. Then there is a mantra therapy. Everything is scientifically based, which was supposed to be nature cure. What's your concept in nature therapy?
Very poor, sir. I don't have.
We give medicine. Any naturopathy?
What? Yeah, cupping again is a upcoming thing. We send it to the physiotherapist. Yeah. Thank you. Thank you so much.
Before he start, I can tell one new I very lot of geriatric patients. A person at 70 years take about 10-30. So you are a long way away from 70 years. And a person at 80 years takes 15 minutes. Believe or not. You know that? And backache and pain is one of them. Sleep, diabetes, blood pressure, asthma, arthritis, backache, sleep, joint pain, spondylitis. People add all these in 15 medicine and 80 years. So try to be naturopathic sleep than all 10 medicine. You know, naturopathic can cure diabetes and blood pressure.
Thank you, sir. Thank you, chairpersons, for chairing this session on blocks. May I request the chairpersons to kindly felicitate the speakers. May I respect Professor Mahapatra sir, Professor Dureja sir, to kindly come on the stage and felicitate the speakers.
You should have put all the your.
May I request Dr. Devesh Goi to kindly come on the stage. Dr. Dureja sir, please.
Actually, my work is my OT-2 reduce. You know that?
Dr. Mahapatra sir and Dr. Dureja sir will be felicitating Dr. Devesh Goi. Dr. Devesh Goi, additional professor in anesthesia at Main AIIMS. May I request Professor Mahapatra sir and Professor Dureja sir to kindly felicitate Professor Virendra Mohan sir. Professor Virendra Mohan sir and Professor Devesh sir are continuing the legacy started by Dr. Dureja in the Department of Anesthesia at AIIMS. May I request Dr. Mahapatra and Dr. Dureja sir to kindly felicitate Dr. Navdeep Sokal. I thanks Professor Mahapatra sir and Professor Dureja sir for this felicitation. Now moving on to next session. Next session is on neurostimulation, ablation and miscellaneous session. I request chairpersons to kindly come occupy the chairperson chairs. Chairpersons are Professor KVL Narsingh Rao, Professor Navdeep Sokal, Dr. Anirban Banerjee, and Dr. Ajay Chaudhary. I hand over the mic to chairpersons to proceed with this session's proceedings. नहीं इनका नहीं था मैं बता रहा हूँ दुर्जय सर का खोल दुर्जय सर ये इस खोल ये वाला ये खोलो यार थर्ड ठीक
Good evening everyone. So we have called the first speaker, Professor J.P. Dureja. His talk would be on epidural traditional lysis using Ryan's catheter. Professor Dureja.
Thank you very much. So basically this is what we demonstrated in the afternoon during the live workshop, and we are going to just give a brief description of what it is. And as we were discussing in the afternoon during the live workshop, that epidural fibrosis or epidural adhesions are generally defined as a non-physiological scar formation secondary to local inflammation. So whenever there are recurrent disc herniations, reticulopathies, there is bound to be inflammatory changes, and if it is recurrent, there is bound to be some fibrosis. This is because of the tissue trauma which happens in the epidural space. And of course, the major culprit is a surgery, and if you are repeatedly operating on a patient, you are adding on to the epidural fibrosis and epidural adhesions. And almost it is said that 46%, although I hate to use this term, failed back surgery syndrome, 46% of post-laminectomy persistent pain syndrome, they have epidural fibrosis or epidural adhesions as one of the major cause for pain. And generally these patients who have fibrosis, either because of recurrent inflammation, because of disc bulges or because of surgery, they complain with severe paresthesias. They have leg pain like the one which we demonstrated to you, burning sensation in the back and the leg and back. There is a restricted mobility. We call them a spinal cripple because they are not able to do their activities of daily living. Their sleep hygiene is disturbed. The paresthesia is very unpleasant, and nothing much you can do with the help of medication. You may give high doses of pregabalin, you may give high doses of opioids, nothing works for them. You think that there is something in the mind, you do psycho-cognitive behavioral therapies, nothing works. Bladder and bowel may also be affected if it is the cauda equina which is being affected because of this fibrosis. Typical example, you can see the back of this patient who has been operated twice. A big laminectomy, discectomy and fusion was done once in 2014, 2019. This is nothing. I have had patients who had 7 operations, 7 surgeries of the spine, and he was ready for the 8th one till a neurosurgeon told him enough is enough. Now let's go for a pain management. So this patient presented with paresthesias, leg pain, back pain for last 1 year. Typical presentation of epidural fibrosis, restricted mobility, paresthesias in leg, unpleasant and lot of unpleasantness. So 2 to 4 operations, typical patient who would come with fibrosis would be MRI showing arachnoiditis and epidural fibrosis, recurrent disc herniation, non-restorative sleep, hardly 4 to 5 hours. And of course, if you do a subjective or objective evaluation, you will find that they are depressed and anxious because of the chronic pain. They have family problems, socio-economic problems, high dose of opioids. Unlikely that further surgery will help in management of pain. Often, as I mentioned, referred to as failed back, but it is better to call it as a post-operative chronic leg and back syndrome. And as you see, there is, the MRI would show you arachnoiditis and perineural fibrosis, epidural fibrosis, and I am sure as surgeon you would also agree with me that even another further surgery is not going to help. There is a recurrent disc protrusion, as you can see, the recurrent disc protrusion and lateral canal stenosis. All these are adding on to the problem. So basically you are left with no choice but to do something which is called epidural adhesiolysis. The diagnosis, of course, you can do a laboratory workup. If the patient has been operated recently, you may find some infection maybe. So just to rule out infection, because if you are doing any intervention, there should not be any post-operative infection. The best, as we were discussing in the morning, is a MRI with a contrast. So gadolinium MRI should be the best one to tell you whether there is enough of arachnoiditis or fibrosis contributing to the symptoms. So that's the best diagnostic test to find out whether a patient has epidural fibrosis. So once he has fibrosis, basically what do you do? Of course, surgery is out because any further surgery would add on to this problem. So we do a mechanical dissolution of this epidural fibrotic scar, which is resulting in axial pain or radicular pain, and which is refractory to conservative management. So of course you have given transforaminal steroids, you have given epidural steroids, but nothing is working. So what do? Basically you can do an intervention with the help of a specialized designed catheter which is called the RAX catheter. RAX is a pain physician in US who designed this catheter, and it is very helpful. All the morning we were doing with a epidural catheter, but this is a specially designed catheter which can move along the areas where there is fibrosis.
There is so much crosstalk here. Can we have some silence for the speaker? Everybody please quiet it down.
Wow, great. What a relief. So, so this is the C-arm positioning, generally done in prone position. And the best route would be a caudal route if you are targeting up to L4-5. But if it is L3-L4 or L2-L3, you may have to go through a interlaminar approach. But just like you put a spinal cord stimulator needle, you have to be going obliquely, touching the lamina and then entering into the epidural space so that you can negotiate your catheter to the higher ups. But for L4-5 and L5S1 region, you can definitely go through this. So this is a RAX catheter, and you see this is a specially designed epidural needle which is curved, and this is the catheter, this is the stellate, which is steel, and this then generally goes into the steel, the spiral tip catheter with a 15 degrees bend, and you can negotiate this catheter. Of course, on the fluoroscopy you see this catheter, and you keep negotiating into the epidural space wherever you find adhesion after doing an epidurogram. Through the caudal root, the catheter is inserted. So first you put a dye, as you saw it in the morning, outline the adhesions and the targeted nerve root, like we saw the right-sided L5 was not being delineated. You put some hyaluronidase, about 1500 units, 10 ml of preservative-free saline, which could be hypertonic saline, along with 40 milligrams of triamcinolone. And then you keep the catheter there, and for 3 continuous days, admit the patient and continuously infuse local anesthetic hypertonic saline to break the vicious cycle, as well as to break the adhesions which are there in the epidural space. And the same procedure is repeated after 6 to 8 weeks to get a very favorable results in terms of these adhesions. So this is what you see in an epidurogram, a typical Christmas tree appearance, but there is a filling defect in this region. So this particular area has to be targeted, and then we put this catheter in and then negotiate this. You can see the catheter going right up to the L5 nerve root, and we are putting the dye. You can see now the lateral recess is open, and you can see the S1 root also is getting open, unlike in the epidurogram which you saw no S1 and no L5. So this is how this adhesive lysis is done. This is the catheter through which, specialized catheter which has a filter also, which is put in, and then we tunnel it and then keep it for 3 days so that you can do a good infusion. Dural puncture can happen because this is a stellate which is made of steel. So if you are pushing it hard, you can and there are adhesions there, so you can produce a dural puncture. You can have the medications going into the subarachnoid and subdural space. Catheter can shear. This is a major complication because while pulling out the stellate, you can shear the catheter, and some part of the catheter can remain there. This has happened. Infection, then of course hemodynamic instability, bleeding or aspiration from the epidural space, and of course there will be dermatomal numbness if you are using large amount of local anesthetic. Thank you so much. Thank you. In time.
We have time for 1 minute for the questions. If anybody has any questions or any comments are there. Yeah. Go ahead.
Yeah. Like if you get a favorable result with the first procedure, you can repeat it after maybe 8 weeks. If you get a favorable result. Generally this fell back like post laminectomy persistent pain syndrome, where you expect adhesions, and you have done a contrast MRI which does reveal epidural fibrosis, or a patient who has recurrent inflammation, because recurrent radiculopathy because of disc bulges, there also you can expect this. So those are also the patients where you can do it.
If a past surgery is done properly,
Yeah.
proper indication, tail back syndrome will not exist.
See, basically it is not a failed surgeon, it is the back which has failed. No? So don't think that it's a failed surgeon.
Inadequately performed surgery or inappropriate method. Suppose I have a joint arthropathy and you have to put the
Yeah.
wrist. Not going to happen. So before we do any surgery, understand the pathology. The pathology is the backache is not only disc prolapse, osteoarthritis, osteoarthropathy, osteoporosis, vitamin D deficiency, so many things, and we just jump to a small disc. And you know, cesarean and disc operation is the most unethical operation. You know that in the world. go to see that. Out of 2 major unethical operation in the world, 7 million unethical operation done in US per year, and mostly is cesarean and disc operation. If you don't believe, go to next.
Sir, I have a question. You told that you infuse the hypertonic saline over 3 days. So, do you give bolus or at what rate?
Bolus of hypertonic saline, infused normal saline.
Infuse normal saline. So, at what rate you infuse it?
So basically, either you give boluses or you can give about 1 to 2 ml per hour. Of about 50 ml in 24 hours.
So, continuous 24 hours?
Yes.
Okay.
With an ambulatory infusion pump. So you have those elastomeric pumps which we filled up with small doses of local anesthetic and saline and continue the infusion. And every day we give 20 milligrams of tamsunolone.
Okay, 20 milligram tamsunolone and 1 ml per hour.
50 ml of local anesthetic and saline for 24 hours.
Okay, thank you, sir.
How many, sir?
3 days.
3 days.
So epidural fibrosis is a real problem.
It is.
Many a times you repeatedly feel that. Isn't how far it is efficacious in those cases where?
To be very honest, it gives very temporary relief. It is not a permanent solution. These are the candidates where we are stimulator. So these are the most appropriate candidates for spinal cord stimulation device.
Do you find in your experience like repeated epidural injection can cause epidural fibrosis?
Well, the literature definitely tells you. That's why like the American standard also, the Indian standard also, we don't go beyond 3 in a year. But my personal, I don't go even maximum 2 in a year.
So what we found in, surgery for prolapsed disc, when there is more than 3 injections, there is good amount of fibrosis.
It is there in the literature, but it has not been sort of validated in human beings. These are studies done in sheep where they did epidural injections every 4 weeks and they found some fibrosis. But in human beings, this has not been revalidated, or even MRIs have not confirmed that there was any fibrosis. But yes, surgeons' anecdotal experiences do say.
So I think we can move to the next lecture by Professor Durga sir.
Yeah.
The CRPS and update.
Yeah. So Dr. Rajeev requested me to take this topic also because this is a very important topic. Slide down. Yeah. So this is a complex regional pain syndrome, a very common syndrome which we encounter in our practice. And this is like a typical patient who would come to you. In the 70s, these patients used to go to the rheumatologist because they had swollen fingers, trophic changes, not being able to move their fingers, and the GP used to send them to a rheumatologist thinking that it is a rheumatoid arthritis. So this is a typical patient complaining of severe wrist pain. He had a cast because of a radial fracture, and after removal of the cast, patient is complaining of burning pain, numbness, tingling, and you can see dark swollen finger, the inability to you can see that the subtle change in the color of this color of the hand. This is darkish, this is pinkish, and you can see the swollen fingers, trophic changes, etc. So this is a classical CRPS. This is an acute phase of CRPS. This is a chronic change. This is the stage 3 where the trophic changes have already set in. And again in the lower limb, it's an acute phase of CRPS. This can follow any trivial trauma also. An ankle sprain, patient may develop a CRPS. Or simple fracture, 2-3 weeks of plaster, and patient comes out with this. Why is it called complex regional pain syndrome? Because it's a very complex pain, varied and dynamic clinical presentation. Regional because it's a non-dermatomal distribution of pain, not in that dermatome where the pain occurs. Pain is out of proportion. It's a very trivial injury. Some friend holding the hand and twisting the arm results in CRPS. And the pain, the syndrome, because it's a constellation of symptoms. The constellation of symptoms are like pain, sensory, autonomic, motor, or trophic symptom, which can no longer be explained. A trivial trauma, like you have just hurt your wrist and developing this. Paul Sudek, we used to call it as Sudek dystrophy. When I joined my MBBS, we used to call it as Sudek dystrophy. And Sudek was the one who in 19th century defined the signs and symptoms of reflex sympathetic dystrophy. He used to call it RSD or Sudek dystrophy, where there was an exaggerated inflammatory response. And then, of course, there was a osteopenia, osteoporosis, and all the associated signs and symptoms of dystrophic changes. The term CRPS came when this International Association of Study of Pain came, and they found there are 2 types of CRPS. CRPS type 1 with no nerve lesions, no nerve injuries, and CRPS type 2 where there is a nerve injury. And as neurosurgeons, you see a lot of patients with brachial plexus injuries, causalgias, peripheral nerve injuries because of trauma. These are all patients who have developed CRPS type 2. So type 1 initially is primarily warm, as you saw, pinkish and edema, that's a warm phase, and then it goes into the cold phase. So you should not allow the patient to go into the cold phase. The diagnosis should be at the earliest, and the treatment should start immediately. This is one patient which was sort of referred to me long time ago in AIMS only, from a neurosurgery department. He had a brachial plexus injury. He had a very severe allodynia that he had to always cover the arm for the hand with a cloth, and he used to keep pouring it. So that sort of a burning sensation he used to get. He had a history of trauma. The brachial plexus was injured. There was no motor movements, but the pain was really exhausting for him and very severe. So as I mentioned, acute warm phase and cold phase, and this is the diagnostic criteria. They should have at least one symptom out of this sensory, pseudomotor, motor or trophic, and at least one sign like allodynia or temperature differences, so you can measure the temperature, or there should be motor like decreased range of motion. So these are some of the reported symptoms, and these are signs which are observed on examination. If the score is 16, this is a patient who has compressed regional pain syndrome. How to diagnose? Basically, you can rule out, like I said, rheumatology. So you can rule out by doing ESR, CRP to see. Initially, yes, in the warm phase, all these would be elevated. Anti-nuclear antibody, RA factor to rule out any rheumatological disease. And then the confirmatory test is a triphasic bone scan or X-ray. X-ray will show you localized osteoporosis. This is very significant osteoporosis, and a bone scan, triphasic bone scan, will show you the pooling of the dye in the third phase of the bone scan, and this is confirmatory. Any person with nuclear medicine experience will tell you that this is a typical bone scan of a patient who has CRPS type 2. Of course, you have infrared thermography. If you have this apparatus, you can take the temperature and you will see the difference between a normal and an abnormal hand, again confirming that this is complex regional pain syndrome. So the pathophysiology, whenever there is an insult like trauma, surgery, stroke, there is a classical inflammation, exaggerated inflammation. Then there is a neurogenic inflammation. That's why patient complains of burning sensation, autonomic dysfunction. That's why it's called sympathetically mediated pain. Central nervous system plasticity, psychological factors, all these contributing. So whenever you're treating CRPS, you have to take into consideration all these factors while considering the treatment part of it. Inflammation is very important, and sympathetic nervous system, like when we started, CRPS was like a sympathetically mediated pain, and we used to be told that you go and give a sympathetic block, patient will be better. But sooner or later we realized that it is not entirely the sympathetically mediated pain, only 50% is sympathetically mediated pain. The initial terminology, reflex sympathetic dystrophy, also mentioned that it is a sympathetic overactivity, but later on we found that it is an inflammation which leads on to this phase, and 50% of patients would be having a sympathetic overactivity. Multiple discrepancies undermine the possibility of sympathetic nervous system as a cause, like plasma catecholamine levels are lower. Most patients do not get a significant relief with sympathetic blocks. So that's why the terminology came in, sympathetically mediated pain or sympathetically independent pain. So doing a diagnostic block, if a patient gets relief, it says SMP. If he is not getting relief, it is a SIP. So we have various therapies, starting from medical therapies, like vasodilators, physiotherapies. In the acute phase, you can even put in steroid, like methylprednisolone, succinate infusions. They can really help. Of course, psychotherapy, sympathetic nervous blocks like stellate ganglion or lumbar sympathetic blocks can also help. Pharmacological treatment generally are steroid, bisphosphonates, calcitonin, vasodilators like nifedipine. And of course, gabapentinoids are also preferred because there is an element of central sensitization. What we have got good results with a intravenous long-term ketamine infusion. Bisphosphonates are very good. As you saw, there is a localized osteoporosis. So immediately, as soon as you diagnose, you start the patient on bisphosphonates, either oral or parenteral, and they really work wonders. Tricyclic antidepressant, IV lidocaine, calcitonin, very important again, gabapentin, nifedipine orally. Sympathetic blocks do work in the sympathetically mediated pain, so should be tried. But what I want to lay emphasis is on a new therapy which is called intravenous ketamine infusion. This is a stellate ganglion block, and you can see the patient is having a Horner syndrome. 3 months post-modal therapy, post-multimodal therapy, after stellate, this patient is doing wonders. Now, ketamine infusion do have a role. And ketamine infusions, what we do is we give in a dose of about 1 milligram per kilogram body weight, and dissolve in normal saline and give it over a period of 4 hours. And every day we increase the dose. We give it for 6 to 10 days. We increase the dose by 25 to 50 milligram to go up to maximum of 300 milligrams in 24 hours. And this is an NMDA receptor antagonist. Unfortunately, we do not have any oral drug which can block the NMDA receptors, but this works wonder. To be done under monitoring, to be done in a hospital setup, but fantastic desensitization, because NMDA receptors blockade happens, and the desensitization can only be helped with the help of these drugs which act on the NMDA receptors. Then mirror therapies are some sort of like whenever there are trophic changes, the mirror imaging graded therapy can help in mobilization of the, otherwise these trophic changes are very difficult to handle. So imagery, mirror imaging, like patient places a normal hand in front of the mirror, abnormal hand behind the mirror, he moves the normal hand, and involuntarily the affected hand also starts moving, and this is a very good physiotherapeutic or rehabilitation mode. So graded motor imagery, as we call it. So the carry home message is that CRPS is a constellation of pain, sensory, autonomic, motor and trophic symptoms. It is heterogeneous and a mixed pathophysiology. Some of sympathetic nervous system cause is there, definitely 50%. But the combination therapy helps, which involves pharmacotherapy, psychotherapy, physiotherapy, occupational therapy, and of course therapies like intravenous ketamine and sympathetic blocks. Thank you. Thank you very much. If there are any questions.
Sir, I think I'd like to add that hyperbaric oxygen therapy has a role in complex regional pain syndrome. It decreases inflammation and the swelling at the earliest and helps to rehabilitate.
Okay.
If there are no further questions, yes. Okay.
And he had undergone multiple surgeries in the he had put it in the shoulder, the occipital region, in the back, and he said he had severe pain which is not responding to any analgesia. We thought over and particularly injected ibuprofen and ibuprofen steroid in the regional pattern wherever the cluster of threads were there. And retrospectively, I think that it was something of a
Absolutely. Yes.
See, that is the reason for a long back, people have done frontal liquid to have the perception pain changed. See, when everything failed, if you go to olden literature, to treatment of intractable pain, frontal leucotomy. So that the reaction to pain will not there. Prefrontal leucotomy.
Yes, sir. And if there are no further questions, we will move to the next presentation by Dr. Energy on spinal neuromodulation.
सिंपोजियम बंद कर दे ये वाला Good evening, respected chairpersons, seniors, especially Dr. Mahabharata. Good to see him again, and my dear colleagues. So, what is neuromodulation? By definition, it is the alteration of nerve activity through targeted delivery of a stimulus, such as electrical stimulation or chemical agents, to specific neurological sites in the body, depending on the pathology and the need of your treatment. So this is the basic definition. Now, if we extrapolate this to say any neuromodulation for today's topic, spinal neuromodulation,
we can divide it into two broad groups again. One is electrical and one is chemical. In electrical, you have spinal cord stimulation, especially mainly or rather ethically used for pain. Then sacral nerve stimulation, some people consider it peripheral, but because you access the S3 through the spinal foramen, you can stretch it into this. And in the chemical group, you have intrathecal baclofen pump, intrathecal morphine pump, the first for spasticity and the morphine pump for intractable pain, especially oncological pain. But because of the theme of today's symposium and with respect to time, I will concentrate my talk today on my experience with spinal cord stimulation for pain. And I would like it to be an interactive session because I face many problems doing this, and would be glad if I get some answers from the august audience. So, coming to the basics. So, pain is like, it's just like there's a plethora of pain disorders. So, first and foremost, we have to pick up the right patient. For that, our basic, this is the, so two important words, neuropathic and chronic pain. So for any neuromodulation to succeed, the pain has to be ascertained as neuropathic. I will not go into the base definitions because the august audience is enlightened to it. Two words, chronic pain lasting more than 3 to 6 months, and it has to be neuropathic. Now this cluster of pain, chronic neuropathic pain, is a tough nut to crack. There are various ladders and algorithms explained, but many cases, the last resort always falls on neuromodulation. So there has to be a sort of a running protocol. Different institutes have different protocols. In our pain clinic, what we follow is the patient with a chronic neuropathic pain should have at least tried judicious use of pain medications, physical therapy. Once these two are exhausted, not less than 2 interventions, whether it be a block or a corrective surgery. If these procedures fail, then the patient's, after ascertaining he has a neuropathic pain which is chronic, becomes a candidate for neuromodulation. And coming to the spinal cord neuromodulation, again from the same protocol what we discussed in the previous slide, there are two main syndromes which fall into that category. One is the failed back syndrome, which, Dr. Mohabbat has an objection with the term, but it is mainly, as you rightly elucidated in the previous discussion, it's mainly an improperly selected patient or an improperly done or overzealously done fusion, rather than, a simple failed back surgery. So it's again goes back to the patient selection and the procedure selected. So that is one of the major indications for chronic neuropathic pain spinal cord stimulation. And second is, of course, CRPS type 1. The mechanism of action, it's still fuzzy. So there are various hypotheses which runs from stimulation of the dorsal column leading to gait control, increase in the concentration of the inhibitory neurotransmitters and decrease in the concentration of excitatory neurotransmitter with chronic stimulation, increased activity of the inhibitory interneurons, and also some supraspinal mechanisms which are implicated for the success. But the jury is still out regarding the exact mechanism of action, but it does work in properly selected cases. Now, why not an ablative surgery? Why such an expensive surgery? So there are definitive advantages. Not only it is a non-destructive and less invasive surgery, that is a given, but it is reversible. And if the pain increases or pain relapses, we can reprogram the device and go one up over the pathology. Almost, it provides you with a scope of a trial. Before you commit to the final therapy, you can have to do a spinal cord stimulation trial, which gives you an opportunity not only to gauge the patient response, the coverage area, as well as the response of the pain. It also provides an adjustment period of say around 5 to 7 days. And we have a thumb rule of a 50% reduction in pain in, say, a visual analog score. If there is minimum of 50% reduction at the end of the trial period, then you can counsel the patient that he is a reasonable candidate. Still, you can't predict 100% success, but you can say he is a reasonable candidate for a spinal cord stimulation. The dilemma starts here. What will you put? A percutaneous lead or a paddle lead? Now, my practice over the last 12 years has shifted, and now it started with purely percutaneous and now it is purely paddle because of these very reasons. Unlike a percutaneous lead, a paddle lead provides less scope of lead migration. It's anchored to the dura. You can connect it with, stitch it up with the surrounding connective tissue. So, because the migration is, there is less positional variation. And the footprint of a paddle is much greater. It gives you a better footprint, you can have a better coverage with a single lead. What I do in my trial periods, I use a paddle and then connect it with an extension wire. The extension wire is the one which is exposed outside for the trial. So if I get benefit during trial period, I don't have to take out the trial lead. I will keep the trial lead and just remove the extension wire and hook the trial lead with a new extension wire and internalize it. So there was always a danger with percutaneous leads that once you have a good trial, when you remove it, there is no guarantee once you are putting the final lead, you will hit the same spot. But a paddle lead negates that possibility. And of course, if you are doing a small laminectomy going in, an epidural scar is a predicament to the infiltration of the current into the dorsal column. So you can clear the epidural scar and hope for better efficacy of the spinal cord stimulation. So various reports are there in literature which confirm these advantages. We had our experience from Vedanta published earlier this year in AJNS, and it also verifies that paddle lead has got definite advantages over percutaneous cylindrical leads. Technological step is the simplest of all surgeries which anyone can perform. So you just have to do a small laminotomy depending on the area where you want the spinal segments to be covered. For example, here I have put a quadripolar lead on a cervical for a upper limb CRPS. Here there is a dorsal paddle lead 565 configuration for a failed back syndrome. So the spinal segments you select according to the clinical the distribution of the pain. Under fluoroscopic guidance, we put the lead. It's a very simple thing. Do a small laminotomy, clear the epidural scarring, and just put it. The laterality you can adjust a bit. Suppose it's more unilateral, you have to shift towards one side of the center of the axis. That small adjustment, the simple adjustment you can do during the procedure. Once you have a successful trial period of say, at least 50% reduction in pain, the second stage after 5 to 7 days, you internalize the system, take away the old extension wire and connect the paddle lead which you have used for the trial with a pacemaker and internalize it, and that's the end of the surgery. Programming strategy, I usually use wide bipolar combination so as to have maximum pain coverage area, pulse width of around 210, rate varies depending on the response, and I tend to have different programs for different activities. There's a reason for it, I will come to that. So my personal experience, limited though, 31 cases, 23 were failed back surgery cases and 8 were CRPS type 1. The point here I want to make is, it's very all hunky-dory and rosy for the first 2 years. Patient will come to your follow-up and say, I'm doing fine. Problem starts after 24 months. As you can see, there is a sharp increase in the visual analog score scale after 2 years follow-up in my cases. So at the latest follow-up, the average VAS was 4.1. So patients are not doing that well, which they were doing at the start of the surgery or even up to 2 years. So this is something which I am sure with doctors who are into spinal cord neuromodulation, this is something which is nightmare for us. The effect diminishes with time. There are various causes for that. Causes and hypothetical causes like maladaptive neuroplasticity, disease progression, diminution of placebo effect. But once you rule the obvious complication of lead migration and everything, you come to a point where you have to do something to the patient. There are some strategies which you can do, like periodic fine tuning of programming parameters, set different programs for different activities to negate habituation, on-off strategy, burst spinal cord stimulation. There are certain what do you say, newer innovations coming up, like high frequency stimulation, not yet in India, and specific dorsal root ganglion stimulation for patients who were now refractory to even spinal cord stimulation. So what does the evidence say? I just conclude it in a short one, 30 seconds. So on long-term, utility of spinal cord stimulation, there is the plethora of literature. But there are two meta-analyses which I want to point out. One is by Duarte et al. In 2020. The conclusion was conflicting in long-term efficacy. Up to 6 to 24 months, it was good, but in long-term, there were, there were low to moderate quality evidence to say what happens after 5 years down the line. And most authors who were in these trials had conflicts of interest, industry-based. Another meta-analysis which had 12 randomized control trials in its parlance. See the last line. 11 of the 12 studies were industry-sponsored who told that the relief is more than 24 months. The only study which was non-industry sponsored, they said that the nerve stimulation method, they didn't find any difference compared to a traditional method or using an advanced spinal cord stimulation. So you can see the gray area. So if we have to have solid evidence based on which we predict to the patient that you will benefit this much and this is your prognosis, we need to have evidence also. At present, till 2020, most studies are industry-based, industry-sponsored, and that leads to a great bias in concluding and confidently relating the outcome to the patient. Nevertheless, despite everything, if you have a good case selection, the results can be marvelous as well. The case in point is this present study. I will conclude my talk with this study. The 40-year-old gentleman was suffering from CRPS type 1, and it was so severe. It started on the left, marched to the around the neck and to the right upper limb, that he had developed reactive spinal myoclonus. Everything has been tried on him. Then after evaluation in our pain clinic, we offered a retrograde high cervical C1, C2 approach, paddle lead, and not only was he free from his pain, and we have now a follow-up of 72 months, because the pain went away, his reactive spinal myoclonus also disappeared. So these are some videos. You can see this patient was having such severe pain of CRPS that it was like a miserable life. Just to touch, a simple touch, he will throw into this vigorous spinal myoclonus. And this is the patient during the trial period, the second day of trial. You can see I'm touching him, there is no myoclonus, and the patient is quite happy with it. And next. Sound to this video. So there is a patient testimonial to this. I will skip it then. So the patient is saying that
about a week back with complaint of excruciating pain in both his upper limbs and the back side of the neck area, which he has been suffering for the last 12 years following a road traffic accident. Pain was severe, so much so that even to light touch, a feather touch, or the touch of a clothes, it will initiate violent jerks or involuntary movements. Like he will be like ferociously throwing his upper limbs back because of this very rare but excruciatingly nagging disease, what we call as complex regional pain syndrome.
40 डॉक्टर से मिले, पर वो कोई इधर भेजता था, कोई किधर भेजता था, उनके समझ में था कि मैं कुछ करे क्या, सबके पास आए तो उन्होंने समझाया सब कि देखो इसमें
with all due respect, Dr. Juneja was also one of those doctors. He gave him temporary relief with peripheral stimulation, but then couldn't carry on further.
लेकिन ऑपरेशन चलाओ और उसके बाद मुझे अभी तक जलने आया 6 तारीख के बाद जो सेंसेशन था वो 80% रिड्यूस हो गया है.
the retrograde high cervical related spinal cord.
So I'll maybe
it's a pioneer
on the video
in India.
So this case study was published in BJNS, and coming to the conclusion, so spinal cord neuromodulation for chronic pain is on the upswing, but the most important thing is proper patient selection. The thing which I am being plagued with is someone give me some thoughts or some strategies to prevent the temporal diminution of effectiveness. And there should be proper clinical trials which should be industry independent to give honest outcome to the patients. And of course, with better understanding, neurophysiological understanding of the pain pathology and improvement in technology, we will have better results in future. These are some references. Thank you.
Thank you, Anil. Wonderful presentation. Because of short of time, we will move to the next presentation.
So next presentation by Dr. Siddharth Chowdhury. He is the eminent intervention pain physician in the Hyderabad, and he is our excellent president also. So Dr. Chowdhury, please. So he will be talking about non-invasive transcutaneous neuromodulation.
I'd like to thank the organizers for inviting me to talk on this gathering. We've talked a lot about interventional pain options, and we've talked a lot about interventional neuromodulation. So my topic is something slightly more esoteric, and once we can get it set up, I am basically going to be talking about transcutaneous non-invasive neuromodulation. So essentially it is going to be a mechanism where we modulate the autonomic nervous system to achieve let us say functional outcomes in certain disease processes. They may not necessarily be pain. We're talking about diseases which are, come under the purview of cardiology, urology, gastroenterology, even pediatric surgery for that matter. So if you'll bear with me for just a second. मैं आपको मेल कर दूं, ये जल्दी होगा तो
So we can move to the next talk. So we can move to the next talk. We can extend the time to rectify this issue.
No, sir. So I think they're just looking for the cable.
Can we, if there is some technical problem, can we move to the next presentation? Dr. Dev called radio frequency and spinal pain management.
Yes, sir. Yeah, thank you so much. Okay, so this is my last presentation for the day. So today you would have seen me doing radio a radio frequency ablation. We only did one, and that was done by cool tip RF or cool lift radio frequency. So I will just start from where I left today morning when I was discussing radio frequency. So there I said that in traditional radio frequency, you need to be very clear with regards to anatomy. That is one. The active tip of the needle has to be placed in direction to that nerve. Right? So therefore you have to be very precise regarding the anatomy. Then what happened, and that was second, and the third was that we have to have a control over the temperature, because if we keep on burning or increase the temperature, there is going to be burning, which will lead to charring, and that will effectively stop the transmission of heat or electricity leading to heat in the surrounding tissue, and hence our radio frequency probe or the process will be not so effective. So imagine with that concept, what these guys did was they introduced a continuous water column at the active tip, by which the tip never got heated to an extent that the charring would happen. What advantage it made for us was, first was that we got a lesion which was, in a case of a standard RF, like a flame-shaped thing, oval shape, and we had to be very close to the nerve or our target. In this case, and for people lazy like me, where you and you are dodgy with your anatomy, so only if you are close to the nerve, this produces around 15 millimeter size of the lesion. That will make sure that even if you are here or there or not perfectly in direction, you can still achieve that lesion. That is one. Second is the charring, the chance of charring and everything gets grossly reduced. So with that concept, this cool radio frequency technology came into being. So what happened is, this is what I was exactly trying to explain, that you have a flame-shaped lesion and which is not there in front. So active tip has to be in direction with the nerve. Whereas when we talk about this, is there is a round lesion, that is one, bigger lesion, that is number two, and the third thing is that it is even in front of the middle. Therefore, when you could see me perform that median branch now, I could just be right at the middle, and I was sure that I could create that lesion. Whereas if I had to do it in the case of a standard RF, I had to be very sure that I was right in the place where the nerve is coming. Again, this is the temperature. This is 60 and 80. This is our sweet spot. If the tissue goes beyond 45, there is denaturation leading to ablation. So this is our sweet spot. So this is the entire thing where we can get that thing. This is the machine. This is the size that I was talking about. So 18, so entire thing comes out to be 15. This is the particular lesion size. Now one more thing, it is not, everything is not so positive about it. The few challenges what I have felt is that here it is a thicker needle, right? So it is, because it is a thicker needle, 18 gauge or sometimes 16 gauge also, therefore post-procedural pain is one issue that we need to be careful about. That is one. Second, not pertaining to spine, but sometimes if we are doing a radio frequency ablation of a superficial nerve, for example, a genicular nerve RF of a knee, especially the inframedial nerve, it is a very superficial nerve. So there are chances that we might damage there might be skin burning. And post-procedural pain is definitely an issue. Third thing is that if we have any blood vessels within the vicinity of that nerve, the chances of hematoma are quite high. So that are the few disadvantages. Otherwise, it is quite an effective modality when it comes down to providing good pain relief. Now, this was something we probably have tomorrow. So this is the cervical facets. These are the cervical facets, and this is a cervical median branch block. Again, very effective treatment. Now this is what I am doing it in a AP view. We can do it right in the AP view as well as in the lateral view. So this is what we call it as the articular pillar. We just need to be at the center of the articular pillar. This is what we did today. Now again, interestingly, we talked about a lot about the facets and everything. So there is something included which we can do for a discogenic pain also. We can do a biculoplasty, in which we are getting a bipolar kind. We are introducing two needles inside the disc, and both these discs are in the posterior annular part, and where we are denervating so this is done for discogenic pain where it is more of degenerative changes rather than debulking what is required in those spine patients. So a small thing, it's an effective method, gives us a large margin of error, and good evidence is there for long-term relief. But what Sir just talked about, I do believe that what of data that has come out in the recent past is company sponsored, and this is one thing which I always feel. But right now what I feel is that the results are equipotent to the ones of standard RF. Only thing is that you can be slightly more casual when we are doing it. Post-procedural pain, that is one thing which is a thing of bother. Thank you so much. There were a lot of questions when post-procedure, so if you have, please ask. We have a few. I can take, I think, a couple before we start. Any questions? Yeah.
What are the areas where we cannot inform to the RF?
Very good. So the thing is where you don't want to create a larger sized lesion. So for example, for a trigeminal, where you will never go for a cool because you want a smaller lesion. Something like an intercostal neuralgia, you will not like to go for this kind of a thing. But most of the other causes where it is giving you that margin, for example, the denervation of the joints like knee, shoulder, hip, SI joint, where you want large, big lesions, splanchnic nerve block for patients of upper GI malignancies, there definitely you can go for this versus the standard RF.
One more, with the advent of pulse RF, how do you see the cool RF?
So, sir, the thing is the pulse RF is not a neuroablative procedure, it is more neuromodulatory. So, where we want to do ablation, the choice is very clear. It is between standard RF or cool tip RF. But if you want to do something like a neuromodulatory action, there we can use pulse radio frequency. So for example, what I generally do is, if I have a patient of a chronic carpal tunnel syndrome, so what I'll do a nerve block, along with that I'll do a pulse radio frequency. So that will actually help in the recovery. The same goes if I have a patient of chronic adhesive capsulitis, patient has been restricted movement for a long time, so there I will go for a radio frequency ablation of the suprascapular nerve. Fine. Thank you so much. Any questions? There were a few when we were doing the procedures. Fine. Thank you so much. Yeah, thank you so much. Take care.
The next speaker is Dr. Siddharth Reddy.
Yes, hopefully.
He's talking on non-invasive transcutaneous neuromodulation.
अभी चल रहा है क्या तुम्हारा? That's fine. एक मिनट. Yeah, so we're going to be talking about transcutaneous non-invasive neuromodulation therapies. So basically when we talk about neuromodulation, it is the alteration of any nerve activity through targeted delivery of a stimulus. So whether it is electrical stimulation, whether it is a chemical agent to specific sites within the body. So you want to modulate, so that's either normalize or to attenuate nervous tissue function. Now, we've been talking about spinal cord stimulation, we've been talking about RF, all of these are neuromodulatory modalities. One that we haven't talked about is percutaneous or transcutaneous modulation. So in this presentation, we're just going to run through this quickly. What are the different techniques? What are the outcomes vis-a-vis invasive modulatory therapies? And what is their clinical application? Now, there's a lot of focus recently on using certain approaches when it comes to non-invasive neuromodulation. Primarily, we are looking at either the vagus nerve or the sacral complex. So whenever you have neuromodulation, like the previous speakers said so beautifully, the problem is achieving a clinically relevant therapeutic endpoint, having it stick, optimizing the location where you stimulate, optimizing the parameters of stimulation, and the miscellaneous off-target effects that you get. These are the major concerns whenever you talk about any form of neuromodulation. So now when we're talking about non-invasive neuromodulation, broadly we can divide it into cranial versus peripheral. Cranial, we'll talk about either transcranial magnetic stimulation or MR-guided focused ultrasound, and that is beyond the scope of our discussion today. What we will talk about is vagal, sacral, and posterior tibial nerve modulation. Now, when you talk about the vagus nerve complex and the sacral nerve complex, there's a lot of research about this, because whenever you stimulate these directly, so vagal nerve stimulation or sacral nerve stimulation, this has been approved for epilepsy, it's been approved for major depressive disorder. When you look at sacral nerve modulation, it's been approved for overactive bladder, urinary retention, fecal incontinence. So these are very attractive targets, primarily because for a single nervous complex, they innervate an extremely wide area of tissue. Now, vagal nerve stimulation alone, so the indications can be neurological like migraine or epilepsy, and this can be either invasive or non-invasive, major depressive disorder, chronic tinnitus. A lot of the work we are doing at our hospital is on cardiac and GI neuromodulation, whether it be invasive or non-invasive. So we've been doing a lot of vagal nerve stimulation for conditions like arrhythmogenicity, atrial fibrillation, heart failure with reduced or preserved ejection fraction. GI neuromodulation, and we'll come to that, is patients with functional GI disorders, patients with dyssynergic defecation, IBS, Crohn's disease. So a lot of this therapeutic mechanism of when you stimulate the vagus nerve peripherally, and that's primarily through the ear, is thought to be mediated by concentration shifts of norepinephrine, GABA, as well as acetylcholine within the CNS. So these concentration shifts will lead to changes within the cerebral cortex and alter neuroplasticity. Now, all of us know about the vagus nerve, so it's a major component of the autonomic nervous system, important role in metabolic homeostasis. Neuroendocrine immune axis is another major role through afferent as well as efferent pathways. Now, left cervical vagal nerve stimulation is something that all of you are very familiar with, because vagal nerve stimulators are available for refractory epilepsy as well as major depressive disorders. Right cervical vagus nerve stimulation is the area of interest where you're talking about heart failure as well as GI disorders. Now, the ear basically is an attractive target for when you want to do vagal nerve stimulation, because it's got an extremely complex innervation. It's been innervated by the auriculotemporal, the vagus, as well as the greater auricular nerves. Now, this is basically a relay station that affects other brain areas which are involved in autonomic control as well as pain. So projections of these vagus nerve extend to the ventral medulla, hypothalamus, amygdala, and spinal cord. So this is why when you do a peripheral field stimulation of the vagus nerve near the ear, you can have alterations in neuroplasticity as well as firing rate within the amygdala as well as spinal neurons. So you have significant modulation at the spinal, at the dorsal root level, as well as at the central level. Now, when you talk about the ear, so the anterior superior aspect of the ear is innervated by the auriculotemporal nerve. The inferior wall is innervated by the greater auricular nerve. Now, the superior ganglion of the vagus nerve will give off two branches, and this will innervate basically the posterior superior wall of the acoustic meatus. Now, this area is primarily called the Simba concha as well as the concha. So, these are the targets which we use for auricular vagal nerve stimulation. So when we talked about the auricular branch of the vagus nerve, as soon as it comes out of the jugular ganglion, it basically accompanies the inferior ganglion of the glossopharyngeal nerve. And then it will ascend through the lateral surface of the jugular fossa and run along the temporal bone. So within the mastoid, after that, it will basically course over the canal above the sphenomastoid foramen and then divides into two branches, which is what we talked about. The first branch is going to give off branches to the dura mater, and it has a connection with the chorda tympani, which is a branch of the facial nerve. The second branch will give off two small nerves. One of them connects to the posterior auricular nerve, and the second one innervates the posterior inferior or posterior superior skin of the external auditory canal and the tympanic membrane. Now, this is the nerve we are primarily targeting, the second branch of the vagus nerve. Now, there are a lot of treatment modalities which are available for vagal nerve stimulation. So this is a device which was called Gamma Core. It's non-invasive neuromodulation which is applied directly to the neck, and it's being used for refractory migraine. This is a device which is in development where you attach it behind the helix, and this is what we have been using at our hospital. These aren't commercially available. They actually need to be imported from Australia, but essentially it's a clip, and the clip attaches over the Simba concave or over the tragus. And what you're doing there is you're going to stimulate this constantly with a TENS device, a commercially available TENS device with stimulation parameters of your choosing. And the stimulus intensity is set to whatever the patient can tolerate. And this tolerance is going to keep increasing with duration. Now, when we're doing this in the vagus complex, what we're looking at is cardiovascular, GI, as well as immune modulation. So antidepressant effect of the vagus nerve stimulation. So you have alternation of the connectivity of the default mode network. Like we said, there is a lot of change in the firing of the amygdala, hippocampus, and the hypothalamus. So you have a significant effect on patients with major depressive disorder. Cardiac applications. One of the primary reasons for many cardiovascular disease is an elevated sympathetic drive. So whether it is heart failure, whether it is hypertension, whether it is atrial fibrillation, ultimately what we're looking at is a hyperadrenergic status. So when you do electrical stimulation of the inner tragus, which is this vagal nerve stimulation, you activate parasympathetic efferents. And what it has been seen is you have reduced heart rate, you have reduced episodes of atrial fibrillation, and improved heart rate variability. So this again is a interesting area of research where as far as cardiac conditions are concerned. When we talk about GI neuromodulation, which is what I said we're doing, auricular neurostimulation in adolescents with irritable bowel syndrome improves abdominal pain scores, improves consumption of narcotics, improves depression scores. So you're looking at overall improved quality of life as far as these patients are concerned. When you look at functional gastrointestinal disorders in adolescent patients, you're not really looking to intervene too much in this patient group. And again, you have improved functional outcomes, you have improved cognitive scores, and as compared to sham. Now, when it comes to PTNS stimulation, so because it's very closely associated with the tibial artery, the tibial nerve is called the posterior tibial nerve. So it basically originates from the L4 to S3 roots, which are composed of motor as well as sensory fibers. So now the interesting part is pelvic floor muscles, bladder sphincters, bladder destrusor muscles are all innervated by the same root values. So now when the posterior tibial nerve is so easily accessible, it provides a very interesting area when you want to stimulate it. So the exact mechanism is unclear, but the logic being because the sacral plexus has the same root value and because the posterior tibial nerve is a branch of the sciatic nerve, retrograde stimulation of this nerve will provide neuromodulation of afferent pathways to the bladder. So patients with overactive bladder, incontinence or fecal incontinence who do not respond well to conservative or pharmacological therapies are quite good candidates as far as percutaneous or transcutaneous tibial nerve stimulation are concerned. There is a device by Medtronic which is still not available in India, but again conventional TENS devices can also be used to stimulate with reasonable effects. Now, as far as evidence is concerned, urinary incontinence and overactive bladder, urge incontinence, there is quite excellent literature to suggest that transcutaneous as well as percutaneous tibial nerve stimulation leads to good outcomes. Home-based, this is one major advantage. The patient doesn't have to come to the hospital. The TENS machine is relatively cheap. And it basically involves 30-minute sessions daily for about 8 to 12 weeks. Compliance is usually not an issue. And when you measure it with metrics like urodynamic studies, usually the patients will have pretty good outcomes. Transcutaneous sacral nerve stimulation, like we said, you can stimulate the posterior tibial nerve in the leg. You can stimulate the sacral nervous complex directly over the foramina. So again, the same patient population per se, overactive bladder in children. So they had a study which compared transcutaneous sacral nerve stimulation versus oxybutynin. And what they concluded is that they were both very effective therapies as far as pediatric overactive bladder is concerned. So, but electrotherapy was shown to be more effective over a prolonged duration of time. Thank you. Of which one, sir? So we do a fair amount of cardiology indications for auricular stimulation. And like I said, there is improvement in heart rate variability. The endpoints that the cardiologists look for are kind of different from what we consider. So they look at AFib burden. So when they're doing 24-hour Holter monitoring, so the AFib burden is significantly lower. They're also looking at remodeling and cardiac biomarkers. And while we haven't done it per se, there is a lot of literature to suggest that cardiac biomarkers also improve with time with sustained auricular stimulation. PTNS, we've been doing for primarily patients who have undergone dystrophism surgery. So, I mean, long-term data on that is still awaited, but yeah. Fecal incontinence. Yeah. Correct. Yeah. So as far as fecal incontinence is concerned, sir, it depends on the etiology. If you're looking at somebody who's got sphincter failure, typically the standard patient that we get, because it's a primarily GI setup, is we get patients who have post-LAR syndrome. So they have sphincter failure after LAR surgery. In that subset of patients, if you do invasive sacral nerve modulation, I'm not talking about percutaneous or transcutaneous, you have a 70% improvement in symptoms long term. That is the data that is there. Yeah. Yeah.
So, if there is no further question, I will request Dr. Siddharth to continue with his second talk.
Yeah.
On hypogastric plexus and splanchnic nerve neurolysis for visceral pain.
So, yeah. So this may or may not be of particular interest to a large subset of people here, but
Even before you start, what's the cost of that stimulator which you are talking?
Which one, sir?
This one.
So
One.
if you're doing transcutaneously, the TENS machine typically will retail for around 5,000 to 6,000 rupees. That's it. That's a one-time purchase. If you're looking at sacral nerve stimulator insertion, that's a total package cost of around 10 to 12 lakhs. It's cheaper, sir, but yeah. No, 2-3 lakh का फर्क है.
Yeah, I'm sorry, you can continue.
हाँ, yeah.
You can continue. You can.
Yeah, the auricular nerve thing we imported from Australia, and we are planning to basically produce them ourselves. But that's about 25 Australian dollars. It's compatible with your standard TENS machine. Sir. Correct. Correct. So, visceral abdominal pain, again, it's a complex and challenging issue. It arises from diseases affecting internal organs, so it's very difficult to distinguish it from somatic or neuropathic pain. Can be continuous, episodic, provoked, unprovoked. There is actually really no way to predict how visceral abdominal pain really manifests, which is what makes it difficult to treat. So around 25% of the global population is going to experience chronic abdominal pain at some point in their lives. The patients who typically present to us will have chronic pancreatitis, pancreatic malignancies, other GI malignancies, IBD, or functional gastrointestinal disorders. So again, we talked about the vagus nerve, we talked about the sacral nerve. Grossly, all of GI innervation is the same. So you have vagal efferents, you have thoracolumbar pathways, and you have sacral nerve and pelvic nerve pathways. Now, the primary area of interest as far as we are concerned, where GI innervation is concerned, is thoracolumbar pathways, where efferent axons from the GI tract that respond to painful stimuli, as well as efferent sympathetic pathways are there. So this is the area that we're looking to modulate. Now, when you talk about a splanchnic nerve block, a lot of people are familiar with celiac plexus blocks. So splanchnic nerve block is a kind of extension of the same. You want to do it for chronic abdominal pain, you want to do it for chronic pancreatitis, failure of celiac plexus blockade, patients who have abdominal angina, as it is called, or patients who undergo acute pain after arterial embolization for liver tumors. Now, as far as the anatomy is concerned, the abdominal viscera is going to receive sympathetic innervation from the anterolateral horn of the spinal cord. All the fibers that run from the spinal cord are going to synapse at the celiac plexus. Celiac plexus, just before it, there are three nerves, the greater, the lesser, and the least splanchnic nerve. So the T5 to 9 is greater splanchnic nerve, T10 to 11 is lesser splanchnic nerve, and T11 to 12 is the least splanchnic nerve. So all the three together are going to synapse to form the celiac ganglion. And this is where you typically block it. The celiac plexus blockade, which is conventionally known, are responsible for supplying the abdominal viscera, like esophagus to colon. Everything is celiac plexus. So this makes it a really attractive target as far as abdominal pain is concerned. Now, the reason why we would choose a splanchnic plexus block is because it offers itself as a very good anatomical target. When you look at this, you have an area that is bounded medially by the vertebra, laterally, by the diaphragm, inferiorly by the diaphragm. You got a very well-defined area within the paravertebral space. When you do celiac plexus blockade, you have complications where you're trying to basically bend the needle around the vertebra, and you want to get the drug anterior to the aorta. Whether you go around the aorta, whether you go through the aorta, you're ending up in very close proximity to a major vascular structure. The other problem is most GI malignancies will tend to encase the celiac plexus as well as the different branches of the aorta as it comes off. So this area is a pretty good target as far as it's concerned. You just move one level higher, D10 or D11, and you're able to block the greater, lesser and least splanchnic nerves. Like most of the procedures that you saw today, the patient is positioned prone, buttresses under the chest and the abdomen to reduce the curvature. You want to look at the inferior border of the D11 or D12 vertebra. This is an extremely oblique view with parallax eliminated. The target for the needle is the inferolateral boundary of the vertebra. And essentially what you want to do is manipulate the needle in the space between the vertebra and the rib to move it to the junction of the anterior 1/3 and the posterior 2/3 of the vertebral body. At this point, contrast is usually injected. So the contrast spread is typically like this in the lateral view. You get some amount of spread off to the side and to the front of the vertebral body. You want the contrast to hug the vertebral bodies, and in the AP view, you want it to just outside the lateral border of the vertebral bodies. Too lateral, you're in the muscle. There is also a risk of inadvertent pneumothorax and chylothorax because you're doing it very close to major structures. Vascular injection, nerve damage, epidural as well as subarachnoid injections have all been reported because you're halfway between the foramen as well as the retroperitoneum. Whenever you do this procedure, diagnostic block is done with about 5 to 10 cc of local anesthetic on each side. If you want to do a neurolysis, the same sitting, we usually give around 10 cc of absolute alcohol. When you do a sympatholysis of a major nerve within the thoracolumbar plexus, you are going to have orthostatic hypotension 40 to 50% of the time. Post-procedural referred pain usually radiates to the left shoulder, usually subsides in 24 to 48 hours. Like I said, retroperitoneal hematoma, bowel injury, renal injury, pneumothorax, as well as injury of any kind of neurolytic agent into the artery of Adam-Kivitz all lead to really bad complications. When it comes to literature, this is a recent article from 2021. As opposed to maybe celiac plexus blockade, splanchnic plexus block has pretty good outcomes as far as unresectable pancreatic cancer is considered. Now, there is a problem where there is a need for this kind of intervention in our practice. Patients in developed countries, patients with access to insurance usually will get intrathecal morphine pumps. Most patients can't afford 10 to 12 lakhs once they are diagnosed with terminal cancer. So this gives them pretty good quality of life for anywhere between 3 to 8 months depending on disease progression. As an extension of the same thing, the superior hypogastric plexus is situated in the retroperitoneal space. It extends from the anterior portion of the L4 and L5 vertebral bodies to the upper border of the S1 vertebral body. Now, the lumbar sympathetic chain supplies the afferent and postganglionic efferent fibers, whereas S2 to S4 will supply the parasympathetic fibers. So this travels inferiorly as the inferior hypogastric plexus, and eventually it will form the ganglion impar. So like we said, abdominal pain, which is secondary to malignancy, this is indicated for pelvic pain that is secondary to malignancy. Endometriosis, causalgia, reflex sympathetic dystrophy. This is a lot that we see, proctalgia fugax, as well as radiation colitis or radiation enteritis. This block tends to do quite well in those patients. Again, patient is positioned prone. Now this is an interesting approach, and this is what we usually do, as opposed to, you can again bend the needle around the vertebral body to access it, or an easier option is to go transdiscally. So what we do is we square off the L4 and L5 vertebral bodies, and we go through the L4, L5 disc. So you puncture the annulus posteriorly, You inject contrast, you do a discogram, you know you're inside the disc. Once you engage with the anterior end of the annulus, you take a glass syringe or a loss of resistance syringe, and it is done in the same manner as an epidural. You keep injecting air until you feel loss of resistance. That is when you are just anterior to the annulus. So after careful aspiration, this is not really very clearly visible, but a contrast spread is seen anterior to the vertebral bodies. It usually flows from L5 to S1, and on the AP view it should be dead midline if you're doing it transdiscally. So again, after proper needle placement, 5 to 7 ml, around 10 ml of preservative free local with steroid is injected. Again, usually leads to about 3 to 6 months of good pain relief. Alcohol neurolysis is usually not a very viable option as far as this plexus is concerned, because of the risk of intravascular injection, hematoma, subarachnoid injection. The major concern here is the proximity to the ureters and the bifurcation of the iliac vasculature. So when we do this procedure, we have to do a contrast, you have to do a continuous fluoro, and you have to be very sure of where you are so that you avoid hitting the ureters, so that you avoid hitting the iliac vessels. Just as an aside, this is again something that we do. Chronic abdominal pain, functional abdominal pain with no good cause, with no good treatment, refractory to all other mechanisms of intervention. There is a lot of literature to suggest that spinal cord stimulation is of benefit in this patient population. So you have a high dorsal stimulation pattern, and again, we're talking about the thoracolumbar sympathetic pathways. These are what are modulated by this stimulation pattern. And again, like we talked about splanchnic nerve neurolysis, splanchnic nerve radiofrequency ablation is also viable. Just the difference is you do D10, D10, D11, D12, 3 stacked radiofrequency needles on either side. And this also leads to good outcomes in patients with chronic pancreatitis where you don't want to do a neurolytic procedure. Thank you.
Thank you, Siddharth, for the wonderful presentation. We will move on to the last presentation in this session by Dr. Mahendra Singh Chauhan, headache and disc pain understood through pain matrix.
Good evening. I hope most of you are still awake. So I'm covering 2 topics, the interventional headache management and peripheral nerve blocks. Just to give you a follow-up, the patient that we did occipital nerve block has gone down from VAS of 7 to 2. The husband has just called me, and both of the pain are now almost gone. So headache has been a long-term problem for me because my mother had suffered all her life because of headache, and at least twice a week she would be in bed because of that. And then my wife, ever since I met her in 1992 till recent past, had constant headaches. So when you see headaches and you wonder what's happening, the last account that I knew of the several books and several journals, I knew that the pain comes from intravascular, the intracranial part. And then recently last year, what happened that I saw a case of auriculotemporal neuralgia, and then the focus went out extracranial. So now this became a very interesting journey, and we started doing more and more of these headache blocks, and I'm presenting my experience of last 1 year of 93 cases. So I believe now that we should focus much more extracranially than intracranially.
One of the first conclusion which proves that it is extracranial was done by Professor Guyron when they did an electron microscope and proteomic comparison of trigeminal branches of these nerves, and they showed that there is dysregulation of myelination process in patients with migraine headaches compared with controls. So this was the first evidence. Another thing that I wanted to draw your attention to is a beautiful paper written by Ronald Melzack, and this was in 1990, Pain and the Neurometrics of Brain. And this is something which shows you the mechanism of chronic pain, which has got no survival advantage. Of course, this topic is so big that it requires a separate presentation, so I'll just touch from outside. It just says that the patient, every person has got 4 components. The one is a body self-neurometrics, which is a 3-dimensional perception of pain. And then there is cyclical processing and synthesis in which the neurosignature is produced. The sentinel neuron hub, which perceives or which converts the flow of neurosignatures into the flow of awareness, and then activation of an action of neurometrics to provide the pattern of movement to bring about the desired goals, which means that patient with the chronic pain can have a particular gesture or a particular body posture. So this is a paper you must read before you start treating the chronic pain syndromes. So in short, it says that there is no pain cortex, so there is no specific target which you can manipulate. So we expect the sensory, just like we expect sensory and motor cortex where we do surgeries or lesioning. So with this, I would come back to the headache. So Guyron was one of the major person who did a lot of migraine surgeries, and he classified things into from site 1 to site 6. Site 1 is supraorbital supratrochlear nerves in the frontal region. Site 2 is temporal zone, which is zygomatic branch of the temporal. The rhinogenic trigger zone is site 3. The lesser occipital nerve is site 4. Site 5 is auriculotemporal nerve, and site 6 is greater occipital nerve. Now I would like to give attention, and most of you should remember them, that there are these 3 points on the temporal side, then few points here on the forehead, and then these are the secondary points, these are the trigger points, and posteriorly 1, 2, 3 and 4 points on each side, which can show you that the pain is coming from here. Any headache patient comes to you, if you just press these points, you will come to know that the trigger is coming from somewhere these points. In chronic patients, you can have all of these points activated, so we have to wait till we reduce the mutual induction of these nerves because of chronic pain. I would also like to draw your attention to this dissection, where you can see that there is a huge anastomosis happening in all of these branches from front to side to back, and then because of these, the pain in chronic migraines or chronic pain for the headache, it means that it is spreading from everywhere to everywhere. From it may start from the back, it can go to front, and I'll show you that these patients who I have seen, I have a patient who had continuous headache for 24 years, entirely devastated life, sold her house, husband left her, job was left, became very poor, traveled 3 countries, and still she had headache. I'll show you that case later. So anterior to auricle, there are supratrochlear and supraorbital nerves, then auriculotemporal, which is V3 on the side, and the zygomatic temporal nerve, which is V2. Posterior to auricle is lesser occipital, C2 and C3, greater occipital C2, and third occipital, which is C3. So posteriorly also, lesser occipital nerve and anastomosis with great auricular nerve, which is the cervical plexus, and with occipital branch of posterior auricular nerve, which is internal branch of facial nerve. At vertex, we have accumulation of all these nerves, and then so vertex, sometimes patient will come to you with only vertex pain or vertical pain. In a nutshell, there is a rich anastomosis across the scalp within the branches of trigeminal, facial sensory, and cervical plexus. Now, these are the triggers which are in the temporal region. Particularly, if you see these zygomatic temporal nerves, so if a patient comes and says that my trigger or my pain starts from temporal region, then you have to ask him whether the pain is outside the hairline or inside the hairline. So this, if it is outside, then it is a zygomatic branch of the temporal, or if it is behind the hairline, then it should be auriculotemporal nerve.
And it all started with a guy who came to me who had traveled 3 countries to get his pain treated, where he had pain only related to this region, which was auriculotemporal nerve. So he just jokingly told me that, can you cut this nerve which is here, whatever it is? And I said that, okay, I can cut it, but I don't know what will be the result. But then I pondered upon few papers which were describing auriculotemporal neuralgias. So now, instead of going into the types of migraine and cluster headaches, I would say that most of these are just neuralgias. And the more literature you would find, you would realize that these are exactly like trigeminal neuralgias, where either a tissue band or a blood vessel is overriding a vessel which is causing pain, and that's why we also get throbbing pain. So if you start thinking extracranial for headache, you would find so many answers, and these are so easy to treat. This particular point is called as a vulnerable point for zygomatic temporal nerve, and most of the pain it comes from here, even because if some patient has got too much tense, the muscle hypertrophy happens because they are clenching their jaw. So these 2 muscles, they can actually have pain because of very tense musculature which becomes hypertrophic with time. Now another thing which you should know, that the descending nucleus of the trigeminal nerve, it goes down, and this is the one which is particularly carrying this pain sensation from the face and then from the throat, which interchanges information with the C1, C2 and C3, which is supplying the posterior. So if you've got patients who have so much of pain either coming from the front or in the facial region, which is then referring to the back, or they can have a back pain, occipital pain, which is coming to the face. Like today's patient, she was complaining of pain of the occipital region, which is going typically up to the vertex, and then she was also having referred pain in the eye and in the ear. So now, how to tackle the individual zones? First of all, we'll see the orbital frontal zone, where we usually get a supraorbital supratrochlear nerves. It is very easy to palpate. All of us know it. Most of the neurosurgeons know right from their ICU or their Glasgow Coma scale examination. So we have always elicited pain in a comatose patient. You can have several types of bands over here. This blue is a fibrous band. So with this fibrous band actually converts this partial fossa into complete foramen, and it can be of various types, type 1, type 2, type 3, although it doesn't matter when you're doing a surgery or first you're doing a block. So it can be a simple band, it can be a band with a division, it can be a band called as inversity, it can be a band with a calcification nodule, or it can be a band with a partial bony canal, so that there are 2 foramen, one is supraorbital and one is supratrochlear foramen, or there can be no foramen. But when you are treating them, it's more important is whether they are tender or not, whether they are a trigger point or not. Another thing which also can cause pain is the glabular muscles which are here, which can also, the nerves are supposed to go from behind the belly of corrugator supercilii muscle or these glabular muscles. But another trigger point can be here, and there are now endoscopic subgaleal surgeries happening. Plastic surgeons are doing for a long time. I wonder why neurosurgeons are not doing them. But I intend to do them, and we are actually looking for cases. But right now, my patients are so happy with the blocks. So this is where we can do the blocks. Although from the midline you go up to 2 to 2.5 centimeters, and you can find these trigger points. But I always rely on trigger points. You push them wherever there is sharpest pain. You mark them with a marker pen, and then you can block it. So this is the orbital frontal subgaleal surgeries which can be done. Though we're expecting maybe next year, if I present something like this, we have some experience of doing these endoscopic surgeries. But for now, we have patients who are extremely satisfied with the blocks. So temporal region, this is very simple, 3 points, and then this is the zygomatic branch where you can push it, and then so there are usually 3 points. You go behind the line, you can go to the auriculotemporal nerve, you can go to the zygomatic temporal nerve just behind the orbital margin. So this is the surgery that I did for first as a auriculotemporal neuralgia, where we found that there was a blood vessel which was tortuous superficial the temporalis artery, which was over the nerve. So I did 2 surgeries. I cut the zygomatic temporal nerve, but auriculotemporal nerve we just decompressed vascularly, and patient got a complete relief. In occipital region again, usually these nerves, they have an interaction like this one. You can see either it can be perforated, it can be looped around, or it can be pressed by. And then if you press these points which are there, then you would find most of the pain is coming from here, and then you can start doing the injections. So these are the cadaveric studies where the history of the patients who had headaches, and they were found to have the bands like these, and then you can also see that the occipital nerve is perforated by an artery, an occipital artery. And these are the live surgeries done in some patients. Now another question is Botox versus local anesthetic, and I would say that Botox is not required, although they are very frequently described in the books. But when the trigger is a nerve which is in turn causing a muscle contraction, why don't we relax the nerve? Why don't we tone down the nerve so that the muscle gets toned down automatically? That's how I do a lot of selective dorsal rhizotomy procedures. There's no point in cutting a tight muscle when you can cut a nerve and reduce the neural output. So similarly that. So I don't know why Botox is given. I'm not giving. It's very costly compared to just local anesthesia, and I'm getting pain relief for up to 6 to 8 months, in some cases even up to 1 year. So these are the certain landmarks which I just want to give a reference for occipital nerve. Then we'll go for some cases. If you want to know, can we get an audio output? चल नहीं रहा Okay, maybe the video is not, but you can see this patient is weeping, and she kept coming to me. She needed 3 sittings over 6 months. She was pregnant, so we couldn't give her medications anyways. But then after 3rd sitting, she has got more than 90% relief. This patient, 4 years of persistent headache, almost daily, completely satisfied. Now this patient is the one I was talking about. She was working in Kuwait, and then because of too much absenteeism, she was removed from the job. And then her husband left her, then she had to sell her property. She went to USA, UK, nothing happened. For the first time we gave her a block, and then now with the 2 setting of injections over 6 months, she has got more than 80% pain relief. Another girl, her head was thrown against the wall in a madrasa. She had a headache every day for last 19 years, and then I gave her injection, and then you can see that she's very happy after that. So in a nutshell, just remember these points and start hitting them. And very soon you will become an expert doing all of those things. And so 93 cases, 76 females, 17 males, average age was 38, youngest was 14 years, average duration of relief was 4 months, average benefit of VAS was 6 points. And return within 7 days was 6 cases, low grade infection in 1 case, no hematoma, no failure. One more thing which I want to show here, I needed time for that. I already told that something which was not covered in disc pain management or spinal pain management was toxic annular tears. Am I allowed to speak?
I think we can conclude as it is.
2 minutes. Yeah. Because without this, if you don't understand this, then I think we are not doing justice to spinal pain management. Anyone sees anything in this MRI? This one, yeah? How does it look like when we do endoscopy? It looks like this. This is called as a toxic annular tear with so much of neurogenesis over here, a lot of toxic fluid going from here outside, irritating the dura, something called as chemical neuritis. And then outside there's at this area, there's a dorsal root ganglion. Severe pain happens to the patient. Yeah, and if you see this patient is not able to raise his head, this is one of the tests, McKenzie's test. Yeah, severe pain. I just did a disc block here. We gave steroids and local anesthesia here, and patient is walking for the last 5 months. This female, again, a very tiny hyperintensity area here. Okay, not able to walk, not able to do any work. Then we found that there are 3 toxic annular tears, and then we did the steroid injections here, 3, and she started working right from the next day. Severe pain she had. Immediately you can see she is able to hyperextend her spine. So this is very important. If you can find these hyper dense zones, then like this one, you can see there is a hypertrophic, almost squarish dorsal root ganglion. DRG block and disc block have not been discussed here. If you had a case, I could have shown you how to block them. One more case, I would say we put, there was a patient who had an intracanalicular screw placement, very beautifully done. Then I removed it after 11 years. And then we put a cage here, but somehow after that she had severe pain. So I did a radiculogram that you can see here. She had severe pain. If I show you this video, she was weeping overnight. I don't know, I'm seen there, so, but she used to weep a lot. And then you can see we did a block of dorsal root ganglion. And then even in the operation theater, the very next day she started dancing. So that's the magic of disc block and a dorsal root ganglion block. Then again, I was telling about the peripheral blocks and pseudo-unipolar, the role of pseudo-unipolar neurons, because dorsal root ganglion has one. That means both the axons, they work as the same thing. So whatever you do peripherally starts happening centrally. So if you have a patients like any patient with leg pain or disc pain, just press here, clinically here, common peroneal nerve branch or sural nerve or the posterior tibial nerve. You would have a patient will complain pain even up to neck. And if you block here with just diluted xylocaine, then patient would have magical relief. Right? This patient had a severe cervical pain which was going all the way down. I gave him injection here, and after that now it's more than 7 months patient has got no pain at all. Again, if you see this lady walking like this for 2 years, I gave her a peripheral block and she started smiling. Third patient, not working, but this patient was lying down in front of my clinic when the clinic was closed. Pain going from the leg all the way up to the cervical spine. And we gave her local blocks and she is still 4 or 5 months, she is very happy. So these are very important ones. You can sort them out in your own OPD. You don't need to do anything else. And many patients will thank you for even up to 6 months. Thank you so much.
So what is the reason for having a pain right from top? That is from the head to the foot, they have pain and you block them.
Well,
what is the reason of pathophysiology?
So one thing is that there is sensitization of the sympathetic system because the involvement of the dorsal root ganglion. And we have variable like today I elicited the patient had pain, and when I pushed her here, the pain was going all the way up to elbow. It all depends upon what is the duration. So that should be one of the reason why it is there.
Called psychogenic pain. So that is the reason why pain was treated.
Sorry?
DRG block and selected foot block are the same.
A DRG block is particularly you should do when you are seeing a toxic annular fissure right over the DRG from the disc. If it is directly releasing the chemicals over there, area is slightly different. I wish I had time in OT today, I would have explained that with the same transforaminal, you can go to the disc, you can go to the root, and you can go to the DRG. Much better results than epidural, I can tell you that. Sorry? When they come to me, they already medically managed so many times. What medical management we could do? Just painkillers. Remember, when there is a toxic annular tear, which is not discussed today, the neurogenesis keeps on happening. Right? I have another presentation which says endoscopic visualization of pain generators in spine. The nerve generation will keep on happening and the nerve endings will get thicker and thicker, meaning same tear is going to give you more and more pain with time. So there is no logic and reason why you should be conservative with them. And after all, they are just injections. What? I'm not getting you. Can someone give a mic? So there are certain diagnostic processes, like if you press, I told you the peripheral points, if you can press and patient says that there is severe pain, or if you keep the patient prone, and then, so these are called as Goretz sign and Mackenzie sign. If Mackenzie sign means when you allow the patient, you tell him to hyperextend spine while in a prone position with hands behind, and the pain goes all the way to the leg, then or the pain localizes to the spine. That's the time when you have to do these injections.
Because we see such scans almost many times in our routine practice. We see such MRIs in our routine practice many times.
I have one case which I could not discuss here, that she had a problem, and again when I was in a big hospital here where they won an award for best spine department, there was this high intensity zone in the disc, and they do a screw fixation on that patient. Patient doesn't get a pain relief. Then that patient goes to, from Kenya, they came to India, they got a surgery done in Ahmedabad, they said 2 more screws are required. So from 2 levels, they go to 3 levels, patient has got the same pain. I have got a video of her, we don't have time. And I just gave her a peripheral block, and she said in 4 years for the first time I have got a pain relief. So many times we don't understand at what we are doing by neglecting such cases. Yes. Yeah, so if patient has this problem, that means already the dorsal root ganglion is sensitized. And if you do that, first thing, that patient would know that this guy can treat my pain. Just like with headache. So many patients come to me who have traveled so-called 2-3 countries. And when I'm saying that is it the pain? And they say exactly this is my pain. I said, did anyone elicit this pain? Or did anyone recreate your headache? They say no one did. That means that person knows that where the pain is coming from, that means I can treat. So you get a patient's trust and a short-term pain relief. If you are to do a peripheral this thing to exploit the state of being pseudo-unipolar neuron, you just do diluted xylocaine, and there are several papers on it. You can read them. Yeah. That's a magic. I have a patient's video, she's saying it's a magical injection. So
your talk on the extracranial management of headache is excellent. So I really hope that you publish your data, it will help a lot of pain management.
Definitely, we are very closely observing all these patients, it's very interesting. So my teacher, one of my teacher, he told me only this point, but I press everywhere. Okay, because it all depends upon which dermatome it is coming from, C4, C5, C6, we don't know. I have done that also, because I could see that there is a problem in the disc, and I did that. Even then patient got a relief, but more relief if patient has got this pain. But here only use Xylocard. Patient is going to hypertension.
Sir,
Here only use
because there will be many questions, I'm sure. Yeah. Sure, we'll have
your clinical practice, you don't even know that.
Thank you very much. For the wonderful talk, and I will talk about this. And that brings us to the end of the session. Sharma.
Thank you all the speakers for thank you chairpersons for conducting a very successful section. Now I request the chairpersons to kindly felicitate the speakers. May I respect Dr. KVL Narsingh Rao, Dr. Navdeep Sokal to kindly felicitate the speakers. Dr. Ajay Chaudhary, please come on the stage, please. Dr. Mahendra Singh. आपका भी दे मतलब Dr. Banerjee? Dr. Banerjee? Okay. May I respect Dr. Ajay Chaudhary to kindly felicitate our chairperson, Dr. KVL Narsingh Rao. May I request Dr. Navdeep Sokal to kindly felicitate our chairperson, Dr. Ajay Chaudhary. With this, we conclude this new stimulation session. Now, coming on to last session, debate session. In this, we will be dealing about the various modalities of neuropathic pain. We have discussed all blocks and all interventions. Now, this session will be focusing only on the pharmacological aspect of management of neuropathic pain. Can you put the slides, please? वो स्लाइड्स लोड कर दो. ये वाला 01 ये ऊपर वाला ये वाला. This is a debate session in which we will be debating about the use of pregabalin versus gabapentin in the management of neuropathic pain. Before we start with the debate, we will first discuss about what is neuropathic pain. Neuropathic pain was first described in 1994 and it was defined by IASP as pain initiated or caused by primary lesion or dysfunction in the nervous system. However, the definition was felt appropriate and it was revised in 2011 in which the word somatosensory was added to this definition, and since then it is being defined as pain caused by a lesion or disease of somatosensory nervous system because of the presence of sensory symptoms in these patients. Pain associated with the it can be because of the because of the disease or injury in either the peripheral or central nervous system. And many of the cases there is usually an absence of any stimulus. Another thing to note is that not all patients with neuropathic pain experience, not all patients with nerve damage experience neuropathic pain. These are the various terms we should know. In view of short time, I would not like to go into details of these terms. What is the difference between nociceptive pain and neuropathic pain? Nociceptive pain, usually there is a stimulus, noxious stimulus, and once the noxious stimulus is removed, the pain subsides. What are the various causes? Neuropathic pain can be because of traumatic origin, inflammatory, metabolic, autoimmune, chemotherapy induced, or the hereditary ones, or as neurologists we usually see it in cases of stroke or trauma, or in trigeminal neuralgia or dorsopharyngeal neuralgia. How to make a diagnosis? Most of the cases this onset of pain is spontaneous without any stimulus, and distribution of neuropathic pain matches the degree of neural lesion. These patients may present either with the positive symptoms or negative symptoms, and as a clinician we need to demonstrate what the nerve damage or dysfunction in all patients, all these patients experiencing pain, to make the diagnosis. Diagnosis of neuropathic pain rests heavily on the demonstration of sensory abnormalities, and we need to majority of cases we can treat only the symptom rather than the cause. This is a crux of this. This is the slide which is demonstrating the whole of this conference, and in this we will be dealing the medical management. And this special interest group on neuropathic pain divided the various medical therapies available for management of neuropathic pain into first line, second line, and third line. These are the various options available with us. NICE guideline also recommended amitriptyline, duloxetine, gabapentin, or pregabalin as the initial treatment of neuropathic pain. The exception being trigeminal neuralgia, in which the first treatment of choice is carbamazepine and oxcarbazepine. These gabapentinoids are third line drugs for the management of this pain. Now I call upon Dr. Abhishek, who will be speaking on gabapentin. After that I will call, because gabapentin came into the market first, pregabalin came later. That's why we will be discussing gabapentin first. Dr. Abhishek, please.
Good evening, respected delegates. Thanks for the opportunity to speak here. I'll be talking about the gabapentin in here. Management of neuropathic pain is multidimensional. It includes pharmacotherapy with TCAs, SNRIs, and calcium channel ligands, etc. Then non-pharmacotherapy and psychobehavioral. Now I'll be talking about gabapentin. It is an amino acid analog of GABA that is effective against partial seizures. It was originally conceived as a spasmolytic agent, but was later found to be more effective as an anti-seizure medication. It is primarily used in seizure disorders, management of neuropathic pain, and vasomotor symptoms. Now, talking about the potential mechanisms of gabapentin actions, the mechanism lying behind the pain relief is largely elusive. However, its action on the alpha to delta subunit of presynaptic voltage gated calcium channels causing inhibition of calcium currents and modulation of neurotransmitter release is particularly thought as a mechanism causing pain relief. It also alters GABA metabolism, its non-synaptic release or its reuptake by GABA transmitters. This effect is primarily useful in gabapentin as an anti-seizure medication. Now, the preclinical data which we have available from the laboratory studies are gabapentin does not affect nociceptive threshold. However, it is effective in reducing both allodynia and hyperalgesia in animal models. It may have a selective effect on the nociceptive process involving central sensitization. However, there is no data to support that the effect of gabapentin on spontaneous pain in animal models. Now, is gabapentin an all-purpose painkiller? The answer is unlikely. It is not like a conventional analgesic like opioids that produce analgesia by means of elevating nociceptive threshold. There is no evidence that shows gabapentin to be effective in reducing nociceptive pain. With regard to neuropathic pain, there are few studies which show a small but statistically significant reduction of global pain scores in patients with diabetic neuropathy and post-herpetic neuralgia. Non-controlled open-label clinical studies support a role of gabapentin in reducing spontaneous pain and allodynia to both thermal and mechanical stimuli, regardless of the etiology. It appears particularly helpful in reducing paroxysmal pain with lancinating and burning quality. Now, the side effect profile. The major side effects associated with gabapentin are dizziness, somnolence, confusion, and ataxia. Dizziness and somnolence, these are usually experienced by the patient during the initiation phase of the therapy. Later, they subside. There are some sporadic cases of gabapentin-induced polyneuropathy and psychomotor agitation. There was one study directly comparing the side effect profiles of gabapentin and amitriptyline, and this study failed to prove a better side effect profile for gabapentin over amitriptyline. Now, is gabapentin better than other adjuncts when pain medications? There is only one randomized double-blinded crossover study that compared the efficacy of gabapentin and amitriptyline on diabetic neuropathic pain. There was moderate to great pain relief in 52% of the patients. Since the study was a relatively small-scale clinical trial, it failed to prove an advantageous effect of gabapentin over amitriptyline. Also, the side effect profiles of both the drugs were not much clinically different. At present, there is more data is needed to support the notion that gabapentin is the first line treatment for neuropathic pain with a better efficacy, fewer side effects, and a favorable cost to efficiency ratio. This table was taken from the Cochrane study done in 2017 on around this study concluded around 37 to 40 studies, and the study found that there was it on using gabapentin at a dose of more than or equal to 1800 mg per day. Compared with placebo, the gabapentin fared better in reducing post-herpetic neuralgic pain. This table was taken from the same study for peripheral diabetic neuropathy. When gabapentin was given at a dose of more than or equal to 1800 per day, gabapentin fared better than placebo in the trial. Again, study from the a table from the same study. This table shows us the adverse events and withdrawals associated with gabapentin use at a dose of 1800 to 3600 mg per day. When compared with placebo, gabapentin had more side effects. Now, the same study, a different table. This table shows that when gabapentin was used alone or in combination with morphine, it fared better than placebo in controlling all kinds of mixed neuropathic pain. Now, this table is taken from study which was published in JAMA in 2019. This was a randomized double-blinded trial of gabapentinoid versus placebo for off-label treatment of pain. The study shows that the gabapentin is particularly useful in treating back pain or radicular back pain, diabetic neuropathic pain, but it is not useful in treatment of central neuropathic pain, traumatic nerve injury pain, or acute zoster pain. So in conclusion, gabapentin is a good drug and can be used to treat neuropathic pain. Thank you.
Now coming to pregabalin, pregabalin was synthesized in USA in 1990, and both of these drugs are gabapentinoids. Mechanism of action and the site of action is nearly the same. Pregabalin doesn't bind to both of them don't bind to GABA BZD receptors, or none of them form GABA. And this is the chemical diagram of GABA, pregabalin, gabapentin. We can see that basic molecule is nearly the same. Pregabalin and gabapentin are extensions of GABA. This has already been discussed, and the point I want to highlight in this slide is pregabalin is more potent than gabapentin, and that's why it's prescribed in lower doses. Coming to pharmacokinetics of pregabalin, it's actively absorbed from GIT. Food may delay its absorption. Bioavailability is nearly 90%, and protein binding is 0%. T-half is around 6 to 7 hours in adults, and is less in children. Time to peak is around 3.5 hours when you are fasting, and after food it's 3 hours. It is transported actively across blood-brain barrier, and it undergoes negligible metabolism in the body and eliminated unchanged in urine. Dosing, it was first approved for clinical use by FDA and European Union in 2004, and generally it is started at low doses, and gradually we have to increase. Guidelines says 25 milligram per week we have to increase, and can be increased maximum up to 300 to 600 milligram per day. In various countries have different indications for using this drug for the patients, and this is according to Australia. This can be used only for refractory neuropathic pain not controllable by other treatment, and in epilepsy. However, in India, due to lack of any legislation, there are many off-label uses for both of these drugs. Response of this drug is not immediate like paracetamol. Like you give a medicine and within half an hour you will get a relief. It's not like that. Usually the response takes time, and the response patients gradually start getting the response within the first week after starting therapy. And how we can declare there is no response, and when we can declare it's usually at least 8 weeks of adequate dosing of therapy before declaring no response if response to relief of pain is less than 30%. These are the definitions which are used in literature to define the benefit of the drug. Moderate benefit is labeled when at least 30% pain is relieved, and substantial benefit of the drug is labeled when at least 50% pain is relieved. Coming to adverse reactions, incidence is very, very low, around 3%, and the common adverse effects are respiratory depression, especially when it is taken with other CNS depressing medicines, and suicidal suicidal thoughts or behaviors is also often found adverse event with this drug. Other common drug adverse reactions seen with this drug is dizziness, drowsiness, blurred vision, fatigue, weight gain, dry mouth, headache, impaired balance, and peripheral edema. And this I already discussed. Interactions coming to the important adverse effects is dose. It's a dose dependent, and fatal respiratory depression can be seen when it's administered concomitantly with other CNS depressing medicines. Hypersensitivity reactions as seen with any other drug is possible with this drug, and visual disturbances may also be seen. Pregabalin adverse effect is very, very less, or you can say nearly same as placebo at doses of 150 milligram per day. Higher doses are likely to produce higher adverse events. And this we can see nearly the same effect, same adverse event of 150 milligram per day with placebo. Coming to the overdose symptoms are usually CNS related, like dizziness, agitation, delirium, or headache. And some of these patients might have ECG abnormalities or GI upset or kidney failure. Management is usually supportive, and death is unlikely because of overdose. Are there any contraindications for using these drugs? Hypersensitivity, which is there with any drug. In cases with renal impairment like CRF, we need to do some dose adjustment. And patients with substance abuse, we need to be cautious while administering such drugs. How to, when the patient has got relief for the from the disease, can we withdraw it? Yes, we can withdraw it, but we should not never stop it suddenly. It should be gradually withdrawn. Drug interactions, especially with alcohol, people who take alcohol, especially in the evening, should be and taking the night dose of this drug should be cautious about the CNS depressant effect of the dual combination. Thiazolidinones may enhance the fluid retaining effect of this pregabalin and should be given carefully. Is it safe in elderly? Yes, it is safe in elderly, though symptoms like dizziness, somnolence, peripheral edema, they are slightly more commonly seen in elderly. From this discussion of we could make out there are a lot of similarities between the gabapentin, site of action, mode of action. Many things are nearly the same. But what are the differences? Differences are there in the dosing, are there in the potency. Gabapentin being slightly less potent than pregabalin, that's why gabapentin dosage is slightly more, 300, 400. Pregabalin is 75 or 150. Addiction potential of pregabalin is slightly higher because it gets absorbed quickly and gives quicker onset of action. However, FDA indications are of these two drugs are quite different, and this is again the same summary. And to this, I will like to conclude that both this pregabalin and gabapentin are quite effective in relieving neuropathic pain in various conditions. Now I request Professor Deepak Agarwal to kindly summarize and conclude about this debate session.
Good evening. I have the honor of taking the last talk of the day, and I'll keep it quick. I'm not going to summarize it because as a debate, I'm supposed to say what is against pregabalin and gabapentin. And we know, as pain specialists, as neurosurgeons, we have been using pregabalin right, left, and center. Every patient, we don't even write crocin or paracetamol nowadays, we first write pregabalin. And most of the time we find out the patient's already receiving it from the previous doctor. So we increase the dose. Because there is no other drug. Anything beyond pregabalin becomes actually an opioid like a morphine or a tramadol. There is nothing between them. And unfortunately, we are not very well aware of the side effects. We have been so much industry driven that we have in a way turned a blind eye to potentially fatal complications which these drugs can have. And it is not a small, I would say, kaleidoscope. It is a full array of complications which are not existing. Rajiv said there is a very low complication rate. Actually, complication rate is extremely high. Extremely high. Dizziness, almost every patient will have dizziness. We all know that. And one of the most common things, I think, which the books don't sell, we should start at a very low dose. In fact, in elderly patients which are 60 years above, you should start at 25 mg. And 25 mg pregabalin is available in the market. But we never prescribe it. It is not to be... In children, it is not indicated only because there are no studies, it is contraindicated in children. So why have they made 25 mg? It is for only this reason that you have to start at a very low dose and gradually, because elderly patients, sometimes they will go into a kind of stupor if you give this. Also, common complaint is it's like you are drunk, very high. And actually it makes you feel that. It's a dose dependent side effect. Normally what has been given in books is you can give easily up to 600 milligrams a day. That is the standard dose of pregabalin. We never give that high dose. We usually go up to 150, maximum 300 mg. But in books it's given, and people, once they get addicted to it, go up to 3000 milligrams per day. So 3000, 6000 they can take, because chances of dying is very low, as Dr. Rajiv rightly said. But the high, because patients get tolerant to the drug, so they keep taking higher and higher doses. and it gives you the same high as alcohol. Cardiac causes are very important, and especially for the large number of patients who have blood pressure, congestive heart failure, some other thing, we never take the history. Peripheral edema, which we see, we disregarded. Patients come with swollen, feet, which we can't understand. And PR interval, which is recorded, and I'll tell you why we should be doing all this. Psychiatric, obviously, as I said, psychiatric and neurological complication intermix. And when I say common, it is up to 10%. And very common means more than 10%. Immunologic complications, nobody talks about it, very common. 10% or more patients will have immunologic complication. Chance of infection increase. Any patient you're giving pregabalin, chances of getting any kind of infection will increase dramatically. In fact, if a patient is having some infection and give pregabalin, a more chance of going to sepsis or something like that. Urinary complications, common. Ocular complication, I think Rajiv also touched upon it, but you have to understand visual field defects, very common. 10% or more will have visual field changes. Nobody knows why, but they will have changes. Common is blurry vision, abnormal vision, we consider, we don't even think about it, but patients are, this is a common complication reported. Chest complications are also been reported to be common. We are giving it for pain, but again, this is a drug which can also cause pain. One of the most feared complications, dermatological complications, angioedema is reported swelling. As I said, they can have a very innocuous like swelling in the feet, but it can progress to angioedema, which can go into something akin to anaphylactic reactions, and there have been deaths. So it is not that it's not fatal. They have been, and if you are predisposed, God forbid, if you're predisposed, we never take the history. If you're predisposed to any kind of angioedema because of any other cause, this can prove the last straw in killing you off. That is why what has been actually suggested is you should have for every patient a standard ECG to make sure what is the PR interval. You should have an eye examination, because if the visual field changes, we can never document unless you have a baseline examination. You should have a platelet count, because bleeding, as a neurosurgeon, we all are so aware that bleeding problem should be there or not there. Aspirin somebody is taking, we stop all surgeries on that patient, but we hardly bother about pregabalin, and it has been known to cause platelet dysfunction, and it should not be given in those patients in which you're thinking of getting operated. Also, it increases serum creatinine kinase because of rhabdomyolysis, and we should be monitoring that, especially in those patients which are prone to it. In fact, the complications have been so much that FDA had issued an alert some time back, and that alert in India, it specifically sent an alert to the government that India is one of the countries which is freely giving this drug. Most of the countries have made it, as Dr. Rajiv said, a controlled substance, a Schedule 5 drug. It's almost at the level of morphine. So imagine any country, be it US, be it UK, be it Australia, it is considered same as morphine. You cannot take it out from anywhere. And only in India it is given like crocin or any other drug. And that is why the abuse has started. And in India, if the abuse starts, where it starts from? Punjab. So already papers are starting coming out from Punjab for pregabalin abuse. It is being sold. In fact, there was a crackdown. There was a newspaper report, there was a crackdown. They caught tons of pregabalin being supplied. Pharma companies are doing it. So it is now, it is legally available, almost like off the counter drug, and people are enjoying. It gives you the high. Why should they not take it? Taking 600 milligrams will make you like you're taking a peg of rum. Today all you will be having maybe. So quickly to conclude, see, I can tell you my experience, but doesn't want to stop it. I write, my staff and everybody says, what does Dr. Depot do? He only writes pregabalin. Because any patient with back pain, any patient, any kind, first drug you write is pregabalin. They don't understand at the back end, there is so much of things you're thinking when you're writing pregabalin, when you're stopping, how much you're writing, how much you should give. And I think this lot of quackery is also going on, because Everybody knows that pregabalin will make you feel high, will make you feel euphoric, will make you feel, will obviously affect the pain. So that sense of safety profile which we should be as neurosurgeons, pain specialists, we should be aware of. That is, if we are at 50%, other people beyond our community at 0%. So that is, we should be cognizant, and we should do responsibly our duties in terms of prescription. And bottom line is the minimum possible. That is true for every drug, more so for this drug, especially because the government controls are so lax in this country. It should be the minimum possible dose and for the minimum possible period. Thank you so much.
Any questions? If any of you, so that you can have the other drug. Thank you all. With this, we conclude today's session. And dinner, we are having dinner at Faculty Club. They're just next to Director's Bangla. It's walking distance, maybe around 100 meters from here. So all of you are invited for dinner. Dinner is already started. It's I think around 7 o'clock. 6:30. We are already ready with the dinner. To be from here, you can all directly go to the dinner venue also. See you all there. Thank you so much. Tomorrow we will start sharp at 8 a.m. Tomorrow session is a very important session, trigeminal neuralgia. I request all of you to be please on time so that we can start on time and conclude on time tomorrow. Thank you all. Thank you so much.
Sir, Rajesh sir.
है